Ивето, ще ми намериш ли един бадж, да се види, че съм част от Конгреса? Okay. The moment is here. Dear colleagues and friends, it's my huge honor and pleasure to tell you, welcome. Welcome again. I would say welcome back. Welcome home. This is like the home of endovascular therapy. This hotel, this room, and this conference. This is the home of endovascular therapy, not only for Bulgaria, but also for the regional level. And as usual, we are going to have participations and lecturers from more than 20 countries. So this is very, very important for the development of the mutual collaboration, interdisciplinary, international collaboration, and to put the interventions, the endovascular interventions way of treatment on a new level, different level. Definitely, we cannot do anything without the support of the institutions. It's our huge honor and pleasure to invite our Minister of Health, Professor Hinkov, to tell us several words from the part of the Ministry of Health. Please, Professor Hinkov.
Thank you, Professor Petrov. I got his official speech in Bulgarian, but I'll skip it because I see that I will leave this for you officially. Unofficially, I'll say that I'm one of the patients of Professor Petrov. I got this stand here, and I'm alive. It was 6 years ago, maybe, and at that time, I realized in what time we are living, because 20 years ago, maybe I would be in a chair, wheelchair or something like that. I'm okay now. And this is a huge step in medicine with these procedures you are doing. As a minister, I'm responsible to start a project of establishing a stroke centers in Bulgaria. And according to the financial framework, there will be 10 centers in different parts of the country, which of course needs training of people who will do these procedures in these stroke centers, because unfortunately in different parts of the country the level of professionalization and the level of expertise is not the same as in big cities like Sofia, Plovdiv, Varna, and so on. So I would be very, very happy to have these connections with you to start this project and to continue our mutual collaboration. Thank you for attention. I wish you health. I wish you success in this very important conference. Thank you.
Thank you, Professor Hinkov. Professor Velchev, my course co-director since more than 10 years ago.
Good morning, everyone. Just a few words how we'll proceed. This course will be happening in 2 days. We have 2 rooms going simultaneously because we want to distill a lot of I have the knowledge. So we are starting downstairs with the venous intervention, and you're starting here with the most exciting part, maybe the stroke. So I wish you actually to have fun, and I think we can take off.
Thank you, Vasco. Thank you, my friend, as always, for the support. In fact, I have to mention, I mentioned already about the collaboration and interdisciplinary collaboration. In fact, there are 6 specialties here, and that have some role about endovascular intervention. Thinking endovascular is important. So this is the way to move the medicine at all ahead, to be minimally invasive, to be up to date. So we are going to try during these 2 days, like Professor Velchev mentioned, 2 days head-to-toe endovascular intervention, starting with the stroke, probably one of the biggest killers nowadays all over the world. So this is one of the main accent of our program this year. But not only, also aortic interventions, live cases, live in a box cases, so more than 10 live cases head-to-toe intervention. And there is a space and there is a topic for everybody. So please visit all the interesting lectures that were possible with the support of the companies, the industry. It's very important, this support, so thank you. I will not make any list because somebody can be not very happy in case I miss him. So thank you, the industry, thank you all the international, our teachers, in fact, coming from abroad, and like Professor Grunwald, Professor Matthias, Professor Alvarez from my second, and Professor Lundero, my teacher in endovascular intervention. I have to mention, it's very important to mention that this meeting is the local chapter of International Society of Endovascular Specialists conference. And because of that, I will give the speech, the floor to Jacques Busquet, who is the founder. He gave the idea about building the International Society of Endovascular Therapy. Thank you, Jacques, for coming.
Thank you, Ivo. It's a great pleasure to be with you today. I'm not an ancestor, I'm just a pioneer. And with Ted Dietrich, with also some other people, we founded in 1992 in Bordeaux, my former place, the idea of a collaborative meeting of specialists, all specialists as you mentioned. And this ISEVS that you have on the logo is still very active. There is a journal of endovascular therapy with a good impact factor, and a community of friends with exchanges, especially for the younger generation. And I miss Dr. Reed, who is my good friend, your good friend, who operates here with you. And we are a team. This team is at your disposal to be stronger and to be just good in our specialty. Thank you very much.
Thank you once again, Jacques. I saw on the screen, and you probably saw on the screen, we have also congratulations by the National Health Fund. And it's very important. In fact, for our country, we have one and only National Health Fund that is giving support us, giving financement for the treatment of every single Bulgarian. So this is the Bulgarian way of having the security, social security and medical security for the population. So the collaboration and the support of the National Health Fund, this is in fact the address of the president of the National Health Fund, Mr. Mikhailov. Thank you for the participation also of the members of the National Health Fund in this very, very important conference, because without their support, no one treatment would be possible to be implemented. So, with no more, I will tell you good success, everybody, and have fun. This is very important. Jack mentioned already, it's a meeting of friends. All we are friends united by the idea of thinking endovascular. Thank you once again for coming, and good luck. And I'm giving the floor to the first topic today about stroke intervention. This is the most hot topic nowadays in the world. So, Iris, it's your turn now. Thank you.
Thank you so very much. It's been an absolute pleasure to be here today and to have this joint session from the World Federation for Interventional Stroke Treatment. And without further ado, I'm going to introduce the first speaker. Ivan Staikov, would you please come to the stage? Nikolai. Oh, Nikolai, you're doing. Okay, Nikolai. We would love to learn more about endovascular stroke treatment in Bulgaria. Thank you very much.
Hello, everyone. It is a great pleasure to me and for us as a neurologist to be here and to present to you our initial experience and as neurologists for endovascular treatment of acute ischemic stroke. Ischemic stroke is the second leading cause of death and the leading cause of disability among the 795,000 patients in the Framingham cohort. In patients with acute ischemic stroke, treatment may include restoration of blood flow. Intravenous thrombolysis is routinely used to achieve this goal with the time from onset of the symptoms to administration of IVT being up to 4.5 hours. In patients with National Institute of Health stroke scale below 6 points, intravenous thrombolysis with tissue plasminogen activator shows very good results. In patients with occlusion of middle cerebral artery, after IVT, recanalization occurs in 30% of all patients, and with thrombosis of the internal carotid artery in 10%. The key clinical outcome is functional independence after early recanalization of thrombosed vessels. According to multiple studies in patients with large vessel thrombosis and symptom onset within 4.5 hours, both intravenous thrombolysis and EVT should be performed. Intravenous thrombolysis was approved by the FDA for the treatment of acute ischemic stroke within 4.5 hours of symptom onset. More recently, ECOS-4 and EXTEND evaluate IVT TPA efficiency between 4.5 and 9-hour window in patients who were not endovascular thrombectomy eligible and had a perfusion to diffusion mismatch ratio above or equal to 1.2. Although ECOS-4 did not show any significant improvement in 90-day outcomes, EXTEND demonstrated better functional independence when adjusted for age and stroke severity. 5 randomized control trials showed the efficiency of EVT over standard medical management in patients with anterior circulation stroke with proximal large vessel occlusion. And meta-analysis of 5 major EVT trials found the effectiveness of EVT declined with each passing hour and concluded that treatment within the first 7 hours is likely to produce best results, and number needed to treat was 2.6. The clinical mismatch of wake-up and late presenting stroke was evaluated in 2 trials, DAWN and DIFFUSE-3, and they demonstrate that the effectiveness of EVT in the late time window up to 24 hours. Few trials have evaluated the role of combined IVT and EVT compared to EVT alone, and they noted that EVT alone was non-inferior and resulted in reduced reperfusion rates compared with combined therapy. Posterior circulation, large vessel occlusion stroke may account for 7 to 12% of all intracranial large vessel occlusions in acute ischemic stroke, and up to 80% of patients with basilar arterial occlusion presenting with moderate to severe deficit die or have severe disability despite the treatment. The most frequent causes of posterior circulation large vessel occlusion is atherosclerosis and cardioembolism. 4 trials was conducted to evaluate the role of EVT in posterior stroke circulation, but the biggest one was discontinued due to poor recruitment and high crossover rates between the treatment arms. The basic study did not demonstrate any significant additional benefit with EVT. Stent retrievers and clot aspirations are the 2 most used EVT techniques with continued improvement, leading to reperfusion rates exceeding 90% in LVO thrombectomy. Stent retrievers are inserted within the thrombus and re-establish blood flow once expanded while simultaneously binding the thrombus, and subsequent stent retrieval extract the clot. Aspiration devices, on the other hand, connect to an external aspiration pump that create a negative suction to aspirate the clot. The ASTER trial failed to show superiority of first-line contact aspiration compared with the first-line stent retriever in acute ischemic stroke. The COMPASS trial, on the other hand, compared the 2 techniques and showed that the contact aspiration was non-inferior to stent retrievers. Currently, the choice of technique is primarily based on user preference and expertise. The current AHA-ASA guidelines recommend that all patients suspected of having acute ischemic stroke undergo brain imaging to exclude hemorrhage. For patients with acute ischemic stroke between 6 and 24 hours, guidelines recommend performing of computed tomography angiography or MRI with DWI with or without MR perfusion to selecting EVT candidates in patients below 6 hours from stroke onset. Non-contrast CT scan is enough, but the guidelines also recommend computed tomography angiography or MRI angiography to be performed to evaluate extra and intracranial vessels, which is reasonable for treatment planning. Now, what we do in Bulgaria. Endovascular treatment of stroke was reimbursed by National Health Insurance Fund in the last few years. There are 4 hospitals in Bulgaria which performed 52 endovascular treatment of stroke in 2022, according to National Health Insurance Fund. And I listed the hospital below: University Hospital St. Marina Varna, University Hospital St. Anna Sofia, Tukuda Hospital Sofia, and University Hospital Pirogov Sofia. But all EVT in patients with acute stroke is below 1% for 2022, for the last year. According to Bulgarian guideline for stroke, suitable for mechanical thrombectomy with stent retrievers are patients up to 7 hours from stroke onset, meeting the following criteria: occlusion of the ICA or the proximal part of MCA, age above 18 or equal to 18 years, nicks and aspects above or equal to 6, and MRS prior to stroke below or equal to 1. Although the benefit is not certain, the conductive endovascular therapy is reasonable in patients with MRS before stroke over 1, aspects below 6, and NHSS below 6, and occlusion of the internal carotid artery or the proximal part of middle cerebral artery. And it also could be reasonable for patients with distal thrombosis of M2 or M3 part of MCA, or vertebral posterior cerebral artery or the basilar artery. It should be performed by trained and experienced neurointerventionalists, physicians with one of the following specialties: neurology, neurosurgery, and interventional radiology, who meet national and international requirements. The decision should be made by a multidisciplinary team, include a stroke specialist and neurointerventionalist, and performed in medical centers with experience providing comprehensive stroke care. Data should be entered in a register with follow-up up to 1 year after the procedure. The administered anesthesia depends on the patient's risk factor, but conscious sedation should be preferred over the general anesthesia. Our center in Tokuda Hospital started since 2019. We have 3 neurologists in training as neurointerventionalist, experienced board certified neurointerventionalist, and neuroanesthesiologist. Our stroke center meet the criteria for stroke unit and stroke center according to the European Stroke Organization certification and work 24/7. We perform EVT in 6 hours from stroke onset in anterior circulation according to Bulgarian guideline and NHF requirements. All patients should be, as Bulgarian guideline says, with NHSS above 6, aspects above or equal to 6, and age above or equal to 18, and MRS prior to stroke below 1. If it is possible, we combined IVT and EVT. We prefer conscious sedation, not general anesthesia, if patient is not agitated. We prefer femoral approach for EVT, and at the most of the cases, tent retriever and aspiration are used simultaneously. Our door-to-groin time varies from 75 to 138 minutes, but the most of them are below 90 minutes. We use, in the most of the cases, the following catheters and wires: Neuron Max and Guider Soft Tip as guide catheter. For intermediate catheters, we use aspiration catheters A68 and React 71, microcatheters Marksman and Phenom, and for wires, Terumo hydrophilic guide wire, Sinhu 2 microwire, and if the patient has heart anatomy, we use Amplad super stiff support wire. And now I'll present you a couple of our cases. The first one is 80-year-old woman with acute weakness in the left limbs, 3.5 hours before hospitalization. On CT angio, we found thrombosis of M1 part of MCA on the right. The initial aspects was 8 points, NHSS 8 points, Glasgow Coma Scale 15 points, and MRS prior stroke was 0 points. We performed in this case IV thrombolysis, and after that EVT. IV thrombolysis was standard dose, actually 0.9 milligrams per kilos with 10% bolus. And after the procedure, MCA was fully recanalized to TK3, but on the control CT scan there is a small hypodense area in the globus pallidus on the right. We needed 1 pass to achieve TK3 recanalization. Door-to-needle time was 45 minutes and door-to-groin time was 78 minutes. From stroke onset to recanalization is 5.15 hours. The second case is a patient in this case, we use just aspiration, and it's for a patient, 55-year-old man with right-sided central hemiplegia and sensomotor aphasia, 30 minutes before hospitalization. On CT scan, there is thrombosis of the left MCA M1 part, and we used just suction with pump penumbra and aspiration catheter A64 with a very good result after recanalization TK3 in 3.30 hours after the stroke onset. And the last case it's with not so good results. It was 73-year-old male with acute right-sided weakness, 2.5 hours before hospitalization. It was a moderate severe stroke with aspects 9 points. On CT angio, we found thrombosis of MCA on the left. We performed IVT and after that EVT with thrombus aspiration and stent retrieving with very good result, TK3. But on the control CT scan, we found hypodense area here and here on in ACA and MCA, maybe because of distal embolization. What are our challenges and difficulties? The first, maybe the basic one, is timing. Patients arrive at hospital after permitted time window for EVT, and for Bulgaria it is 4 hours. We can not work in 24 hours, as it is shown in diffuse 3 and down. COVID-19 also made endovascular treatment of stroke very difficult for almost 2 years. Technical issues. For example, patients with thrombosis of ICA and MCA are still hard for us, and some of the patients could not be done very well. Although we fulfill criteria for stroke units and stroke centers according to the European Stroke Organization certification, we are still a young center in the terms of EVT, and we need maybe more training. Thank you.
Thank you very much for this comprehensive overview. I'm very much aware that the number of stroke patients is going to rise. Why would we exclude patients that previously had a walking stick when it's part of the elderly population? Why does it need to be modified ranking scale 0 or 1? The evidence is now coming out for patients with a low aspect score as well, that they do better, although the number needed to treat. How many interventionalists do you think are necessary to provide a 24/7 service in one center? And Ivo, if I could already ask you then. Yeah, but yes, how many do you think?
Maybe 3.
3
or 4.
3 or 4 per center, yes.
4 is better because 1 is always on vacation time.
Thank you very much. Well, Ivo, in light, thank you very much. Because of the time, I'll continue. Ivo, in light of the rising number, which will exceed 25% of patients eligible for endovascular treatments, what do you think is the need for expanding?
Thank you very much. I would like to ask all the speakers to keep the time. So the time is 10 minutes, and I asked, in fact, the technical guys to interrupt the presentation after the 10 minutes. It was a compromise this time, but all the presentations will stop on the 10 minutes. Please, keep the time in order to have a conference. Okay, thank you, Nikolai, for the presentation. It's showing how, in fact, all the centers are in the beginning of their way. I would like to ask you for my presentation. Okay, thank you so much. Is there need to expand endovascular stroke services in Bulgaria? This is the question, and the answer is more than clear. And in Bulgaria, the cardiovascular disease, the so-called diseases of the circulation are number 1 killer, and the stroke is number 1 in Bulgaria. So the myocardial infarction is the second. It's a peculiarity in Bulgaria, but it's true. So in Bulgaria, the stroke is number 1 cause of death, unfortunately. This is the statistics in Bulgaria. Dr. Michnev, he have shown 52 cases. In fact, 52 cases of endovascular intervention represents 0.1 rate of endovascular intervention for the patients with stroke in Bulgaria. It's more than obvious we need more to do in order to have to fulfill some criteria. Act fast is very important. Nikki mentioned that. It's very important, but not only to act fast, but to act properly. How is to act properly? The endovascular treatment of stroke is with class 1A nowadays, and the threshold about aspect and about time, about aspect is going down, the threshold, and about the time is going up. So nowadays, up to based on the trials, up to 24 hours, it's advocated to make an intervention in case we need, in case we have the proper imaging and clinical data. So this is very important. We have more than 7 now randomized control trials showing definitely a huge benefit from the endovascular treatment. There are many meta-analyses nowadays showing much better result, functional result, MRS result in favor of endovascular intervention. And this is, in fact, number needed to treat is putting the endovascular treatment of stroke on one of the first places in the history of medicine of benefit. So the benefit of comparing to do it, comparing not to do it, is tremendous. It's huge. Nikki mentioned already there are different techniques, and this is good. There are different techniques evolving during the time: thromboaspiration, thrombus extraction, the combination of two, the so-called solumbra in the past, and the devices, aspiration devices are increasing the size, the suction capacity is increasing, the extraction with stent rivers is becoming better and better. And this is very important in order to improve the procedural results. It's definitely very important to have the good training. I saw in the presentation of Nikki that interventional cardiologists are excluded from the group of specialists that have the right to do the procedure. This is not right. Not the right, let's say, strategy. So our team performed the first time ever catheter-based intervention of stroke in 2008. It was 15 years ago, and unfortunately still, we are, as a nation, we are still in the beginning of our way. So still we are in the period of training. There are just a few centers. This is our local, in fact, experience. We are not among the centers that are, in fact, authorized by the Ministry of Health to perform strokes, endovascular intervention. I'm just showing an ordinary case from our practice. We have performed during the last five years 62 cases of endovascular intervention, catheter-based. It's a 62-year female coming. She's by definition late comer, so she didn't came on time. She had definitely signs, imaging signs of not a huge stroke, but she had, following this criteria, to a indication to perform the intervention. She had occlusion of the right M1 and critical stenosis of the carotid artery, possible source for the embolization, and to occlude the M1 segment of the middle cerebral artery. So this is the finding. And with the proximal balloon catheter, we stented first, and after that, with the balloon guiding catheter, we occluded the flow in order to make the aspiration. And after making the aspiration, we succeed in extracting this thrombi. we succeeded to have full recanalization of the M1. So it's nothing special, ordinary case. The lady restored very well. So this is in fact the neurological, let's say, examination 1 hour after the intervention under conscious sedation. So we need definitely on a national level much better organization. We have to skip several steps in order to shorten the time of the patient to reach the stroke center. I'm showing here our experience about the primary PCI in myocardial infarction. We have excellent, but really excellent. We are now one of the champions on a European level regarding the application of the primary PCI in myocardial infarction, with more than 53 cath labs all over the territory of Bulgaria, with huge reduction of the mortality. So what we have to do about the stroke, we have to do the same. So we have to have centers ready 24 hours, 7 days a week to accept strokes. In order to achieve, like in many publications now, the collaboration between neurologists and neurointerventionists and also cardiologists, but trained cardiologists. Not every cardiologist has the right to perform the intervention. We need the collaboration and the proper training. I've had the 2 steps of training by the ESMIN course, and both WIST, the World Federation of Interventional Treatment and Stroke, and ESMIN accept interventional cardiologists to be trained to perform the intervention. So my opinion, because of the similarities between the myocardial infarction mechanism and the stroke, and also the need for skills and need for training in order to implement the exact guidelines into the daily practice, we need to have real collaboration, and we have the necessity to train not only neurointerventionists and neurologists and neurovascular surgeons, but we need to train also cardiologists, vascular surgeons, vascular radiologists, so everybody who has a good experience with doing intervention, especially doing carotid intervention, small vessels intervention, but after having the good training, following the guidelines of WIST. Iris and Klaus will tell us more about the training and how this can be performed, but for me this is absolutely crucial. And let's repeat, on a national level we need more. So we need to have more trained people. We have 24 hours availability of these centers in order to provide the proper treatment, the class 1, I repeat, in class 1 indication, treatment of patients with stroke. And thank you very much for your attention.
Ivo, thank you very much, and very interesting how you point out the parallels to STEMI and to the development of treating acute myocardial infarct and the development of the centers. Again, the infrastructure is there in Bulgaria, it is there, has expanded all over the world. When we formed WIST at the time, there was the intention of seeing, well, how could the huge demand be met? And the problem is that even if you had enough neuroradiologists to perform this procedure, the number of aneurysms, AVMs, spinal malformations is limited. So what are they going to do during the other time? They've now gone for the whole training of becoming neuroradiologists, and then they sit around waiting for the stroke case or fighting for an aneurysm to come. So we realized that there's an importance of finding training in those specialities that have the catheter skills, like, for example, interventionists from other fields, and that is how the training guidelines started to develop.
Definitely. Thank you for this comment. We are happy to have the Minister of Health, Professor Hinkov, among us. And I really hope that with your help, Anna, yours, Professor Matthias, Professor Alvarez, with your help, guys, we will have the chance to implement the right guidelines after the right training on a national level, and thank you very much for your support indeed. Thank you.
Thank you. So, without further ado, Professor Klaus Matthias, you are the chair of the training committee in WIST.
Yes, WIST we had. WIST we had the idea to found that was in yes, now already 10 years ago, and then 2015, yes, it was established, and we also developed naturally training guidelines, as you have heard already. So I can go fast through all these. You have already heard that acute stroke is an emergency. We need immediate diagnosis and therapy. Yes, the number of patients who are treated by thrombectomy is still too low, not only in Bulgaria, but worldwide. 2.5 million eligible patients are deprived of this treatment every year. And we need a sufficient number of well-trained vascular interventionalists. We have quite a lot of societies with very similar guidelines how to train and qualify people, as you see, but the most important naturally is the World Federation for Interventional Stroke Treatment, which is interdisciplinary, yes, so involved are all vascular interventionalists who are interested and are doing procedures also in the blood supply to the brain. So we founded these training guidelines, and competency should be in diagnostic cerebral angiography, carotid stenting, cerebrovascular intervention, and naturally performance and training standards for endovascular ischemic stroke treatment. Yes, when physicians providing these treatment, they need to have some baseline qualifications, and they should know clinical signs of acute stroke and establish the diagnosis, be familiar with the neuroimaging and interpretation of these images and cerebral angiography. And certainly when they learn that, there should be also an experienced and qualified physician who is checking on that. Yes, dedicated training naturally is much easier in high-volume centers. When you have daily 1 or 2 strokes to treat, then it's very fast that you can train people, but when you have only 1 per month, then you need quite a lot of time. Therefore, we need a special training program, and a high-volume center is of advantage. Yeah, that includes the training, appropriate access, microcatheter navigation, and also with a small guide wire, neuroguide wires, because you can easily perforate a cerebral artery. Cerebral artery is a little bit thinner wall than the other body arteries. Yes, and you should be also naturally know how to avoid a complication. A typical case, 60-year-old woman, 4 hours symptomatic. Perfusion CT shows you the underperfused area is the middle cerebral artery territory. The angio shows you CT angio, the occlusion of the MCA. It's the most frequently seen location for occlusions. You see then the angiogram. The other arteries are patent. And you see after thrombectomy, normal flow to the middle cerebral artery. Controlled CT, yes, normal. No stroke at all. But 24 hours later, you see tiny signal-intense spots in the brain, MRI, but this is asymptomatic, and new cerebral cells will replace the dead cells there. How to train? Yes, when you don't have these patients and you're waiting for the next, yes, we have several models, the silicon models, 3D printed models, high-fidelity simulators, animal models. It was mentioned that I did the first carotid angioplasty. Yeah, the first carotid angioplasty I did in a dog, in a model, and not in a human being. And human cadavers, you will learn more about that later on. Oh, here is a very nice lady with a gentleman seen on the right side, and that is how to train it with simulators. Yes, there is electronically stored all the data for one case, and then you can choose your devices, and then you start and do the procedure. So it's a very good way, and it's not only one patient stored. There are different anatomies, different locations of the occlusion of the cerebral artery, and so on. Yes, naturally you have also to maintain the qualification. Yeah. Therefore, it is necessary, yes, from time to time to repeat it and to see, yes, is it really solidly founded? Does the new interventionalist know all the facts which were, yes, taught? Very helpful is the quality assurance program, because you have to collect the data, you have to look them up, and then you see what was our success rate, what was our embolization to other territories, complications, yes, and did we have intracranial hemorrhage. So that is also very important, and you have here some figures which are very high. Normally you have much less, so I cannot remember that I had an intracranial hemorrhage of 10%. That is, I would say, we can bring down that figure to 3%. Also, the hospital has, that are the preconditions for an intervention. So you need the diagnostic tools, you need the angio suite, and you need also the specialties, because that is a multi-speciality treatment, acute stroke. You have the neurologist, neurosurgeon, neurointerventionist, and so on. So well-trained neurointerventionalists are a critical component of an organized and efficient team for clinically effective mechanical thrombectomy of acute ischemic stroke patients worldwide. Yes, how to train catheteroprobic in difficult anatomy? Here, you see how to do it. Thank you very much.
Klaus, thank you very much. I think here again the importance of a team approach. It is not going to a course. Yes, now you're certified and that's it. It's providing the ongoing support. It's being there during the first cases. It is being available to be asked if something goes wrong or if you need advice. And I would like to ask you, Alessandro, to share your experience. You were the first center that got trained with WIST, and to share your story. Thank you, Klaus.
Good morning, ladies and gentlemen. It's a great pleasure and a big honor to be here in this amazing meeting in Bulgaria. I'm very happy because it's my first time in Sofia, Bulgaria. And I'm so excited because it's a pleasure and it's special to me to share this session with my family WIST. Thank you very much for the invitation to the whole organization, especially Professor Ivo Petrov. The title is How I Get Trained as a Cardiologist by the World Federation for Interventional Stroke Treatment. I'm Dr. Carlos Alejandro Alvarez, and I'm an interventional cardiologist. I work in 4 centers, 3 in Bahia Blanca, another in Tres Arroyos City. And as an interventional cardiology in my daily practice, I usually do different diagnostic and intervention endovascular treatment in carotid, structural, aortic, venous, peripheral vascular intervention, embolatry, and many others. But in January 2015, a 40-year-old female patient that was working as a nurse in another center had a disabling stroke in her home and was transferred to our hospital without any delay, an obvious big vessel occlusion. But she didn't receive any treatment, was terrified. No thrombolytics, no mechanical thrombectomy, and we couldn't do anything for this young girl. Of course, this patient had a very bad outcomes with modified ranking scale score 4, and she was transferred to another rehabilitation center in another city named Mar del Plata City, and remains for 2 years in a daily physiotherapy, rehabilitation, and the worst thing, totally dependent in her family. But after 2 years, this patient that I knew very well died. Then I decided to get involved in a certified program in mechanical thrombectomy. In order to know more about the stroke field, I decided to attend a dedicated conference, and I found on internet this amazing conference that ICA stroke meeting. I attended 3 ICA stroke meetings in over 3 consecutive years. This is my first ICA stroke meeting in 2016 in Prague. The other stroke meeting that I attended was in Moscow in 2017, and finally in Warsaw. This is a very nice meeting. I learned the clinical evidence. You can interact with experts. You have the feedback with expert faculty, and at the end of the meeting, you have a final exam to score what you learn. In this meeting, I had the opportunity to have an interview with Professor Iris Rumbal and Horst Sieber, and was special to me because they was admitted to an acute stroke and carotid stenting certified program by the World Federation for Interventional Stroke Treatment in England. Finally, I went to England, especially to Kelford City, to do my training at Anglia Ruskin University with Professor Iris Rumbal, that at that moment was the director of Neuroscience Department Vascular Simulation Unit at Anglia Ruskin University. Now she's the chair of Neuroscience Department at Dundee University. Over a month, I complete a very intensive theoretical and practical certified training with Iris at Anglia Ruskin University. I learned anatomy, I learned histology, physiology, different clinical syndromes. I reviewed the pathway, image interpretation, how to score aspect, CT perfusion interpretation, the different sequence and images in MRI. This is a very nice picture of our daily trip from Southern Sea to Kelford City to attend the beauty Anglia Ruskin University. And I did my intensive practical training and certified practical training in the simulator unit at Anglia Ruskin University with Professor Iris, using the Angiomentor Symbiotic 3D simulator, and because it was so realistic, the interaction with the simulator. I did many diagnostic procedures. The first week, I did many diagnostic procedures. I improved my skill in how to use wires to approach different arch anatomy. Then the other week, we started to do many carotid procedures with complex anatomies, different arch, different clinical scenario, and finally, I started my treatment in mechanical thrombectomy in anterior and posterior circulation. We did many procedures, discussed the clinical syndrome, how to manage the patient, relatives, radiographer, anesthesiology, how to manage the patient during the intervention, the blood pressure, etc., and the post-procedure. To complete my program, I went to a high-volume center in Germany, especially in Bremen, to the Klinikum Mitte Bremen, and I met Christian and Christian team. Christian was the director of the neuroscience department in Bremen, and we review all the patients that they treat. How did they select the best candidate to do mechanical thrombectomy, image interpretation, etc. Finally, I returned to Anglia Ruskin University, and I prepared my final exam. That was a theoretical and practical exam, and fortunately, I passed the exam, I think that with a good results. And at the end of the exam, Iris gave me a very nice present that is this amazing book, How to Set Up an Acute Stroke Service. Finally, I come back to Argentina, to my center, and Professor Iris Rumbal went to Bahia Blanca, and I did one hard workshop in how to set up a stroke service. Iris trained nurses, neurologists, all the personnel involved in our team in mechanical thrombectomy. We reviewed the pathway, we discussed many clinical situations, we took some pictures with all the team, with the director of the cath lab, the director of the institution, and finally, Iris went to our endovascular symposium in Bahia Blanca. In that moment, the objective was to celebrate our 40th anniversary of hard work in Bahia Blanca City. It was a special session of carotid intervention and mechanical thrombectomy to treat this acute ischemic stroke patient. Iris gave an amazing lecture to all renew interventional cardiology in Argentina. And finally, was a special moment to me because Iris gave me the certificates by the World Federation of Interventional Stroke Treatment. Since that moment, I started to screen many patients, and really, I share all my clinical cases with Iris that she did teleproctoring in each cases. For ending my lecture, I want to share with you my last cases that it was not an ideal situation, but it's very important to be prepared, to be training in mechanical thrombectomy to help patients. This is a 70-year-old female patient with cardiac risk factor, hypertension, dyslipidemia. The patient had an atrial fibrillation, and electrophysiologists tried to treat with ablation, but failed 2 times. For that reason, the patient was on anticoagulation. And on January 2018, at 2 p.m., had a disabling stroke, severe aphasia, and complete left hemiplegia. And the patient was or lived in a Coronel Pringles, that is a city 200 kilometers away from Bahia Blanca. Then was transferred to the hospital in Coronel Pringles. At 5 o'clock, at 5 p.m., a colleague called me to tell me the clinical case and sent me the images. I score aspect, the score aspect was 9. The strategy was treat the patient with TPI, sent to Bahia Blanca, to the primary hospital, but there's no, was a viable thrombolysis in that moment. Then my colleague sent the patient, but not to the primary stroke center, to the secondary center that I work in that center, because the insurance of the patient. Unfortunately, after the patient arrived, the best things to do is to do an CT images, but the CT machine was broken. There's no available MRI machine. I started the procedure 6 hours and a half. Well, I went directly to the carotid artery, the responsible of the stroke. There was a T occlusion. Then I started with my procedure with the stone retriever. I got the best vascular approach with a 7-frame sheet. I used 100 synchro wire, microcatheter. I got the best support. I progressed the microcatheter through I changed the projection to be sure about the wire position. I deployed the stent retrievers, and I extract a small amount of thrombus. I did 3 paces, but I was not capable to recanalization of the T occlusion. Then I did Solumbra and Penumbra. This is the Penumbra. I did aspiration. Finally, I extract a very huge amount of thrombus. Was a very good flow restoration. And at 9 o'clock, 30 minutes after I started the procedure, we finished the procedure with TC3. The evolution of the patient was very good. This is the 24 hours, the CT angio to evaluate the extracranial and intracranial circulation, the CT angio intracranial, the axial view. And the patient was, at 7 days, was discharged to her home. And this is the first video 7 days after the procedure. The patient was alive with a good quality of life and totally independent on her family. Then, because the patient was on anticoagulation, decided to close the left atrial appendage. Was a very tough case, but I decided to do the procedure. It was an live transmission to the CSI in Frankfurt. And this is my final message. This is the ending of my lecture. This is the message as an interventional cardiology, because I was training in mechanical thrombectomy, I can help the patient. This is a 90-day evolution after the mechanical thrombectomy. The patient is alive with a good quality of life, totally independent on her family. Then all interventionals who want to be involved in mechanical treatment, I think that should be training. In my experience, the best way is by World Federation for Interventional Stroke Treatment. Again, Ivo, thank you very much for the invitation, and thank you very much, Professor Iris Grunwald, for trusting me in helping and treating these kind of patients.
Alessandro, thank you very much. It was the beginning of an amazing, incredible journey, and I'm so proud how you have maintained your team and how you've built things up.
Thank you.
What I learned the most was how much we can learn from each other. So I'm a neuroradiologist from my background, and I learned so much from my colleagues in cardiology, tips and tricks, and also, to come on to the next talk, Dr. Sanjay Pillai, who's an interventional radiologist, and my colleague in Dundee. And as a background, there was no stroke thrombectomy service in 2020 in Scotland at the time. And we thought, well, can it be done in an interventional radiology center?
Cardiologists, yes, the heart is the main source of emboli going to the brain.
Yes. Sanjay, please.
Thank you. Thanks for the opportunity. I would start by saying that anybody with a catheter and wire skill can be trained to do this procedure. I, as an interventional radiologist, work except in heart and brain. That's what I was trained to do. If I can do the procedure comfortably, any of you in this room with catheter wire skill can do it. What is crucial is us working with each other. It is not important. I am a neuroradiologist. I'm the only one who can do it. I'm a cardiologist. I'm the only one who can do it. No, it is us working together. Any endovascular specialist can do it. Please, please. That is my message, really. Right. I've been asked to talk about Scotland. So that is us, top end of the United Kingdom. I would think that we are the most important part of United Kingdom because we are the brain, we are the head. 5 million, small country, right? Healthcare is completely provided by the government. It's a free health service. National Health Service is what we are called. In Scotland, it is, we have a Scottish government which has got devolved power, and healthcare is Scottish government's devolved responsibility. So that is Scotland again. That red line there, that is just to show you how population is there in Scotland. So above the red line is a large area with about 1.5 million population, and that is the region we cover. If you look below the red line, that is where most of the population is concentrated. That is not the region we cover. So we get patients from the islands as well, and there is a delay in time for us to get the patients. So that line is crucial to understand. So before we got in touch with WIST, before we thought about developing a service, this became an interesting and important thing for Scottish government. They came up with a plan that we have to have the service in Scotland. And then we thought, how do we go about it? They wanted a 24/7 coverage, which is the right thing. What they thought was we would implement it as different phases. So start off in one region in the south, and then to the second region in south, and the third region after all this. So if that was how the model was going to be, it would take at least 15 years for it to develop. And the people in the north of Scotland would be less benefited by this. So some of us suggested that, why don't we do something different? And we start a service in the north of Scotland by a different group of specialists rather than interventional neuroradiologists, who were the people who are used to working in the brain. And some people thought they should be the ones who should be providing the service. We thought, well, maybe not. This paper quite clearly said that other people can do it, and we went with it. We looked around, we saw that in different centers in Europe and rest of the world, there are other specialists who do it. So I said, well, if they can do it, why can't we do it? And then we looked around how we do it. So we met up with these people. These are the people above the red line. We said that we have to develop this separately from what Scottish Government is saying. With the help of Scottish Government, how do we get along with it? And lots of people were enthusiastic, keen, and supported us to go with it. And then we decided, well, this is a place where we do it. This is where I work, Dundee, which is in the east of Scotland. Purely the reason was because we had a 24/7 interventional radiology service, and we were quite keen to get this going. And then we looked around. Well, how do we do this? So, these are the people who can do it: interventional radiologists, neuroradiologists, cardiologists, endovascular neurosurgeons, neurologists. Anybody, as I said to you earlier, with catheter wire skill should be able to do it with appropriate training. That's a crucial factor. So, Royal College of Radiology, I'm a radiologist. So this is how we start new procedures. So, the interventional radiologist is something you would understand that different new procedures come into being, prostate, etc., etc. How do we train? Well, we go through those steps and start doing things on our own. Why can't we do the same thing for stroke thrombectomy? It is just another region of the body. And then we decided on a decent pathway to reduce time to make things efficient. So all that happened. And then I looked around to see, where can I get trained? For interventional radiology, I know where I can get trained. For neuroradiology, where do I get trained? I asked around. There was nobody in the United Kingdom to train us because it was all in the hands of interventional neuroradiologists who themselves were struggling to do it. They did not have any experience in it, like me. The only difference between me and them was that they were used to working in the brain, or the blood vessels in the brain. To me, it's just another blood vessel. So a bit of my background, I'm from India, I'm an adopted Scot. I was brought up as a Hindu, right? The reason I'm saying this is because we've got thousands of gods. So when Islam and Christianity came to India, that is just a couple of other gods to us, so we just accepted it. Similarly, as a radiologist, interventional radiologist, I'm used to working in different bits of the body. Brain is just another one. So it's nothing great. It's just that I need to get the exposure to do it. And then I couldn't find anybody to train me. And what happened was I got an email from a meeting in India saying that we have this conference in New Delhi. If you or your team want to get trained in mechanical thrombectomy, register your interest. And I did that in 2018, and I heard nothing back for 6 months. And then I get a phone call saying that, well, are you still interested? If so, contact this number. And I get a United Kingdom phone number, right? This person who emailed me was from Germany. I said, oh, are they having me on? Is that real? So I called this number, and who do I speak to? Iris, right? That's how I came in contact with West. So that is what I say, it's real magic. We moved on. You've seen the training program they have mentioned. It is not me getting trained to suck out a bit of clot. It is very easy for me to get into any artery and suck a bit of clot. That is not the difficult bit. The difficult bit is taking the team with you, the people who work with you together, the stroke physicians, neurologists, the anesthesia team, the nurses, the radiographers, and the lot. So it has to be a team effort. A single person cannot do it. However skilled they are, they can't. And then, well, I'm not going to go too much into this because it's already been said. People with background skills can be trained. You need to know the case selection, anatomy, imaging, and then procedure. We went to get this simulation training. Mechanical simulators. Well, many of us must have used an aircraft to come here. We sit with a pilot safely, and without any issues, we climb on a plane. So why should we not be trained with simulation? I know that there are people who say that, well, simulation training is not equivalent to real-life training. I beg to differ. It can be exactly the same, and sometimes better too, because you can work under controlled conditions to deal with complications. So in Dundee, I was lucky enough to poach Iris from Anglia Ruskin to Dundee, and she works with us now, or I work with her now. We have a good facility where we have simulators. And another thing which we have unique is we have something called a teal cadaver, which is a cadaver which is like a real body, where we can pump fluid and work on it, really like a real body. So what WIST does is amazing. It's not just the team training and training of the individual. They look at the place, they certify the place. So they come and suggest that, well, you're doing great on that, but that is not so good. Why don't you change into this or that? And they would help you throughout the process of developing a service. That is one part of it. The most important part is when you start a program, you need support. You need support, real-life support, when you start it and after you start it. And then they assess you and say, are you doing good or are you killing patients? Data collection, they look at the data every so often and say that, well, you're doing good or you're not doing good. What can you do to improve? And that support is there non-stop. Any time of the year, any time of the day, I can speak to a friend. All I need is to pick a phone up. I have worked a patient on the table with a video camera showing people in Germany or in Buffalo pictures saying, am I doing this right? What do I do next? Nowhere else you would get that kind of a support apart from WIST, in my experience. So I'm not biased at all, you would think. I think that WIST is an excellent training structure. It's just that you need to dip your toe into to get the exposure. Thank you.
Sanjay, thank you very much. I think the important part in overcoming the limitations of simulators is the human perfused cadaveric model. I believe at the moment Dundee is the only place in the world that has developed a model where you can do interventions directly in a dead human body. So that makes it the most realistic, lifelike experience because you can perform procedures directly in the human anatomy, going into the brain, mimicking blood pressure, and that is what has been probably you can comment on.
So it is real life. The body, the embalming technique is unique that it retains the flexibility. The blood vessels remain like blood vessels. You can put a catheter into it. You can push fluid through the blood vessels, and you can do angiograms, you can do valve testings. Before we started endovascular stroke treatment, we have worked on it. We've trained people for biliary interventions, percutaneous ablations. It's like real life patients. It's amazing. You have to see that to believe it.
Yeah. Thank you very much. And then I think we will go on to the live case, recorded live case. And I'm happy to introduce my colleague, Dr. Dufet Aliovsky. Yes. And you're going to show us not an easy case, but a tandem lesion, right?
Yes. So can I get my slides? Thank you. In the matter of time, I will be faster. First case is the guy with 78-year-old admitted in the cardiology with serious problem with heart. Today, after that, he has a major stroke with right side hemiplegia. Oh, thank you. It will be better for me also, just to watch. Where is the... Can I go further? So, initial CT scan shows he's going, yes. This is pre-op CT scan. Initial angio, we find a right side truncus brachiocephalicus and subclavian occlusion. From the left side, it's same. And the occlusion of the common carotid artery of the left side. We do a couple of balloon dilatation of common carotid artery, and after that we find stenosis and occlusion of left carotid artery. We success to put the distal protection spider in the left carotid artery, and after 2 passes with balloon, we have this resulted. So, and after the tromp aspiration, for us is first pass policy is thrombectomy. We have a TK3, but after 10 minutes, for example, we have another occlusion of the left internal carotid artery, and after that we use stent retriever NEVA, and this is the final result also the final result of common carotid artery. Control CT scan of the next day. It is our protocol. This is the final result, a lot of clots. Patient was discharged without significant neurological deficit, modified Rankin score 1, slight speech disorder, NIC score 2. Second patient, it's 68-year female, admission 4 hours after onset of symptoms with disability of speech, left hemiplegia, and 7th nerve palsy, NHS score 19. This is, initial CT. Initial imaging shows MCA occlusion. After first pass, we have a TK2B, but we understand that we have a instable plaque because when we put the stent into the parent vessel, we see the shrinking of the stent. Control angio through the stent in the parent vessel, showing, where is the laser here, showing black. And after the control angio without stent, we see also instable plaque in the MCA artery. For this reason, we decide to do balloon dilatation of MCA. After the balloon dilatation, this is the final result. This is the CT scan of the next day. It shows small ischemia of posterior cerebral artery. This is the control angio, CT angiography of the patient 1 month after the procedure. This is the result after the balloon dilatation. And third case, it's patient from the last days. It is 70-year-old male. Patient is admitted in a neurological department with TIA, but with slight hemiparesis. 2 hours after admission, he has a symptom of huge stroke with NHS score 26. For this reason, he was on double antiplatelet therapy for no stenosis of carotid artery. For this reason, we start with directly for mechanical thrombectomy. This is the initial CT scan. In initial angiography, we found subtotal occlusion of left carotid artery 99%. For Europe, tandem occlusion are around 10%. In our center, tandem occlusion is around 25%, which means we have problems. So I success to put all 10 wire through the stenosis, and after that I exchange with all 14 balloon dilatation. Yes, with small balloon 2.20, for example, to be able to put the distal protection. Now, I show this distal protection. In regular, I work with spider protection. After balloon dilatation with 5x20, we place the stand protégé 10.7 by 40 millimeter. But after that, we find occlusion below to the stand. We just succeed to pass through the strut of the stands and to do mechanical, to do trompe aspiration with a catheter, and this is the final result of the patient. Post-operative CT scan is from yesterday, and improvement of the patient. He's walking, NHS score 12, modified ranking score, I think that it's 2 now. And thank you for the attention.
Yes, thank you very much. Is there any comment or question? If not, I thank you and I wish you much success also in future.
Thank you.
And we are going on in the program. After this pre-recorded live case, I come now to our Italian guest. We have already heard something about stroke management in Bulgaria, in Argentina, and now we hear it, how it is running in Italy.
Good morning, everybody. I would like to thank you for having me today. Thank you so much. It's a great honor. I'm Simone Peschillo. I'm from Italy. And today I would like to talk about the endovascular stroke service in Italy. So we should always keep in mind that for stroke treatment, we are talking about not only ischemic stroke, but also hemorrhagic stroke. But today I will show you how we have organized the stroke, the ischemic stroke treatment. We know that there are two kind of model that are the drip and ship model and the mothership model. On the drip and ship model, the patient goes to the peripheral hospital where he can perform the intravenous thrombolysis. Then, if it is necessary, it will ship to the up center for mechanical thrombectomy. Or the mothership model, where the patient, wherever he is, it is sent directly to the hub center. Following this meta-analysis regarding the outcomes of patients treated with the drip and ship model and the mothership model, the authors have demonstrated that mothership organization paradigm was associated with higher rates of functional independence in 3 months compared to drip and ship. So that's why 10 years ago in Italy, it was decided to use the mothership model. In fact, we have the up center where all patients from SPOC, from where SPOC center will send the patient to the hub. We have a two kind of level about stroke unit. The level 1 stroke unit is a SPOC center, and the level 2 stroke unit that is an hub center, where neurosurgery, neurointerventional, and stroke unit are. In fact, to be an hub center, the equipment must be a level 2 stroke unit with neurology 24 hours a day, neurointerventional endovascular procedures, neurosurgery, vascular neurosurgery, and the capability to perform all the procedures, not only the ischemic strokes, but also hemorrhagic stroke. Those are official data from the Italian Ministry of Health. Normally we have around 5,240 patients per year regarding ischemic stroke, and those are the statistics about the door to groin, and during the last year we slightly improved this time. This is the stroke patient journey about the ischemic stroke. We have a rapid identification of potential stroke, direct transport to the stroke ready hospital, where the patient perform an angio-CT, and in case of occlusion, thrombolysis, and in case of large vessel occlusion or other indication, the patient go directly to the angio suite for thrombectomy. And this is the journey about an hemorrhagic patient. Angio-CT, then we decide to treat the patient if open or endovascularly, and then the patient go directly, if there are no complications, to rehabilitation. This is the map of Tuscany, where the stroke network is very good. And in pink, you can see the centers that are allowed to do thrombectomy, and in blue, the SPOC centers. So from all over the region, patient can have to be transferred for mechanical thrombectomy to Siena, Firenze, and Pisa. In this cartogram, you can see the rates of thrombolysis during the years. This picture refers to 2019, this 2020, this 2021. So it was a little bit increasing, especially in the north part of Italy, and those are all together. But if you move to thrombectomy, we can see that in 2019, in particular in the south part of Italy, there were not centers to do thrombectomy, but among the last years, this improved, especially, for example, in my region, in the Lazio region. And here you can see the evolution of the endovascular treatments. This is a temporal distribution of thrombectomy treatments in terms of frequency. So the majority of them come in the emergency department from 1 to 3 hours in 48% of the cases. But I would like to point out this paper that was published recently, where the authors have compared the international centers, and they made a survey about the data, about the ischemic stroke data. So look here, those are the number of additional stroke units that would be required in each country. Those are the number of additional thrombectomy centers, and those are the number of additional intravenous thrombolysis and endovascular treatment per year. So all over Europe, we need to treat more than 200,000 people for intravenous thrombolysis and 67,000 people for thrombectomy. So we have a lot of things to do. And in particular, look here, Bulgaria needs to have 3 more comprehensive stroke centers and to treat 1,400 patients, compared to Italy, where we need to work to have 10 more stroke centers to deal treating 3,000 people. So in this choropleth map, you can see clearly the status of thrombolysis. So the best in Europe is Germany. Italy is the same level of France and Spain, so we need to improve. And this regards the endovascular treatment. Look, France, for example, is better than Italy. Germany is still the best, but all the east part of Europe is in red. So there is still a lot to do. The advent of stroke unit has reduced mortality of 3%, dependence of 5%, and institutionalization of 2%. Look here, this is the statistic about the stroke unit per million population. So even in this case, we need to do more. And 1% decrease in mortality and 20% in 25% in disability can reduce overall cost by more than 10%. This is very important. In conclusion, we can say that there is still much to be done, and we need a healthcare policy that goes beyond the vetoes, allowing other specialties, such as neurologists and neurosurgeons, to perform endovascular procedures, as is now the case worldwide. We owe it to the patients. Thank you so much.
Yeah, thank you very much for this overview. And I congratulate you. Yes, and as you mentioned, there's still some work to be done in the future. In Germany, you mentioned it, we have a stroke unit with stroke treatment interventionally in every city. And in the large cities like Berlin, Hamburg, Munich, there are several of them, naturally, because not only one center. So I think every city, not every village, but every city should have a center. So we go on in the program. It's now my pleasure, yes, to announce Iris. And we have already heard about dead bodies and so on. And when you look into history, back, it's more than 3,000 years that human people were very curious what is going on within the body. So also the old Egyptians already cut open the bodies and so on. And the Greek people established anatomy, looking and speculating what is the function of a liver or of a kidney and so on. And now we will learn much more about these, yes, not cutting open all the bodies, but to preserve them.
Thank you. I will talk about the role of simulators and the perfused human cadaveric model. I do have a disclosure. The most important one is that I'm co-founder of the AI company Brainomics. So what is different with the WIS training? It is based on competency rather than time. You can spend as much time in a center as you want. If you're not allowed to touch the patient or do procedures, you will not necessarily learn the technical skills. And here, the skills can be acquired with high-fidelity simulators and on perfused human cadavers. So how do we get trained? There's different ways. You can employ an interventional neuroradiologist. Unfortunately, there are not that many around, and they may not necessarily want to join your center. You can read a book Will not give you a lot of practical experience, but will give you some basic knowledge. You can do a fellowship in a thrombectomy center. Problem is, are you going to be allowed to touch the patient? Do you have the insurance? Do you need registration in that country? And are you competing with the local residents? So how do we get both the clinical knowledge and the procedural knowledge? For the clinical knowledge, I think it is vital that you know how to interpret images. You're the operator, you need to know what you're dealing with. You need to know how much brain is still salvageable. You need to know the vessel anatomy. For this, we use AI tools where basically instead of someone standing next to you to always criticize or to always say this is the area of stroke, you can do scoring and the result is shown to you afterwards by the AI software. Interestingly, we found that it takes about 57 cases before you get better in scoring aspect score in early ischemic stroke. Again, looking at collaterals and collateral scoring, and looking at the infarct volume here. The infarct volume is given to us already from the plain CT. Again, an important question to know what you're fighting for to make an individual risk-benefit analysis for the patient and to see how long this brain is likely going to be alive looking at the collaterals. We use digital communication tools where we now have a dedicated patient channel where you can call someone in for help. They do not need to be alerted for every single case that you're doing, but if you need to pull someone into that channel, you will pull them in and they will have all that patient information on one place. Now, how about the technical skills? How about the procedural knowledge? For this, simulators have come a long way, developing from being expensive toys to being real medical devices that are, for certain procedures, CE marked and FDA approved for putting the real patient data on and practicing that patient's case. You can practice complications with the whole team in a safe environment, and you can repeat this practicing so that when it comes to a complication or when the procedure starts, everyone will know their place and will have had the chance of knowing what the other person's role is. So I quite like changing roles between operator and nurse and anesthetist. To give everyone that experience. Now it is possible to also put cases directly on to the simulator.
I'd like to just discuss the case that you sent over.
Last week. So this is a case that was sent to us. You can put that case onto the simulator and you can go through that case live with the other operator, planning different treatment techniques. That is how far these simulators have evolved now, giving you the haptic feedback and simulating that patient's anatomy. I would now ask you not to copy these images so that we can comply with the Human Anatomy Act and not share it outside of a scientific meeting, because I'm now going to show you the perfused human cadaveric model. Most of you will be familiar with cadavers, even from med school, and they would be formalin fixed, and they would be something like this. Stiff, the blood inside the vessels is coagulated. There's no way you can use these for performing an interventional procedure. Now, the new technique that we are using here is using perfused human cadaveric models, which are embalmed in a specific way that they remain flexible and that we can keep the vessels, both the arteries and the veins, open. The other advantage is that they do not need to be cooled anymore, and we have a bereavement period of 3 years, but theoretically they could last forever if you don't perforate the vessel. So here an example of an injection and looking at the vessels in the leg, you can see how even the small anatomy and the small vessels remain open in this cadaveric model. Here, perfused cadaveric model where we implanted a stent. You can see the stent being employed here. Here the stent is deployed. Very good also for device testing. If it's nitinol material, we perfuse the cadavers with heated fluid in order to simulate body temperature. It goes as far as being able to do procedures on the heart. Here you can see the aortic valve with a view from an endoscopic camera in the thoracic aorta, and heart-lung bypass with antegrade flow from left to the arterial port. Again, something in a human, we would have blood, which will limit us from seeing anything in the clear fluid. It is possible to exactly see how devices are being placed, and we can also evaluate vessel damage with this model. But the main advantage here is the testing of real devices that can be put inside, mimicking exactly the procedure or getting familiar with new devices. That includes the vital part of the procedure, which is the flushing and having continuous flow and checking that pressure bags are dripping. Again, team training, so important. It is not just the operator, it's the whole team that needs to work together, and because stroke is also so time sensitive. With the human cadavers, you can practice a complete team training session from bringing the patient in, doing a CT scan, to finishing the intervention. We have the advantage of being able to use the real anatomy, the real human anatomy, and again, the cases can be transmitted. Here we're using glasses for the transmission of a case. And it is possible to go into the intracranial anatomy here using stent retrievers, aspiration devices, doing coiling procedures to really get the feeling of the vessel anatomy. Thank you very much for your attention.
Ari, thank you very much for you see, explosion, yes. It's not only clapping the hands, it's a little even more, yes. So thank you very much. And then I have to announce a very special thing, because we are talking sometimes about transgender and so on, and something miraculously happened here in Bulgaria, so that Klaus Fassbender changed his gender overnight, and now you see here a very attractive lady. So you see, things happen. And so I wish you much success with your talk.
Thank you, Professor Matthias. Yes, it's the Bulgarian magic. I'm very grateful to Professor Petrov and the team here for having us again in this beautiful country, in this beautiful city. And we are looking forward as much as to discussion with you to also visit the city center and enjoy the city. The good news is that this is the last talk before the coffee break, so there's not much more that you need to bear. My talk is on behalf of Professor Fassbender, who unfortunately couldn't come in today. And already Nikolai and already Simon, they've highlighted the importance of time, of getting the patient quickly to the hospital and giving the treatment quite promptly. We thought about the mothership, drip to the hospital models. And then it was Professor Fassbender, who is the leading force behind the mobile stroke unit. It was already in 2003 when he had this idea to, why not bring the hospital to the patient? Instead of wasting time of bringing the patient to the big hospital, why not bring all of our imaging techniques, all of our expertise, and treat the patient at their home? That's why I'm sure that Iris will be able to tell all details, the story of the first grant with the students and how the first mobile stroke clinic was developed in Germany. And let's see how it works. Can we play the video? There should be also the voice. All right, we got a very quick gist, let's call it the technical difficulties. We had a very quick gist that in this ambulance, it's absolutely everything that you need to treat the stroke with the thrombolysis. Yeah. So from 2003 until now, a lot of has happened. Mobile stroke units are available across the world. There are more than 30 at the moment, and they are delivering the treatment in the golden hour, delivering much better results to the patients. It made its way to the guidelines. If possible, in the healthcare system, it is recommended to use mobile stroke unit because the results of the patients are just so much better. But there is a lot of talk about the price, about the standby time, also in the remote areas in Scotland where Iris and Sanjay is currently working. There may be not as many strokes in one day for this big ambulance with a lot of equipment to be affordable and helpful for people. That's why there was a new idea to do a little bit more and go hybrid. So the main thing is the same. There is an ambulance with the seat inside, and there is a basic crew that is composed from the doctor and the paramedic. And then, on top of that, we added a couple of more things. We added a radiography system, so we are able to perform chest x-rays. We also added ultrasound device that can look at the trauma patients to see if there is any free fluid, and also ECG and EEG device, so we can treat the cardiac emergency and also neurological emergencies with the status epilepticus. There's also point-of-care laboratory that will give us the analysis of multiple blood biomarkers in just a matter of seconds and minutes. And also, we had a little bit more medications in this ambulance now. So yes, we had the thrombolysis as the primary idea behind this mobile stroke unit, but we also added anti-seizures medications, antibiotics, vitamin K, and also things to treat severe asthma and respiratory distress. And what happened is that we've already tested the idea. So under the lead of Professor Walter in the UK and with Iris as a main radiologist and advising on most of the images produced on the ambulance, between May 2020 and February 2021, there was a pilot study in Suffolk in the UK where 250 patients were seen by mobile hybrid unit. And where they were compared with the matched patients from the normal ambulance service. What was good was that the hybrid MSU was acting as an independent ambulance. There was no duplication work. They were going on their own without the support of the normal system. And they were called out to the codes in the 999 or 112 system that were suspected of stroke, seizures, falls with head trauma, headache, unconsciousness, infection and pandemic, breathing problems and chest pains. And what was amazing that it was 86% of cases that we avoided A&E. I'm not sure how is currently the waiting time in Bulgaria in A&E, but in the UK it's quite abysmal. So any efforts that we can take away also from our emergency colleagues and provide earlier care at home is very beneficial to them. And almost half of the patients stayed at home. So, all the elderly people who were in the nursing home having a fall. And unfortunately, they're on the coagulant, so we need to make a CT head to make sure that there is no bleed in the brain. All of them, after the exclusion of this complication, could stay there. I didn't have to have a time-consuming trip to the hospital. We also admitted directly to the ward that was able to take the best care of the patient. There was quite a lot of immediate treatment, mainly around the stroke and around the seizures and severe infections. What was interesting that out of all the calls that were called stroke, only half of them were stroke. And then out of those that were called non-stroke, 20 of them were stroke. So that shows that MSU may be missing out quite a lot of patients. And hopefully the cost benefit and time benefit and then clinical benefit for the patient will be much better going forward. Thank you for your attention, and I hope you will enjoy your coffee.
Yes, and I hope that
Thank
you
you.
will see you again after the coffee break.
Correct. Thank you so much.
Perfect. Thank you.
20 minutes coffee.
20 minutes.
Yes.
Please have a seat. We want to continue with the session. And perhaps you can close the door because there is too much noise coming from outside. And it's now my pleasure to attend our speaker. And she will not speak about artificial intelligence replacing the brain, but how to save the brain.
Definitely, we are not planning to replace anything. But it is very much about the cooperation between our brain and the AI brain. So when I got the title of this topic, I couldn't resist, and I went to ChatGPT and I asked how AI can save time and brain. It gave me quite a generic answer with a lot of home improvements, with a lot of automation. It did mention the healthcare. Can aid medical professionals in diagnosing, interpreting medical images, and managing patient records. But I didn't feel it's enough. That's why I went to another generator, so Bard. Bard is the Google version of the ChatGPT. And again, it gave fairly standard long answer and a little bit more details. AI is being used to develop new drugs and treatments, to diagnose diseases and more accurately, and to provide personalized care to patients. And I think this is the highlight of that answer. There will be no fight. There are a lot of people afraid that human will fight against the robots, but what I believe that will naturally happen is that the human intelligence and artificial intelligence will supplement each other, will guide AI where to go into the repetitive automation of repetitive tasks, how to make the life easier for us. But it cannot stand on its own, and it still needs our human intelligence to look for overview. And in terms of the stroke, a lot of is focus put on the imaging, and imaging looking back to the onset, to the short and long-term outcomes. But however, I believe that it comes even before. Already in the stage of development, pre-stroke and cardiovascular risk factors, we can use AI algorithms to do the predictive algorithms. Here is one example that combines a lot of clinical factors, but also the ultrasound images of the carotid artery, where it calculates the plaque. And we can see that in this particular algorithm, the image phenotypes based on carotid ultrasound are responsible for half of the prediction of the stroke risk. There is also the Calvin Health. This is the Bulgarian company that uses the thermography to detect the underperfusion from the carotid. I'm sure that there will be a session with them at Wolf to attend that also help us to see and find people at risk of stroke even before it develops. And then there is a little bit of pre-hospital phase and also the communication tools that Iris has already mentioned that are using algorithms to try to detect the patients. And of course, there is imaging. Carlos already mentioned sharing WhatsApp images, and I'm sure that we all have been guilty of that, but the quality, it's not the best. That's why with the specialized software, we can get much more pristine images that will give us much more information rather than a blurry image on the WhatsApp. This is an example from Brainomics that does all the thinking for us, scores and shows us the occlusion even on the plain CT head. So if in the part of Scotland, I believe the Shetlands, they don't have CT angio yet. So if there is a stroke patient that would like to be sent to Sanjay and Iris, there is no real occlusion that we can see on the CT angio. So we need a supplemental thing to detect on the CT scan how to qualify this patient for treatment. There are different solutions, different pros and cons. I won't focus on those details. This is another with the CT angio. It also can show you like a penumbra tissue at risk. And of course, it indicates your target, your occlusion. Again, lot of system, lot of pros and cons. The same goes for the CT perfusion and also for the MRI imaging. And all of this is involved in the apps that are accessible immediately at our phones, wherever we are. And why we are doing all of this algorithms, all of these applications? We are doing this because it improves patients' outcomes and it improves times. This is an example of the Hungarian hospital after introduction of Brainomics, how the times were cut and how the outcomes were better. And then AI doesn't only need to help us with the everyday clinical care. It also helps us with clinical trials. They implemented an AI algorithm to detect a patient who may qualify for the clinical trial based on a hospital-wide base of the CT head scan, and we had more than 2,100 increase in the qualification to patients to the trial. So it shows also that we can learn more and faster with the support of AI. And then, after this acute treatment, or making the decision of acute treatment. This is based on the Mr. Clean study from Denmark. They built 2 calculators. The first one is just prior to making the decision about the endovascular thrombectomy. You need to put just a couple of details, like age and HSS, pre-stroke MRS, diabetes mellitus, blood pressure, and also details about the occlusion imaging. And it gives you the percentage of improvement and treatment benefit with or without endovascular therapy. So sometimes in this very acute situation when we need to get consent from the family, for some people it's easier to visualize of how much patient can get better with the treatment. A similar calculator here is supposed to predict the 3 months outcomes based on the imaging also on 24 hours was also developed by them. You can find the link at the top of the slides on both occasions. And it goes further. The rehabilitation in stroke doesn't stop using AI. There are, again, decision trees that are supporting for upper limb rehabilitation, prediction of outcomes, and deciding how to tailor the rehabilitation program to the particular patient. It is just one example. So that was a very quick overview of what's happening in stroke. As a cherry on top of everything, I just wanted to mention one AI solution that is running on ChatGPT, which saved me hours of work. I absolutely fell in love. This is Nabla Copilot, where you just do your consultation with the patient. It does, first of all, the transcription, and then it makes the automated medical notes that you can just copy-paste to the system. I've saved a lot of time and a lot of headache already, and I've been using it only 2 weeks. So it is very good because you can personalize your specialty. It is multilingual. There's no Bulgarian yet, but I know that they are working for. If there is any French speaker or Spanish speaker, you can consider yourself lucky if you are doing the consultation in those languages. And it also is, it doesn't store the data. Everything is on your computer, so it's quite safe in terms of the Data Protection Act. And again, thank you for your attention. I'll be happy to take any questions if there are.
So Iris will be the next speaker, but when you have any question to Anna,
okay, perfect.
It was so clear and you convinced all the people, so there is no question. Yeah. That gives me the pleasure now to announce Iris as the next speaker. She's working with the technology a little bit. And then we have, yes, communication tools.
Yes, I'm going to talk about a new communication tool, Moussala. Could I have the slides? Perfect. And here, relevant disclosure, Moussala have given us this communication software for evaluation for free of charge. Now, what is it? We know that in stroke, every minute counts. Per 30 minutes delay, the patient will slip on the modified ranking score, where 6 is dead, 5 is basically being a vegetable, and only 0 to 2 mean living independently by 1 point per 30 minutes delay. Again, it is quite disruptive to one's life if you get a lot of pre-alerts, which turn out not to be a case. And we thought, is there any possibility of already selecting patients that are likely thrombectomy candidates to meet our target of 9 minutes from decision to arterial puncture? So this is a communication tool where we could connect with other partners also by video. There is a pre-specified pathway for a range of diseases. And it streamlines this communication pathway with asking the relevant information to be entered, such as estimated time of arrival, LAMS, NIH score. You can choose whichever score you want, and you can also tailor it on how you use it. We're using the LAMS score in our pre-assessment, the Los Angeles Motor Scale score. So if a patient has a LAMS score of 5, we will pre-alert the angio team, the cath lab, and we will already get started and have not the expensive devices ripped open, but the other ones, and we know it has a reliability of about 80%. So that justifies already getting the pre-alert. We can have it on our smartphones, on tablets, it can be web-based. The thing that I like about it a lot is that it has one specific patient channel for the dedicated care team. So it is not like a WhatsApp group where you involve a lot of people who have nothing to do with the procedure, but with one press of a button, you can get the next layer of critical care team involved, be it the anesthetist, be it the interventional team. We've also integrated it in the North of Scotland AI radiology system and together with Brainomics so that we do not need to switch between different applications. I'm quickly going to show it to you on a video.
Raise your arms. Now I let go.
The vital parameters can also be transmitted. The stroke consultant now gets the call.
Turn to task. I will show through.
And can communicate directly with the paramedics. And do a targeted examination. He now thinks this is a high LAM score, and he alerts all selected team members. That is the pre-alert for the initial CT scanning, the diagnostic radiologist who will interpret the images, in our case the study nurse. And the interventional radiology team gets a pre-alert with the estimated time of arrival. Mind, we do not have the CT or CT angio yet. Anesthetists are pre-alerted here in this pathway, so that we do not need to wait for them, and we check if there's a bed availability, which is very UK specific. A bed is available, the ambulance comes, we can directly know where the ambulance comes, we can also direct where the team will meet. We've got several CT scanners, so it's important to have every members of the team. Images were interpreted. There is a large vessel occlusion. In fact, core was visible. It's going to go at pace.
We got the anesthetist on the line as well. We were trying to discuss whether we should do this with GA or without anesthetic. Patient's very cooperative.
Perfect, I'm on my way.
Running anesthetist on the way. Cath lab now being prepared whilst the patient is getting their thrombolysis. The angio is made ready. As I said, our aim is 9 minutes from decision to arterial puncture. In this case, high-grade carotid stenosis, and patient got a stent. Now, for the post-procedural management, we can involve in our case, ICU or the other ward where the patient will go, also give the transmission of the DYNA CT. And we can say that the case is completed and ask for the patient to be collected, and also give feedback to the team. Thank you. So what we looked is, did it make a real-world impact in our hospital? So we looked at the first, I'll call it the conventional period, without any AI tools in it. We first started introducing Brainomics. I've excluded the COVID period because that really slowed down something and it would bias the data. And then in February, we started introducing Pulsara in addition to Brainomics, with it being integrated. These are the cases, so unfortunately only 25, these are the cases that got thrombolysis within hours. so on the normal working days only, not in the night or on the weekends, because there we have a different pathway. And we looked at the door to CT time, and there was a significant improvement in our door to CT time. So in conclusion, it reduced the door to CT times, the door to needle times. There was a trend towards better outcome in the patients. We don't have enough yet to give significance for the data. It served to connect teams across organizations, because we have a lot of spoke hospitals who are from the islands or who are referring patients to us. So here again, very important that everyone has the same information at the same time when they need to know it. You do not want to be loaded with lots of potential cases that do not go ahead. You only want to have the relevant information, because you're likely going to stand in the cath lab in the middle of a procedure, and you just need to know the relevant part. Yes, is it a case, yes or no, and then know if the patient is, for example, on antiplatelet therapy in case you need to put a stent. It reduced the communication delays, it reduced near misses, and it allows us to securely share the patient information, and also it is possible to communicate between different EMS and hospital staff. Thank you very much. Our first experience with Moussala.
So thank you very much, Iris, and we are very thankful that you pushed forward all these things so that we communicate much better and faster. And I will also remind you that with an occluded cerebral artery, we are losing about 2 million brain cells per minute, not per hour, per minute. Certainly we have some billions of them, but nevertheless, time is very important. There's one question.
Yes.
Can you let us know the communication before we introduce Moussala? How many communications you had before you did it?
So the communication was a nightmare, getting everyone connected. We used WhatsApp, which is definitely not a safe tool for the communication. 58 messages was the average of messages to get the team together. Near misses when, for example, the CT scanner was full, and we needed to go to a different CT scanner. You have the anesthetist arriving at the wrong place, delays from that. Or if we say, because we do not have a dedicated angio room, we do the other procedures as well. So we need to say, procedure is going to be, or room is going to be ready in 20 minutes. If the procedure takes longer, no way of getting the whole team. In our team, we've got 70 anesthetists to participate in the on-call. And it is difficult to remember all the names and to know who is on call at that time. Here with the tool, you have the dedicated person who switches themselves on site, and the nice thing is it works across continents. I remember I was on a tiger safari in India when the first case was done, and Sanjay activated the case, and everyone said, oh, this is the bird that tells us that a tiger is coming and is imminent. Everyone be quiet. And that's when the alarm went off. And so it is possible from wherever you are to immediately see the images, have a quick look at the images, and get all the relevant information. And if you want, you can pull someone into the communication. If you say, I need help, Sanjay, give me a second opinion. What do you mean? I can just pull him into that conversation. The moment he's pulled in, he has all the information in one place. So it's the first installation in Europe. I'm sure there will be other tools that will come out. But at the moment, in a stroke service where it's not done by a very small group, I think it is such a way of avoiding near misses and to really have all the vital information.
So, when there are no further questions and comments, so there is some, please. And sing as loud as you can.
Thanks so much. Oh, that's a lot better. Thanks so much for this wonderful event and your wonderful presentations. I'm an engineer, and I'm very fond of all innovations in the world. After the stroke of my mother, my life was destroyed, of course, and the whole family. But the good result is that we already have a patient organization in Bulgaria. And I'm very much fond of this organization to go forward and change the plan and the situation in Bulgaria. And I would also ask Professor Aliosky to support me in this statement. We have regions in Bulgaria where there is no, and also hospitals where there is no, it's a lack of professionalists and experts. So is there possibility, or do you have good practice in combining these via telemedicine and all possible logistic good practices so that you really rely on good experts at the right moment to save time in the treatment time and period? So is there a possibility for the innovations to be helpful in the telemedicine in this case?
So I'll let you answer.
Because we have places in Bulgaria where practically and basically you don't have experts on spot.
Actually, in my center, we use VSI more than 1 year, and
Amazing.
this is the answer of your question.
So good, yeah. So there is already a step advanced.
Yes.
So there are different ways for telemedicine and different systems available. It is much easier if it is a stationary system in a hospital. You can have a big screen and you can do remote assessment of patients and to also make the decision for thrombolysis. For this communication tool, the advantage is that it is on your mobile phones where everyone immediately has access to it, or on an iPad or however you want it, with the possibility of immediately pulling members in. So it's specifically designed for emergency situations. There are 16 possible scenarios, so it's for STEMI, it's for trauma patients, sepsis. So it is meant as a communication tool within the complete hospital where you can pull people in by, I need the urologist on call. Yeah, I need the stroke physician on call. Yeah, so that you have if you don't know who it is, that you can pull them in. It also has the possibility of putting in the patient's or relatives' information, so that if we need guidance, for example, in a case where a lot of the brain is already damaged, and you're kind of wondering what are the wishes of the patient, because very often we don't have any information before relatives come in, it is possible to connect there as well. So the whole aim here is to streamline that communication process. With the software, the imaging software, there the aim is to have a faster interpretation of the images and basically have an expert opinion immediately available. The softwares have been validated against experts so that you will instantly basically have the result there. There's just been a very interesting study with implementation of Brainomics done in a large area in the UK where government has bought it, and they found that it increased the number of patients living independently after a stroke from 11% to 48%. So because it saves time. It's mainly about saving time. Thank you.
Okay, so, and when you don't have all these techniques available at the moment, yes, you can also organize it that the ambulance will call the hospital. I have a case, perhaps it is a stroke. Then the neurologist will be at the door of the hospital when the ambulance arrives and will see, oh yes, that seems to be a stroke. And also he has informed beforehand already the radiological department to keep one CT unit free and also to be prepared to have one angio suite free. So the patient goes directly from the hospital door to the CT, accompanied by the neurologist. When the CT shows, yes, that is a case for intervention, goes directly to the angio lab. Yes. And so even with these very simple means, yes, you can save quite a lot of time. Naturally, you might have a problem when there is an emergency case on the angio table, and then the next comes, and you have not only one angio suite, then that is helpful, then to go to another one, but when you have only one, then you are blocked for some time. Even then, all these techniques does not help, because you need then enough capacity with your angio intervention. So I will not give an additional talk. I will now advance in the program, and we will hear now what is new
stroke intervention.
in the stroke intervention, and that is
speech.
a pre-recorded
Yes.
presentation. So we will.
Adnan Siddiqui.
So Adnan Siddiqui from Buffalo, New
Yeah,
York.
it is already.
Hello, everybody in Sofia. It is my pleasure to be able to talk to you today about what's new in stroke. I really appreciate this opportunity to present to you, and I hope very much to visit one day your wonderful country and your wonderful city and get a chance to spend some time with the Sedokov brothers about the wonderful work they're doing. So without much further ado, given the limited amount of time I have, I will talk about what's new in stroke. Here are my disclosures. So what's not in the guidelines right now, and there are a lot of things: pediatric population, mild strokes, completed large course strokes beyond 24 hours, posterior circulation, distal and medium vessel occlusions, tandem occlusions, as well as adjunctive thrombolytics. So I think we made some progress in 2023, and I'd like to share that with you. So we have been doing a lot of different trials. Many have been completed. Some are still ongoing, including large core trials, distal trials, no NIH trials, as well as upcoming tandem occlusion trials. So start off with posterior circulation. 4 major trials published in the Lancet and the New England Journal from Japan, from China, from the United States, as well as from Europe and other parts of South America. And the basic consensus is that the outcomes are not quite as good in posterior circulation as they are in anterior circulation. However, when you look at the combination of all data, the modified Rankin score now 0 to 3, not 0 to 2, shows an odds ratio of almost 2 in favor of thrombectomy based on all the trials that are there. So it sounds like we can help these people a lot better than medical therapy, but basilars don't do as well as anterior circulation. The second thing that we learned this year is large core strokes. So we're really talking of aspects of 0 to 5. And when you look at the multiple trials, 3 have been completed: Rescue, Tesla, Angel Aspect, and Select 2. Actually, 4 has been treated, and the others are going to be presented or completed very, very soon and presented probably in early 2024. And again, if you look at the 3 initial trials, the American Select, the Chinese, and the and the Japan Rescue, again, odds ratio is even greater in favor of intervention. So odds ratio of 3 in favor of 0 to 3, and not only that, odds ratio of 3 in relationship 0 to 2. So this is really important. Note that there's no significant sort of increase in the risk of symptomatic hemorrhage, maybe a slight mortality difference, but not significant. So when you look at considerations large core, important thing to keep in mind is there seems to still be a dichotomy. If you went with aspect score of 0 to 5, and then looked at the populations within cores based on other perfusion parameters, it seems that when the core is greater than 70, the likelihood of a good outcome is not that good, despite good recanalization. But these numbers obviously are very, very, very small. The majority of patients, even in large core trials, had cores less than 70 cc's. So it's a new concept that's starting to develop that one needs to really appreciate, that there is an issue of core size in terms of how bad is bad. Then the next category is mild strokes, so NIH of less than 6. And here, ongoing trials, Endolo and Tension are still going on, but we don't have those results back yet. But we do have data from meta-analyses, such as this multi-center matched analysis by Raoul and cohort. And the important thing to remember interventional medical therapy, good outcome, 84%, best medical therapy, good outcome, 70%, with significance. Symptomatic hemorrhage rate slightly higher, but not significant. And again, aspects were quite similar. So important to note that these mild strokes, there clearly appears to be a deficit associated with best medical therapy. And this is represented again in these charts. So while zeros were the same, clear differences in MRS of 1 and 2, significantly in favor of intervention for mild strokes. Here's a meta-analysis of a very large data set, 138 mechanical thrombectomy and best medical 113. And when you look at, again, the outcomes in these patients, in meta-analyses, these are not quite that different. And so you've got to sort of think about, when you look at MRS, 3-month follow-up, quite similar, 0.29. So none of these really achieve significance in the modified Rankin score or any other parameters, suggesting that we do need the trials. And so we have got extremis, most, last, and endolo going on right now in Europe and the United States, and we'll see what those results look like. The next category to talk about is tandem occlusions. Very common when you look at populations, almost 33%, Mr. Clean, 20% with escape and revascat. And when you look at the populations, fairly sizable populations, there's Mr. Clean, and 30 small patients underwent stenting. And when you really look at escape, again, almost 20 patients. And the best outcome, the category where you have the greatest odds ratio, 10-fold in favor of intervention, is cervical carotid occlusion. So this is a uniquely hurt group with medical therapy and a uniquely benefited group with interventional therapy. And this is true not just for one trial, but revascat, again, shows the same factor, fairly common event. And when you look at the benefit, odds ratio of 4, higher than any other category of patients who are helped with tandem. I think it's really, really important to keep in mind that this is what's happening. And then let's talk about distal and median vessel occlusions. They account for 35 to 40% of strokes and can be quite common. We define them based on vessels which are 2 millimeters or smaller in size. I think that's a good definition to go by. You can have primary distal or you could have secondary. But just because they're small vessels doesn't necessarily mean that there's mild stroke. In fact, they are quite significant problems. So MRS of 3 to 6 and to almost 60% in some studies. And so I think it's important to know that almost 50% of these patients do not achieve recanalization with alteplase alone. To suggest that 80 or 90% are being recanalized for distal is not based on reality. And so what do you do? Because you can't really use those large stent retrievers in very, very distal vessels. There's a higher complication. So we are starting to get new devices. I think a lot of additional new technology features, especially in 2023, widely available, are new balloon guides, such as this Walrus balloon guide has been very, very popular in the United States, and now it's in Europe as well. And it really, the early data seems to really suggest that you have faster procedure times, better clinical outcomes, better recanalizations, and higher first pass effect with balloon guides than without. Other things that have been happening over the last year are catheters are getting better. We start getting bigger and bigger and bigger catheters, or the evolution of technology, so telescopic catheters, aspiration, variation with pulsatile aspiration, as well as new designs such as the telescopic catheters that I just talked about. This is the MIVI catheter, which supposedly, because of a larger volume available for aspiration, results in greater force being applied to the clot to pull it back. So here's an example of a 70-year-old presents with what looks like a clear M3 occlusion. It's dominant hemisphere, fairly significant deficit. There's a very clear cutoff, and this is the M3 or Q3 catheter being placed in the right place. And once we have the catheter in place, you can sort of see how this works. It's just go up and you catheterize the vessel with the wire. We used to use 14 wires, and then we went to 18, and now we're starting to actually go into 24, and there's the Q3, which is just riding up. And when it goes forward like that, it really means it's ingested the clot. So you gradually pull the catheter back. I like to have balloon guides for this. There's the balloon guide there. And once the aspiration is back, then we do a run, and we have beautiful recanalization of that territory with TICI-3 score. Other things, larger bore catheter. So that was a 3 French. This is now an 8 French guide. And to demonstrate, this is a 71 catheter over a microcatheter, and now the 88 guide. This is the imperative care zoom catheter, large distal platform being brought up over the 71 catheter all the way into the MCA for direct aspiration of the clot and local flow rest. So when you have an 88 catheter in the MCA, it obviates the need for a balloon guide in the neck because it's so big. When you apply aspiration, the vessels stick to it and you have complete flow access control. Here is one last quick case that I like to show of a patient who presents with an M2 occlusion, and it looks exactly like the one that we talked about. So we start off with a Zoom 55 over a microcatheter, and this is the 88 catheter sitting in the MCA, and we open the vessel, and now we've got greater flow, but now we have even further distal occlusion. So now we're going to go with a 45, again, over a 25 wire, and there's 45 has gone all the way up. Again, we have track start in the MCA, so no need for balloon guide, and aspirate it out. And we have now the Q3 catheter going all the way to the distal vessel, and with complete recanalization of the patient. Lots of stent retrievers are on the market, but what's really new is the new Tiger retriever, which really allows you to go up and down in size. By doing that, you can really vary the size. So you enlarge, you capture, and then slightly reduce the size as you pull the catheter back. These are designed for large all the way down to medium and small vessels. The large ones have been approved through trials in the United States. The small ones are being evaluated specifically for distal occlusions currently, especially the Tiger 13, and we'll sort of see what those results. The trial is enrolling very, very nicely, and there are ongoing trials such as the distal trial that I just talked to you about, which is using it's randomized using the Tiger retriever. So I think thrombectomy is the gold standard, no question, up to 24 hours, but indications keep expanding with several positive trials. Ongoing trials will further address these populations. I suspect soon it'll be thrombectomy for everybody who has a large to medium to small vessel occlusion. As our tools get better, I think thrombectomy is going to really become even more popular and more effective as we go forward. Thank you very much for your time and attention. Appreciate it.
Great. After we've now heard what's new in 2023, I'm happy to continue with innovation and to announce the Satellite Symposium about non-stop innovation, pipeline vantage, new generation of flow diverters. And it's my pleasure to announce our speakers, and that is Dr. Alioski, Dr. Zirokov, and Dr. Velinov. Thank you.
Thank you.
Hello, everyone. It's a great pleasure for me to be here, and I would like to thank Professor Petrov for the invitation. Well, I would like to say a few words about the Vantage. Well, Zarko, I can finally say Vantage is here. I've been hearing on all the Medtronic training events, why do we put Shield and you don't put Vantage? So the fourth generation stent is already in Bulgaria. What does it give us? More control, precise delivery, promote flow diversion effect, and of course, shielded by science. This is the history of the first, second, third, and fourth generation pipelines. You see from 2008 to 2014 with the second and third generation pipeline, Europe is leading. And in 2021, we have the fourth generation pipeline Vantage. What are the advantages? The delivery system recapture is different. Delivery force through tortuosity and straight line is very good. Distal braid release from the EPTFE and overall ease of deployment and resheathing. You can see here that while for the Shield and the previous pipelines, we had to use a larger delivery system. Here with the Vantage, we have possibilities for 0.021 inch delivery system platform with a 0.018 inch pusher. And for the larger stands from 3.5 to 6 millimeters, we have a 0.027 inch delivery platform with a 0.023 pusher. So this allows us to deploy smaller flow diverters in vessels where this was not possible before with the other generations of pipeline. So the delivery system design, we have three things which are important. The single core wire design is novel. There is a novel resheathing mechanism, and there is a redesigned distal end. If we look at the pipeline flex, we have a separated bumper with a hollow hypotube and a 0.20 inch pusher for all diameters. In the pipeline Vantage, we have an integrated bumper with a continuous core wire. And as I said, we have two different systems. For smaller stands, 2.5 to 3.5 millimeters, we use the 0.21 system. And for larger stands from 3.5 to 6 millimeters, we have the 0.27 system. Advanced resheathing mechanism, we have protruding fingers of the laser cut stainless steel hand. They engage with the proximal pores of the braid. This allows for resheathing and repositioning of the braid, and the advanced resheathing mechanism is freely mounted onto the delivery wire. Platinum markers indicate the point of no return on the delivery system, and once the point of no return is passed, the braid is deployed. The silicone elastomer disc expands over the resheathing mechanism, and the expanded silicone elastomer disc prevents the resheathing mechanism from engaging with the pores of the braid. Another advantage, 44% thinner EPTFE sleeves, which allow improved distal braid release and ease of recapturing the sleeves with the microcatheter. If we look at the consistency of pipeline flex and pipeline Vantage, you can see that while pipeline flex had 75% cobalt chromium wires for radial strength and 25% platinum, the integrated wire design of pipeline Vantage utilizes drone-filled tubes with cobalt chrome, shell, and platinum core. There is an optimized wire count. The pipeline flex has 48 wires for all braid diameters, which means all stands from 2.5 to 5 had 45 wires, and the pipeline Vantage for the 2.5 to 3.5 millimeter stands, we have 45 wires, and for the larger stands, we have 64 wires. So this is optimized wire count in the structure of the stand. So all these improvements in the engineered scaffold provide optimized pore density, implant wall thickness, wall apposition, and outward radial force to promote the flow diversion effect. The outward radial force, or the so-called chronic outward force, it's practically the circumferential radial force that the stent has while exerting and deploying in the vessel. It is extremely important. And you can see here that compared to many other stents, the pipeline Vantage has a very, very strong chronic outward force. Shield technology, already known, but I think it is something extremely good, allows us to put these stents even in patients with hemorrhage, less thrombogenity. So the covalently bonding phosphoryl to the surface implant actually achieves this scientifically proven effect. So this is, again, in the advantage as we have in Shield. Traditional coatings, this is just an example to show that they are adhered to the substrate by physical encapsulation through a process of dipping, spraying, or brushing, while Shield technology is a surface modification adhered to the implant by covalent bonding. Thickness of Shield technology is less than 3 nanometers, which means 0.01% of one braid wire. The impact of Shield technology reduces the material thrombogenicity, promotes endothelialization, and improves performance. And I would like to ask Dr. Alioski to come here and continue. I try to do my best to be very fast. And then Professor Sirakov.
Okay, thank you. I would like to show that the case of 62-year female with slight light hemiparesis, headache, and vertigo. Comorbidities: hypertonic and very bad smoker, small right MCA aneurysm, and left PCOM aneurysm. But the patient was admitted with strong headache. Initial CT scan shows big right MCA aneurysm, but we think that it was partially thrombosed giant aneurysm. For this reason, we do also MRI, and we find that yes, it is giant partial thrombosed aneurysm. For this reason, we're planning to do flow diversion with partially coiling of aneurysm. So the procedure was done with general anesthesia, 8 French long guiding sheet, 6 French distal access catheter, and 2 microcatheters, one smaller and bigger one for the delivery of the stent. This is the initially, it is initially conventional angiography. So we success to catch the MCA aneurysm, MCA artery with 2 microcatheters with omega loop through the aneurysm, because I think that it was dissecting artery, dissecting aneurysm. And after the deployment of the stent, yes, this is the beginning of deployment, we put the coils into the aneurysm to avoid the delayed rupture of the aneurysm. This is the final angio, and the question was, should we do the balloon dilatation, because we see the shrinking of the stent in the zone that we think that it's desiccation of the ICA. The reason was we don't do the balloon because we think that the new technology of pipeline vintage has a bigger radial force, and for this reason, and we are happy with the result, and for this reason we don't do the balloon dilatation. This is the patient was okay, and without decreasing of neurological deficit. This is the next day video of the patient post-operative, and this is the 2 weeks, I think, after the procedure. We see the shrinking of aneurysm on the post-op MRI. This is the first post-op MRI. Without contrast into the giant aneurysm. So, thank you for the attention, and Miro, please.
You show the follow-up with MR and with contrast,
Yes.
because it is not the conventional way with Raymond-Roy classification to look for an aneurysm if an aneurysm is occluded. Very often in flow, probably you could just explain.
It is our protocol for follow-up the patient with MRI angio. Thank you. Miro, please welcome. Thank you.
Greetings, everybody. My name is Danimir Sierakov, and I'm going to show one case we did with the new Pipeline Vantage. We have previous experience with the previous version. We use a lot of Pipeline's competitors. So in this case, I'm going to show and present. I had ordered the longer stent the new generation provides, 6x50. So I thought if I had a case in which I will need a bigger length, for example, some fusiform basilar aneurysms or something like that, I had this implant already in my department. So there is a patient in her 60s with some visual symptoms, came to the department, so we do the MRI, we saw a large aneurysm on the left ICA, which expands, and of course the mass effect and the compression of the two optical nerves was the reason for the visual symptoms. So when we do the DCA, we do our measurements. Our initial strategy was to put 2 or 3 stents in a satellite fashion, but we, like I mentioned, we have already ordered this big device 6x50. So we try to use it in this case. For example, the measurements at some points of the internal carotid was 6.5, like in size. And you can see it's like a dysplastic portion of the aneurysm before and after the aneurysm sac. So our concern was to use a longer stent. Here we need around 40 millimeters of length, but we were thinking about this dysplastic portion where the size were really large, like 6.5 millimeters in diameter. So I thought it will be useful to try this Pipeline Vantage, in this particular case 6x50, like I mentioned. So we decided to start, this is the navigation of the procedure. We put the guiding catheter, I think in this case was the Chaperon 6 French, and we put additional distal access catheter, Sophia, also 5 French, I think 115 centimeters of length. For stability, like maybe most of you know, when we use a large implant, sometimes there's a lot of rigid deployment, and every physician and operator should have this additional support with the distal guiding catheter. In this case, like I mentioned, Sophia 5 French. So this is the 3D, like you see, this is a large dysplastic ICA. 6.5 was the most of the size of the vessel we need to cover with the stent. And the initial strategy was to start, here are the measurements, was to start from the M1 segment, just before the MCA bifurcation for stability of the implant. And this is the measurement we had with the 615 we already had at our department. So this is the navigation, nothing particular. We managed to pass quite easily. You can see several attempts inside the aneurysm sac, then the guide wire became on this J form, which was easier to pass through the aneurysm and safely reach the M1 region of the left middle cerebral artery. Maybe you didn't see, but the catheter is 27 phenome, 0.27-inch catheter phenome. And this is the navigation through the aneurysm. I didn't put it on faster, so you can see that just after several attempts, it was easier. We didn't even change the shape of the microcatheter. It was from the first tries we had. I think the guide wire was synchro. So here you can see form the J shape, and you can just navigate through the MCA for stability. On the lateral projection, you can see the bifurcation we reach. That was the plan to start the implant. Distal position was to start just from the bifurcation. That's why we navigated in the bigger lower segment of the M2 and deliver the microcatheter. You know the tip of the stent is around 30 millimeters or less. So we think it will be stable enough just to put here the guide wire and the tip of the stent, and we can start delivering from the bifurcation. So the microcatheter is at the desired position, and we will navigate with the pipeline vantage. You can nicely see where is the tip where from the stent should begin with the sleeves of the markers, which Professor Velinov showed. So we are still at the lower bottom. You can see MCA M2 segment on the lateral view, and this was the strategy to place stable the tip of the stent. I can say, compared to the previous experience we had, this big implant 6x50, this is the first flow diverter at this size I put in my hands. It was quite easily to put through the 0.27, so maybe this is the benefit of the new generation of the pipeline. So here we just open the sleeves, and you can see on the lateral we are satisfied that it's not in the lower branch of M2, but it just passed the bifurcation. And you can observe now very nicely deployed with the push and pull technique. This is the segment of the M1 I really want to deliver the stent for stability later on, because at the level of the Sept, I was able to push more the stent. You can see on the bolt projection, and I can feel safely myself that the implant is correctly opened, and most important, it's not protruding through the aneurysm. Sometimes, with the other stents, we can see this sausage form, sometimes bulging inside the aneurysm sac. So here it was easy, in my opinion, because of the stability of the M1, and you can see very nicely it's just opened at the cavernous segment. Now I realize how long I have left from the stent. Like I mentioned at the beginning, I ordered it because I really want to try in a fusiform case, maybe 6x50. We don't have any other competitor which provides 6x50 flow diverter stent. So here you can see several maneuvers just to pop and open correctly the second curve of the stent. Because it's a bigger implant, the chance of not good opening or some twisting, it's possible. But I was very gladly that it didn't happen. Just 2 maneuvers, you can play with the system. Applying a little force at the microcatheters, you can reach this opening at the level of the curves. So already the second curve is opened. You can see it's a real life. We didn't fasten the movie, so it was like a 10 minutes case. And here you see the big tension left of the last fourth quarter of the stent portion. So he was a little bit concerned, should it open correctly and pop? But you can see just a little bit applying of the force of the microcatheter going back, and the stent opened correctly. So most of the time our protocol is to go through with the 0.27 inside the stent just to know it's correctly opened, and if something bothers us, we can go for angioplasty. Or we lately do a lot of Comaneci angioplasty. It's easier because you don't navigate second time with the balloon, you just put the Comaneci inside the 0.27 and you can expand correctly. So here we're going through the 0.27, you can see it's fully opened. because I have enough distal and proximal portion covering the aneurysm neck, I here let myself go through also with the Sophia. You can see we go with the Sophia through the whole implant. And it was a very stable, very, like I said, comfortable feeling to go through with the Sophia. So we here completely, the distal tip of the microcatheter is completely out of the stent distally. So we retrieve the wire of the stent. And it's correctly open everywhere. We just checked. And also at the final angio, we didn't see any distal thromboembolism. You can observe very nice stagnation of the aneurysm, but with so long proximal covering, it was not a surprise. So that was our first experience with the new Vantage. Thank you.
So thank you very much. What I have done differently is first place a microcatheter into the sac of the aneurysm and then do the procedure. And so at the end, I could call the aneurysm protected by the stent.
You do it this in like a protocol
so
in every case?
So you need 2 access sites naturally, yes, because you...
And when is your guidance, when is your criteria that these aneurysms you're going for coiling and stent instead of only flow?
Yes, you cannot do a primary coiling, otherwise the coils will drop out and will occlude the artery.
My occlusion is maybe you're concerned about delayed rupture, that's why you're going to put a coil, or?
Yes, that is the reason why.
Here our concern was about the patient's visual symptoms. So we decided maybe it's better if you will induce some inflammation at the beginning, but with a good medicamentation therapy, maybe we're going to reduce the size of the sac faster compared to when we put additional coils inside.
I had to say this after Nufet's case. This is a warning because in Ankara, we did a lot of work to develop this Vantage. And actually, I was very proud of the product because I agree with you, the best opening, the much easier push. But the problem is to be able to do that, the engineers of Medtronic lessen the amount of chrome cobalt. So we have actually much less CRF than regular pipeline sheet. And kind of turned out to be a nitinol flow diverter in ICA. And we have seen early stroke cases, especially in ICA aneurysms, because material was collapsing like a Silk Vista or other nitinol stents. That's why I like to warn you about this, because this is your early experience, and especially if you see like this, you should be doing a PTA. I mean, even with after perfect opening, good adjustment, I have seen 5 cases out of 65 stent collapse and early stroke. That's why I quit using pipeline Vantage. I just use for when I need a large size, like 5.5 and 6, or I use for distal aneurysms, like M3, M2, because, 21 catheter deployment. But be careful. I mean, I strongly suggest you still use the good old chrome cobalt braid in ICA aneurysms.
Thank you for the
standard cases.
Thank you.
Vajte.
Do you think, in your opinion, after performing a PTA of this nitinol kind of stent, you're going to prevent future collapsing of the stent? Because I have this bad experience with the new P64 stent, which is very soft. We put it and we see the collapsing after 7 to 10 days.
Yes.
So the PTA at the end of the procedure won't prevent, I think, in my opinion, longer
I agree. That's why I'm saying that it turned out to be like a nitinol stent. Because, you make it... The problem was we were asking from industry to push easier things, okay?
Yep.
But this is a problem, actually. We have to have some difficulty to be able to have the geometrical modification, which I'm just going to allude in the afternoon, okay?
That was our thinking, and our resident, one of our residents now, his research is just with that field. When and how reacts the most of the time ICA carotid wall when we put different radio force stents, because he is starting to do a single shots on the 3rd day, on the 7th day, and in some P64s, in a younger patients which are very reactive, you can see this collapsing very fast. And we are still thinking about the idea of suffocating some of the receptors of the muscle cells inside the intima, or the other is the reason. And are we going to observe this phenomenon with a more stronger radio force stents? So it's a balance, like you said, it's easier to deploy, but you have to think about how it will behave the stents in maybe younger, more reactive patients. This is just our theory for now. We didn't know that that's the criteria to observe this phenomenon or not.
My fear in flow diverters is always the redirection of flow. So even an aneurysm that has not ruptured and is probably held together only by some thrombus without even a membrane around it, when the flow is redirected, the pressure would make the thrombus disappear. And an aneurysm that hasn't ruptured for years, because it is now not held together by the thrombus anymore, because of the redirection of flow, could lead to rupture. I'm just wondering, with your experience, do you coil, what percentage of aneurysms do you coil and put a flow diverter in, or do you go for flow diversion directly without coil, just as a shared experience?
Like before 5-6 years ago,
Yes.
we listened to our teachers,
Yes.
which suggest above 10 millimeters you have to coil. Or the idea or the criteria then was larger aneurysms produce larger inflammatory space, so you can lysis the wall of the aneurysm, it could rupture, delayed rupture.
Yes, yes.
So
delayed
the
rupture.
criteria then was above 10 millimeters, we try to coil. Then the strategy changed. Like our Turkish group suggests several years ago, if it's big enough, I really like just to coil with some adjunctive device, Comaneci balloon, to wait 30-40 days. So they suggest you change this red thrombus inside the white thrombus.
Yes.
And then you put a flow diverter, if it's possible, so it's very less risky to have a delayed rupture.
Yes.
And nowadays also we think a lot about the medication therapy. If you do a perfect anti-inflammatory, anti-edema therapy, I have like more than 20 cases above 15-20 millimeters directly with flow diverter with no delayed ruptures. Maybe we are just lucky. Our series is too small. But my first strategy, like my team knows, if I can coil, I coil the aneurysm, bigger aneurysm than 10-15 millimeters. I wait 30 days, you change the inflammatory process around the coils, then you put. Don't do it in one procedure like they suggest us several times.
To avoid the late
because
rupture.
Professor Çekirge showed us, I was very impressed several years ago, perfectly coil aneurysm, large aneurysm on, like he mentioned, I think his resident's mother.
Yes.
And they put the flow diverter, but you cannot see a free space inside the coils. And he showed us a delayed rupture.
Iris, it's a very, if we go into this discussion, it's not going to finish, so I'm just going to finish it. Even with tough packing, we had bleedings.
Yes.
So this anti-inflammatory reaction is just happens person to person. So finally, we find the best approach. Just balloon remodel, wait for regrowth,
And
6
then
months, then put a flow diverter.
Okay, so we want to go forward. And to go forward,
Thank you very much. Thank
we
you.
need
It was
a
really
speaker
interesting.
who will talk about going forward. And therefore, I ask now my old...
Did you want to say something?
I just wanted,
yes.
if possible, for 1 minute,
sorry,
because
yeah.
the Vienna team has also a very large experience with Vantage and Shield, so I wanted the opinion of Professor Vajte.
Piotr, if you could come
Thank you
already.
very much. Just short comments from me. We switched to Vantage very early. So meanwhile, we'll also collect about 60 cases so far. And we were aware about this problem that it will not open sufficiently. But meanwhile, with in our experience, we have not this problem of collapsing. But of course, everybody wants out. You have to take care about this. But our experience is that you can deliver it very easy. It's a huge advantage for somebody who is not very familiar with it. But the results are very acceptable.
Thank you.
So yes, because we are running out of time, yes, we are already above the normal limit. And so it's now a pleasure for me yes, to announce my old friend and colleague Piotr Moussala.
Thank you so much. Thank you for your kind invitation. Thanks to Ivo, thanks to the organizing committee. It's a real privilege to be with you here today. My task is not an easy one because I'm supposed to bridge what's been said already and what some of the things that will be said in the afternoon, during the afternoon session, and really try to wrap up the concept of how to best deliver mechanical revascularization in stroke. So how to apply the tool that is available to benefit the patients, because as you will see, the size of unmet need is really, really large. So stroke is the most common cause of complex disability, a major cause of death worldwide. We all know that. Stroke is not a disease of a neuron, but stroke is a vascular disease of the brain. So stroke requires vascular management. And the strokes we're all focused on are large vessel occlusion strokes. There are more than 15 to 20% of strokes. You look at different series. Nick Hopkins shows even up to 40% of patients, all-comer patients with ischemic stroke, may be eligible for mechanical intervention. So today we do have an effective treatment that saves brains and also saves lives, that reduces the misery of the patients, stroke-affected patients and families, but we largely fail in application. And although, you know, there's been congresses and conferences and everybody's from the Hermes meta-analysis Times talks about how treatment is implemented and where the successes are. The estimated number of thrombectomies, stroke thrombectomies that should be performed are 310 per million inhabitants. How many inhabitants in Bulgaria? 6. So 6 times 310 is 1,800 thrombectomies. How many do you do now per year? So nearly 2,000 you should be doing. Sorry? 52 last year. Okay, there's nothing wrong with you because we have the same problem in Poland, but you see the size of the gap, yes? So it's 62 versus the need of nearly 2,000 thrombectomies that should be performed in Bulgaria. And there's different analysis and different maps. You see that the green part of the world is very small. And even if you look at this publication from Circulation this year, you see where one of my best friends, Alejandro, is. With all the great things he's been doing, you see that Argentina is in the same color as Paraguay or a Poland, yeah? So despite all the individual teams and individual institutions' efforts, the overall situation is really bad. The glass needs still a lot to be half full. What are the two fundamental limitations? The two fundamental limitations is shortage of operators and shortage of centers. This is recent data from Europe in the European Heart Journal. You can see that the goal should be 100 to 160 mechanical thrombectomies per 1,000 ischemic strokes. And even the best ones, like Germany, France, Switzerland, they do about 50. So it's not only those countries that are really trying to catch up, but it's also those theoretically countries with well-established systems that still should be doing better. Obviously, you know, it's a cliche now, time is brain, we all know that, but it's worth repeating because even if you talk to very experienced friends in neuroradiology, they tend to sometimes forget that the 90% chance of good clinical outcome is within the first 2 hours from the onset of the disease. And transportation here plays a very important negative role because still in many countries, the patients travel 100 kilometers, 200 kilometers. You know, there's a huge delay with transportation. There's strong data now on that. So even if at the end of the day, they have an effective opening of their M1, radiologically, this opening of the M1 is no longer effective clinically. That's why local treatment or quality treatment as close to where the patient gets the disease is really of key importance. There's 2 clocks in stroke management. There's a physical clock that we unfortunately cannot change, and there is the tissue clock on which we have some influence.
and you share both of the clocks with your patient. So from the point you hear about your patient, you should really bear in mind this physical clock and the tissue clock, and both of the clocks are in your hands. In stroke, imaging is nearly everything, because then you have to safely perform the procedure, and there's also post-procedural patient management. But imaging is of key importance, and it's not that somebody who's, say, experienced in coronary PCI or peripheral interventions will just jump into stroke treatment, because, and this is one of the fundamentals of VIST, you need understanding of imaging. You will not interpret all the images yourself, but you need to know what to expect from CT, what to expect from diffusion weighting MRI, what to expect from FLAIR, and how this information is supposed to affect your decisions regarding your patient. So you need to understand imaging, and that's one of the key things for VIST. This is one of the patients that really was the last drop in our decision to start management. This is the patient whom I was asked to consult 4 hours after cerebral large vessel occlusion. You can see still at that point good collateral circulation. Collaterals do exhaust with time. The patient was declined by level 1 stroke center, comprehensive stroke center. The travel time there is over 100 kilometers, more than an hour, taking logistics 2 hours, 4 hours from the onset of disease. They said 6 hours, we would not take the patient. So instead of being treated according to what we know today and what we should be doing today, what was done is the observation of the natural history of the disease. And of course, this is the natural history of the disease. The patient is disabled now, and this was a salvageable brain and a salvageable patient. So the treatment, when it can be delivered safely locally, it should be delivered locally, and the way to do it is to find people who will help you to develop a safe treatment protocol on site. So symptom onset to first medical contact, you can do public campaigns, transportation or transportations. These patients, unfortunately, often travel from one hospital to another, then to another. Imaging and decision-making, time to procedure and procedural time. These are all the key elements. And of course, today it is clear that transportation, if somebody tells you, yes, we will treat this patient in this great center, we have one center in the capital of the country, and of course we can cover all the strokes in our country, this is not true, because transportation is unethical. There's a huge body of evidence now, this is just some data from Adnan Siddiqui group, showing that transportation kills brains, even if that you can open an artery later. So 2 levels of centers, comprehensive stroke centers and thrombectomy-capable stroke centers, and it's really those, you can hardly affect the number of comprehensive stroke centers, because our colleagues in interventional neurologists, they are focused also on aneurysm work, they're focused on malformation work. And if they start to be doing a lot of strokes to meet this demand, this will also dilute their skills and their knowledge in what remains the core of interventional neuroradiology. That's one of the big issues being discussed, for instance, in the States now by the commissions that decide, how to best balance the needs to the level of needed training. So 2 different levels of centers. Now, obviously, it's clear that level 2 centers have only optional neurosurgical services, so it's not that you do need to have neurosurgery on site to treat strokes. How many centers are needed? It's estimated between one per between 500,000 and 1 million centers. One of the very important things that VIST offers is quality control and quality assurance. VIST can help you develop local standard operating procedures. This is an example from our hospital in Krakow. You can see local standard operating procedure, management of patient with acute LVO stroke, how this SOP is prepared, verified, and approved. And this SOP was developed with the help of Professor Grunwald and other people who came from VIST. They looked at our local logistics, what are the needs, what is needed to link the imaging, neurology to the cath labs that can perform intervention, and that's what ends up to center-specific standard operating procedure that then can be followed. So algorithms and checklists, and only appropriately trained operators, only appropriately equipped cath labs. It's not that anyone can jump onto stroke thrombectomy because they say, I want, so I will do. No way. There needs to be an established system, and you need to be safe to do that. So quality control is really important, and that's also raised by now the VIST guidelines. So we have algorithm checklists on the one hand, on the other hand is your patient. So what matters to your decisions? Baseline clinical status, very important. Years ahead, quality of life ahead, what MRS they are starting with. Where is the stroke located? How badly it will affect the patient? How much is salvageable? How much can I save? What is the core? What's the penumbra? How much can I make worse with my interventions? Because not all interventions are obviously successful. And finally, what matters in my decision-making is what would I want for my mother, father, sister, and for myself, finally. So all those considerations are really important. VIST can help you tailor those to your local situation and your local effects. This is a first pass effect in a case that was proctored online by Professor Grunwald. You can see patient with acute pulmonary embolism. There's a crossed embolus occluding M1. As you can see here, patient received RT-TPA in the admissions room, then brought straight after CT imaging to the cath lab. You can see M1 occlusion with JET 7. We achieved first pass effect. Iris, I think you remember the time I called you. That was more than 2 years ago now with this case. And now whenever we need, I know that there is a patient in VIST, a person in VIST that I can call and consult if in doubt regarding the patient management. For those who come from the coronary territory, and there's some people I know here, it's really important to remember that cerebral artery is not a coronary artery, stroke is not an MI, and mechanical thrombectomy is not a primary PCI. So it's not just that doing one, you can think, now I will be a neurointerventionist. No, you will not be without appropriate training, without appropriate support. So what stroke intervention puts together is symptoms and imaging and local logistics. And this is where VIST comes and where VIST can help you. Carotid artery stenting competence is important because for those who have experience in carotid artery stenting, their pathway to stroke thrombectomy is shorter. Obviously, they know how to reach the vessel. And also, they already have half of the knowledge, at least, in treating tandem strokes. And tandem strokes are up to 30% strokes, so it's a large portion of strokes, a lot of tandem strokes, and a lot of carotid-related strokes with carotid lesion only do not reach neurointerventional stroke centers. That's a topic for a separate discussion, for a separate talk. So this is where people coming from the carotid stenting world can bridge to stroke management. This is one of our cases, as you can see, the large diameter stent reaver that was used to open this carotid and to stent it with a micronet covered stent with an excellent long-term result for the brain and also for the patient. Like I said, a lot of patients do not get treated mechanically, especially those with carotid occlusions. Those patients do not belong anywhere. Some people say vascular surgery, If they do well, maybe stenting. But a lot of patients get untreated during the acute stroke, and obviously treating those patients, you can see here a thrombus-containing lesion on your right, obviously makes a huge difference to the outcomes. You can see MRS in the untreated and a series of EMR-treated patients. The pillars of training are simulation. You've heard about this in the morning. Standardized protocols for simulation training. This is part of also of the operator certification process. It's important for new operators, for lower volume operators in centers getting established, but also continued refreshers and for quality assurance. So that's, I don't know what systems you have in your hospitals. For instance, in our hospital, you have to do CPR course every year, once a year. Although we all know it, we do it, but you need to refresh. So simulator allows you to refresh and also to feed the data from a specific patient into a simulator. Calavoric model training has been covered by Iris, a very important new opening for training and also for device testing. So in the fight with the two clocks, really, even if you really do your best to make use of the green clock, it's important to remember, and it's really important for those in your hospitals who will be criticizing you. They said, okay, we opened this service, and you know, this patient did not well, that patient that died. You know, this is the reality. The reality of stroke management is that really you can only make some more faces green, but never all your faces will be green or yellow. Here, as Mr. predicts, that's other scores. So this training consists of clinical and procedural skills. Both are needed, both are needed. It includes simulation for difficult scenarios, complications, real-life cases that can be fed, utilizes artificial intelligence and digital communication, as you've heard, and most importantly to me, it is tailored to site-specific and operator-specific needs and logistics. This training and support, it works, it is safe, both for the patient and for the operator and for the hospital, and it is effective. These guidelines now are up, you've heard of. Obviously, we can't change the physics, but with the help of VIST, you can make advantage, you can benefit from the tissue clock in your patient to replace the destiny, the misery of the patient with, in many patients, good clinical outcome. So this is our adventure with VIST. You've heard from Alejandro how they progressed. This is also how we progressed. And this is just to tell you that I'm not talking about something, you know, this is my last slide. Yes, I'm finishing. This is the case I did just before coming here. You can see a stroke in evolution, a 69-year-old patient, proximal protection, flow reversal, something we'll be hearing from Dimitris more about. And this is the final result with a micronet covered stent, by the way, bridging to the symposium we've just finished, well embedded into the wall. You heard about problems with flow diverter, if it hangs in, that it can collapse. Here, what I did yesterday, I used 5.5 balloon, 20 to 22 atmospheres pressures to really well embed this stent into the wall to get a lasting effect of endovascular revascularization. The patient is already home today. Thank you very much for your attention.
So, Piotr, thank you for the
Thank you.
interesting presentation. In the matter of time, I suggest to skip the presentation of Iris and Ivo. And I want to introduce my good friend from Serbia to speak about the treatment of stroke in Serbia.
Hello to everyone.
Please.
I would like to thank the organizing committee for the invitation. It's wonderful to be here with the friends. So without further ado, if we get a presentation, we can go on. So what is the situation in Serbia? You can see that this is the global incidence. In the developed countries is less, and you can see Serbia is 270 per 100,000, so we have a bit of epidemiological crisis, and also the younger patients are coming for thrombectomies, which is not good. We have 7 million inhabitants. We have 5 comprehensive stroke centers plus 1 that is not completely comprehensive but does the thrombectomies. And in Belgrade, which is the capital, we have these 2 comprehensive plus 1. In Novi Sad, Niš, and Kragujevac, we have 1. You will see it's very well distributed. This is 1 in Vojvodina, then Belgrade and the region, 3, then 1 here and 1 here. Maybe we will need in the future some for example, some 1 or 2 here. So we will cover everything very nicely. In Belgrade, we have 2 million inhabitants, meaning 2.5 million catchment area. So what is the situation in Serbia? So we can say that the procedure is approved, is completely reimbursed, no national strategy for now, but it's on the way, no registry. It's very difficult for the registry. And then I can say in Belgrade we do 100 cases per year. In Novi Sad it's around 45, 50. In other cities by 30. It's not sufficient enough, of course. You can see that estimation is 1,040 thrombectomies per year. So probably the patient come too late, which is this pre-hospital phase, and then in hospital phase the same problems as you mentioned before. The stroke organization, as you know, depends on the local geography. In Belgrade, so I said 2 million inhabitants, 3 centers and 3 stroke units. This is a case from Paris. You know, when it's the time to be on call, they switch and they have this 4 region, and they have a rotation. Every region of the Paris is 1 day that is on call. So that's how they put up with the pressure. Here in Belgrade, we did something similar, but with asymmetric rotational. In my hospital, we do 4 days. In the other hospital, 2 days, and the military academy 1 day. So we switch, and the emergency knows which day is for each center. So of course we work in parallel to save the time. We don't have yet this artificial intelligence. We're on the way for this, but we use very well the Viber WhatsApp group. It functions. It's not bad. So the neurologist receives the patient, neurologist that is there is his shift, and then he sends us the pictures. He informs us. We're waiting for the pictures. We have then discussion with a common decision, and then in case of disagreement, of course, we convince each other but not fight. How to save time? Also, direct admission to stroke patient into the dedicated emergency department. We don't have that yet. IVT pain is CT. No, we don't do it yet, but it should be done probably. For drip and ship patient, we usually don't repeat imaging, of course, unless the patient worsens significantly, only get better significantly. And then we try to progressively privilege mothership. You saw this small country, so everybody can come to the comprehensive stroke center in 1.5 hours or 2 hours. So what we need, technician, nurse, and interventionalist, anesthesiologist on site. We don't have that, I must say. We do it in local anesthesia. Only when we need general anesthesia, we call an anesthesiologist. We manage the high blood pressure by ourselves, and if things get rough, we call them. There's not enough anesthesiologists. And then we try to avoid the general anesthesia because they're not that skilled in keeping the blood pressure up. So every time the blood pressure drops 90 for the systolic, and then it's a problem for the penumbra. We have 2 biplanes, 1+1 hybrid, and then this one would be used for the thrombectomies we share with cardiology. And it's another facility that deals with the urgent patients. So we do the CT, CTA, and the CT perfusion for the cases that we don't know the time when it began. And we do the most, as I said, under local anesthesia. We do CT the day after, or MRI, and adopt anticoagulation if there is one. And this is very important, which we adopted from the very beginning, that we try to maintain the high blood pressure between 140 and 180 systolic during the intervention, before the intervention. If we get recanalization, it's always aggressively put down below 140, not too much, but below that, and that kept us away from a lot of parenchymal hematomas. So of course, as I said, the perfusion for the wake-ups and with the stroke, and we don't care if it's tandem lesion, we do it, of course. What are the numbers? In our facility, okay, we were from 2006 doing the aneurysms, AVMs, so hardcore neurointerventions, and from 2018 we started doing thrombectomies. Now we're on 130 per year. We should go up, of course, and 2/3 of them are done outside the working hours. These are our numbers, and I can just highlight some importance. IVT is only 17%, but should be 60%. Like in developed countries, and we can explain that the patient come late and they're outside this hour for the intervenous thrombolysis, and also the patients are usually not very well, and they have some adjunctive diseases. Also, you can see door to AP, it's 130. So we should be, now I think we are below that because we have new facility with scanners, CT and angio, and everything is in a range of a couple of minutes. And I was in Toulouse with Christophe Cognard and Christine Group, and we compared their first 2 years of thrombectomies and our first 2 years. And you can see that there's not much difference with the MRS 0 to 2, 43%, 41% compared to 50%. But where the major difference is in mortality. You can see very high mortality. Now there was in the first 2 years was 29%, or almost 15% above the Toulouse group, and then now it's around 23%, but it's also high, and meaning that the patient that gets thrombectomy in Toulouse or in Belgrade has two times more chance to die. And why is that? Because stroke severity, of course, and comorbidities, our patients are very fragile, and there is the basic population health is not that great like in developed countries. So we're very vulnerable population. You can see that in a resilience study of Brazil, the same thing. They had a 25% of mortality. So the patients from the MRS 5 are shifted to the MRS 6. So no age limit, but be human, of course. And children, we do it. Why not? This is a patient that came to us 30 hours after the occlusion of the basilar artery. Then he was getting the symptoms are getting very pronounced. And then we did the thrombectomy. You can see there's some problems. We removed the clot, but there is something in the mid-basilar. Of course, even in the mid-basilar occlusion, we always suspect something is going on there. You can see the clot was forming again, that it was probably dissection. So we were reluctant to put a stent in a 12-year-old kid. So we get the bolus of agrastat and stabilize the thrombus. And after that, the patient was good. At day 1, he was NHS 1 and recovered very well. This is the 2-year control. You can see the classical situation after dissection. We should perform in a posterior articulation, of course. I will not skip that. And for the tandem lesions, the stent or not stent, or MCA first or the second, these are the questions. We usually do it in the way that we do intracranial first, and then I will go fast through this patient that had occluded a stent in the common carotid, the left. We did thrombectomy, removed the clot. We didn't care about this occlusion proximal because he has developed collaterals. And then it was, I think, good decision because his NHS had dropped. He was MRS 3 at the end. So very good news. Before we were 1 or 2 neurointerventionists. Now we are 4. All of us are trained abroad, more or less. And our specialty becomes very attractive for the young generation. And exciting to be here and see what will be in 10 years. Thank you.
Thank you very much. I saw that there were 15% of patients which were referral patients. So I suppose you expect that to increase even more in the future with better selection.
We need to do our job, but they come late. And try to work out with the ambulance and to come.
Yes, and train the centers, the other centers. Yes, well done.
Thank you.
Great work.
Thank you for the wonderful presentation. It's my great pleasure to invite my friend from Bosnia, Denis, to show us the treatment of the stroke in Bosnia. Thank you.
Thank you very much. I express my gratitude to the organizing committee for having me here and giving me an opportunity to present what are we doing in Bosnia. So I have nothing to disclose, and we all remember the Mr. Clean results actually published in World Stroke Congress in Istanbul, Turkey in October 2014 and published at the New England Journal of Medicine. Which actually showed that, okay, thank you, that thrombectomy works. So I remember time in Frankfurt at TCNR just a few months before, and the frustration of the neurointerventionalists by the results of the previous studies like ECAS that actually failed to conclude that thrombectomy actually works. So these were the game changers in 2015, and one of them actually showed that intravenous thrombolysis actually works. However, you can see the statistics in my center. So the number of actual intravenous thrombolysis is really low. It tends to rise in recent years, but we actually did not reach even pre-epidemic levels yet. So it's for the first 7 months only 13 IBTs in our country. Where we are right now. So first mechanical thrombectomy was performed by me and my colleague in Sarajevo in early 2021. We are actually somewhere here. So we do not have, we have only 2 comprehensive stroke centers in our country. They're located in Sarajevo and in Mostar, and you can see the population that we tend to catch with our thrombectomies. The other 2 comprehensive stroke centers are actually being developed in Tuzla and in Banja Luka, and we have some primary stroke centers which need to be eligible for IVT in Bijeljina and perhaps in Bihać. So there are no acute stroke-ready hospitals in our country, and we, in primary stroke centers, mostly we do not offer IVT-PA. So the other problem is, of course, infrastructure. So the green is actually highways that are being constructed, and grays are those who are planned and not built yet. So even though it's not so distant between other cities, it's still quite a journey for the patient to actually come timely for the intervention. The other thing that we actually encounter is, of course, cost effectiveness of mechanical thrombectomy, and we always have these complaints by the National Health Fund and insurance companies that it doesn't work, but it works actually in most of the countries except for Bulgaria. I don't know why. In this study, it showed that it is not cost effective. Of course, it's obviously because of our relatively poor economic condition in comparison to other countries in the Europe. However, we have our local obstacles as well. So this was actually one of the first cases. It was actually a young lady. She had actually birthday day after, and upon admission she had an NHSS score of 11, and door to groin was actually 3 hours. How this actually happened? Because we managed to talk into neurologists in going for the case, and we performed it with the simple aspiration. It was a first pass effect, and this is immediately after the procedure. So NHSS immediately dropped to 7, and upon discharge she was released as MRS 0. So what were the difficulties of first case? Of course, there was a sluggishness of emergency medicine department staff because they didn't know what to do. There was no clarity in the further clinical pathway of the patient, and upon discharge from NG suite, because they were claiming that we are conducting experimental medicine, they didn't want to admit patient to the neurological intensive care unit. So the patient stayed for 3 hours in the emergency medicine department, observed by us. So, as Ivan already said, we have a lot of comorbidities, and the number of tandem occlusions is actually pretty high. So this was maybe fifth case that we performed. So we expected only M1 occlusion because we didn't scan at that time craniocervical part, but just cranial. So the guy was actually from the one of the embassies, and that's why we actually had the opportunity to perform thrombectomy. So as Ivan said, we went straight for the MCA, and then we returned and passed the stent and implanted the stent at the carotid artery, and this was the final result. It's TK2B. He was discharged to London as MRS 2, and this was the final image. So what are the difficulties here? So we had prolongation of door to groin time to 4 hours because they demanded MRI. I don't know for what reason. And we had to wait for green light by primary care physician in London and the spouse. So I think the mothership model has to be favored here. Of course, we're so far away from drip and drive, and drip and ship is maybe it may be in the near future. Yet again, we are mainly performing thrombectomies beyond guidelines because the neurologists are actually giving us more opportunities in posterior circulation. So this guy actually had a really nice angiographic result, and we balloon angioplasty the culprit lesion in the mid basilar as well. However, MRS at the discharge was 4, so not a good result. But it keeps getting better, of course. So. Again, another guy with door to groin of 10 hours. So, of course, we used only ADAPT here, and the result was actually better. This is one pediatric case of a 5-year-old boy. The initial referral diagnosis was actually falling from the chair and had contusion. We performed CT, which obviously showed basilar artery occlusion, and went for the angio, and after 3 passes we managed to actually extract almost everything. So hypoplastic PCA on the left side with good collateral, and this is the boy only 1 month later. Again, pediatric case, 8-year-old girl with coagulation problems due to the COVID infection. This happened last year, and we managed actually to achieve TK2B. However, the result is actually MRS free, so it was not as satisfactory. If you compare 2021 number of cases in developed countries, in countries of region, and in Bosnia and Herzegovina, you will see that we are actually getting stuck in 2021 on 50 thrombectomies, and this is mainly because of the help of Republic of Croatia, which actually put some money in order to actually boost the number of procedures in our country. And I hope that it will improve in the future. So what can we do? We can organize public campaigns, and we already did that. We need to use AI in stroke detection. We had problems with recognition of procedure, with reimbursement. However, it is being done right now, and we established at least a local stroke registry in our department in just last month. And of course, we experience really hard difficulties in changing of clinical doctrines, especially with the neurologists. So we organized some events which were well attended even by neurologists and anesthesists. However, we are expecting better results in the future. So thank you for your attention.
Denis, thank you for the
Thank you
wonderful
very
presentation. In a matter of time, we will switch from Bosnia to Macedonia. Please, Menka.
My slides. First, to thank you for the invitation to the organizer and to my friend Alioski. It's a beautiful gathering together at this Endovascular Academy. I will talk a little bit about the treatment of stroke in North Macedonia. We started 2018, but we are still at the beginning. Macedonia has a total area of 25 square kilometers, population almost 2 million, less than 2 million. Capital city is Skopje, and more than quarter, maybe half of the population is living in Skopje. The furthest place is maximum 200 kilometers from the capital town, and there is only 2 helioports in clinical center and clinical hospital Acıbadem Sistina. There is a project in the Ministry of Health many years ago, and still we are fighting with that, but we don't have established network, and the government budget is in process a little bit with the COVID, and now we are again applicating and waiting to be approved, and has some help. With the endovascular treatment of aneurysms and hemorrhagic stroke, AVMs, etc. We started 2005. It was just a small amount of this pathology that was treated endovascularly till 2010, and then there is much more, and we have a little bit statistic about this pathology that is around 150 aneurysms per year, and 70 to 80% are treated endovascularly. But with the stroke, we have less information. It should be like acute myocardial infarction, or that's for the large vessel occlusion, it's supposed to be 150 per year for 2 million, but with the MIVO and distal should be much more. We have just 4 primary stroke center where is available TPA, and neurologists are having some statistic that there is a 5,000 per year strokes, but we don't know how much is for large vessel and etc. because we don't have statistic for that. There is 2 centers for neurointervention in our country, and from November 2018 we have only 68 patients. They are all in arterial circulation. LVO and small amount of MIVO were treated with mechanical thrombectomy in Macedonia. For now, as I said, 2 centers can provide this treatment, and also stroke patients were anterior, as I said, and they were diagnosed with the CT, mostly of them, 80%, and a small amount with MRI and MRI. First patient was directly evaluated and treated in the angiographic suite on the basis of non-enhanced CT with a hyperdense MCA sign, and We have treated 59 with M1, M2 occlusion, of which 10 are tandem lesions and 9 patients with T occlusion. In mostly of our treatment, we used stent retriever and aspiration combined. We didn't use till now balloon guiding catheters. And from symptoms onset to groin puncture in 15 patients was less than 6 hours, 11 patients was 6 to 8 hours, and wake-up stroke 7 patients till now. Technical and success and failure for endovascular recanalization and reperfusion was assessed with MTK score. And we have, as you can see, MTK2B around 30%, MTK3 around 50%, and 4% that we didn't succeed. It was no reperfusion. And some of them was one without neurological deficit, that was MIVO, and 2 was with worsening. Till this year, we haven't in that small amount of patient major hemorrhage, but in 2 months we have already in 2 centers by 1 major hemorrhage. After the first pass in a young patient, we have major hemorrhage that need craniectomy. We are using the same scales and scores, guidelines with update, etc. How does it work? Till today, rapid clinical and radiological assessment. Patient receive IVTPA if it's suitable, but neurologists are not using so much because the patients are coming in these primary centers very late. And then transfer, if it's eligible for EVT, it's transferred to the hospital by road. I can show some of the first cases, through this year, some cases. This is female patient on 48 years old, 30 minutes after stroke onset. Why we catch this patient, why we diagnose this patient so early? Because it was in the clinical center, in the hospital. It was for another examination, and then in that time she get the stroke and hemiparesis and NHS score 15, and it was near to the neurology department, and everything was done. It was 2 pass MTK3. 32-year male patient, it's wake-up stroke, it's a young patient, left hemiparesis, and no IVTPA. We can see the dissection in the distal part, small dissection on the distal part. Because of that, we are saying tandem. Okay. And it was first pass MTK3, but we decided not to treat this dissection site because of the cross filling, and it's a tiny. And after 1 month, I think we made a CT and medical therapy. It was remodeling. This is one colleague, doctor on 72 years. Male with stroke onset 3 hours, no IVTP, tandem lesion, and first we went to clean the brain, but we didn't succeed despite this subocclusion of the extracranial ICA. And then we decided to put first the stent and post-dilatation, and then we go to clean the brain. We give half dose of tirofiban, 20 hours, and then the next day we made the control, and give double antiplatelet. This is 25 years old male with endocarditis in the other institution that was waiting for the valve replacement. And this boy get worsening in the morning before the operation and was diagnosed with M1 occlusion. But with the progressive clinical worsening with Glasgow coma 7, intubated patient was driven to our department 7-8 hours after the onset. We did the thrombectomy. It was, I think, 2 passes. But next day when we made the CT, there was a hemorrhage contralaterally in the thalamus, right? But that was before we do the thrombectomy. And this is T occlusion, 30 years old female, wake-up stroke. We did 2 passes for MCA, but migration of the thromb. And we went with the same stent retriever to A2, A3, and the patient is now with a MRS 2. She did well. There was PFO. For MIVO, we know that there is no clear guidelines, but we have recommendation. We are starting to manage these types of clots. If it's located, we should always look for the consider about the level, size of the branch, functional importance, etc. This is MIVO with just left arm paresis, and in the angio suite, the patient was, after the first pass, without any symptoms. This is a very good patient. IC occlusion without LVO, we don't, the recommendation are not clear, and no randomized control study. I am already done. This is the patient that has ICA occlusion and distal vessel occlusion, but we didn't decide to treat this patient in that time, and after 48 hours there was a stroke. I think that we did the mistake for this patient, and this is another patient with I can it was watershed infarction, but because of the improving of the clinical status, we leave this patient, and after 3 months with the double antiplatelet, we treated the carotid subocclusion. And this is the patient, the last one, with the infarction with the ischemic infarction 48 hour before. It was admitted in our hospital after this event. But previously, 7 days, she had TIA once or 2 times, we don't know, and they detected with the CTA subocclusion, and we decided the same day to treat this patient with a carotid stent. It was too late for the distal occlusion on M2, and the patient has fast improvement and very good result. What we are missing? We don't have developed national strategy for mechanical thrombectomy. Project waiting to be approved. Poor support from the government and institution, and we think that artificial intelligence application maybe will help to us to have a faster workflow, and we don't have units for post-stroke rehabilitation. That's the problem, very big problem. Future perspective, we have to improve the patient outcome, and clinic and reperfusion is always necessary. Thank you for your attention. I was over
Menka, thank you. In conclude, I think that after a couple of wonderful presentations, I understand that stroke is the common cause for that in the Balkans. We understand that we need more centers. Maybe it's necessary to have an improvement about the treatment of stroke. And most important thing that we need more and more physicians to treat patients with a stroke.
Something that unites us. We can work together
Yes.
here as friends
Yes.
and
Thank
continue
you.
this
Thank
lovely
you.
meeting.
Thank you.
Thank you everyone for attending. And
Thank you.
Yes, and
lunch session.
have a nice lunchtime, but it will be only 20 minutes because we want to
Yes,
start
but by the
on
time.
cake.
Thank you.
Thank you.
Thank you.
if you don't see, you cannot treat a patient. The Azerion brings complete rethinking of the system.
Sure. Put it to the maximum now.
I always say that if you don't see,
Vladimir.
Hello, everyone. My name is Nikolai Velinov, and we will start the second session, neuroendovascular interventions, which is of great interest, I believe, for all interventionalists within the field of neuroradiology, neurosurgery, neurology. So Professor Sirakov will give the first talk, Taming the AVM Beast, the Visual Odyssey of Exemplary Cases at a Single Center Institution. I suggest that we have discussion after the two talks of Professor Sirakov, and yeah, thank you.
Thank you, Professor Velinov. Greetings, everybody. Today I'm going to share our experience with our endovascular experience with treating cerebral AVMs. Like everybody knows, the AVMs is a dangerous beast, which we continually explore and understand. It is not very known about their condition, nature, history, and hemodynamics. So how we treat the AVMs? When we should wait, when it's inevitable for the patients to have bleeding or already neurological symptoms, and how should we respond to these clinical features? There is no established guidelines. Should we wait or should we treat AVMs? You know, everybody heard about Aruba and other design studies which suggest us to go conservatively or to perform some surgical endovascular or radiosurgery therapy for these beasts. If we have a beast, of course, we have to temper it somehow. So one important topic of these lesions are the size, of course, and the architectonics. So if we have to treat, we think about reducing the size. Also, reducing the dangerous point inside the AVM, intranidus, aneurysms, hemodynamic stress portions of the nidus, and etc. So our goal, endovascularly speaking, is to reduce the risk of bleeding, so to reduce the risk of this AVM to do a harm or danger for the patient. And I'm going to show our experience with timing these tempers beasts so we can reduce or cure completely the AVMs in our institution. Like I already mentioned, the size is very important. Also the location is also very important, and the architectonics itself of these lesions is maybe the most important thing which can predict us should we go directly for treating and attack these lesions, or we could stay conservatively with them. I will start with several simpler, if I may say, AVMs. This is a small AVM feeded from the posterior cerebral artery on the left with single drainage through the straight sagittal sinus. In this location, you can see select navigation directly inside the nidus with a microcatheter suitable for endovascular approach by embolize completely the nidus, and of course the first initial full portion of the venous system. And at the end, you can see final result with total embolization of this AVM, which we think about totally cured. This is another example with a young lady with epileptic seizures. On the MRI, we found a ruptured AVM in the past, not acutely one, so we decided to give it a try with the endovascular treatment. You can see the supply from the anterior cerebral artery and draining through a single vein to the superior sagittal sinus. And again, here we transarterially reach the AVM and manage to perform total embolization. And this is the MRI postoperatively with not additional visual complications. This is another example, a little bit bigger AVM with supply from the right MCA branches and single drainage to the, again, superior sagittal sinus. In this case, of course, we manage to navigate transarterially to embolize this as much as possible. At the end of the procedure, we don't see any additional venous outflow, but of course with some residual or still visible arterial anastomosis through the MCA and ICA. This is another example, almost the same AVM, the same localization, the same size with single drainage, and here we manage to embolize it totally without any residual visual vascular lesions at the end of the procedure. This is, of course, completely different beasts. Thalamic AVM, close to, very important cerebral structures supplied from the posterior cerebral arteries, and it's a lot of perforators in this area. Of course, transarterially with 2 microcatheters, like a flow control, we managed to embolize maybe 90% of the AVM with reducing in size, and of course, after that, we send this patient for the radiosurgery with very nice results at the 3rd year. 11 years old boy with a very heavily intraparenchymal hematoma. In this case, we have to obliterate the nidus as much as possible, so the patient could go safely for evacuation of the hematoma. So we do our best, and we managed to embolize it totally, and of course the hematoma was evacuated immediately post-embolization with very nice recovery of the young boy. And this is the case of AVM situated, mainly supplied from the anterior cerebral artery with a very fast flow, big feeder from the anterior circulation. Here we decided to use so-called pressure cooker technique, so to reduce the size of the reflux of glue, and we managed to embolize it completely without risking important perforating arising a little bit proximal from the plug we created to embolize this AVM. And of course, the worst AVMs you can have, a big AVM situated in the posterior fossa, fed by a lot of branches, drainage simultaneously through several venous outflow to the transverse and sigmoid sinus and the deep venous localization. In 2 procedures, we managed to totally embolize this AVM with very nice recovery of the patient without any symptoms. This is the final angio, and we of course continually to follow up this patient for some recanalization, but until now, because we expect some recanalization and maybe send it to radiosurgery, but until now there is no visual recanalization with direct fistulas or venous outflow. We can say it's a residual AVM. This is of course another example in which it was a young boy. We managed to embolize the whole visual nidus we saw at the beginning of the procedure with very nice result, but at the end we also performed posterior circulation, and sorry, this is a different case. It was very close to the young boy. We managed to embolize it totally without any recanalization. This was a rupture AVM, thalamic one, with no good arterial feeder we can navigate through and try to embolize transarterially. So in this case, we go retrogradely, transvenously, go with 2 microcatheters in which we put coils, and the second one was for delivering the liquid embolic agents. And when we start to embolize with the liquid embolic agents, we also put a balloon in the left posterior cerebral artery so we can reduce the inflow of the nidus until we reach complete embolization with retrograde filling of the glue inside the nidus from the venous outflow, with a very nice result at the end, total embolization, without aiming to catheterize these very small and difficult to catheterize feeders from the arterial side. And this is the control at the end. Again, I show you without this inflation of the balloon, maybe the risk of not completely cure the AVM will be very big. So we decide. So in our opinion, the balloon flow remodeling during the embolization transvenous is also very important when it's possible. This was very strangely ruptured AV fistula coming from the very small branches of the posterior A1 segment. But we were very lucky to catheterize them and manage to completely embolize it by glue. And of course, the patient was spared to go for additional surgery, because if we fail this, we should send the patient for additional surgery. At the end angiography, sorry for lacking the DCA, we didn't observe any recanalization, and the patient recovered very nicely without any signs of recanalization or residual at the end. This was the boy I was just mistaken before 2-3 slides. We managed to completely embolize it transarterially from the anterior circulation. We are very happy with the result, but when we performed the posterior circulation, there were some feeders opened at the end of the procedures and still fed the portion we didn't manage to occlude by glue. So this one go directly for surgery. We didn't wake him up. Of course, our neurosurgeons were very happy because they said it's very more easier for them to do partial embolized AVM compared to not one. And the final result was okay. Another case, posterior circulation, single arterial feeder. When you can reach it, it's very easy. If you know the glue you're using, how it behaves, it's very easy to make complete embolization without any recanalization or residual portion. And this was the patient we treated 4 or 5 days ago. With BKAVM, we managed completely occlude through transarterial road. So in conclusion, it's very important this lesions should be individual approach for every of them to decide should they be treated endovascularly, surgically, with radiosurgery or combined. And the most important balance in this case is for the benefit of the patient. Thank you for your attention. After the next one.
Okay. Thank you very much, Professor Sirako, for the wonderful presentation. So I will ask Professor Bogarts to come to stage. He will give us the presentation, the role of the hybrid neurosurgeon and the hybrid neurosurgical theater. More and more of these across Europe are opening, and it gives opportunities combining surgical techniques and endovascular. So we'll be very interested to see what is your experience.
Well, thank you very much for the organizing committee, for the invitation, and for the excellent meeting. Good. So no relevant conflicts of interest for this talk. So I was given the title, the role of the hybrid neurosurgeon and the hybrid neurosurgical theater. So actually that are two topics, and as such I divided this 10 minutes talk in two parts. So the first is, what's the role of the hybrid neurosurgeon? So let's put things in perspective. How about the open surgical, neurosurgical development? So of course the big three in the last part of the 19th century, Victor Horsley, Harvey Cushing and Walter Denley really started off with neurosurgery. And then in 1937 the first clips came and they changed a lot. Then Theodor Kurz with the microscope, also very important development, and of course you all know Yasser Gale with the bypass development. And then Guillot from France, he started with the neuroendoscopy, which was also a big advancement in the field. And then several decades later, navigation came in, and one of the last major important, especially for vascular neurosurgery, was the advent of the ICG, in which you can visualize the vessels, the circulation during the OR. So how about endovascular? You all know this. Moniz was the forerunner with the angiography. And then Lucenhub came with the microcatheters, which had a great impact on the possibilities. And then Fabius Serbinenko with the detachable balloons, with the real first attempts to treat the aneurysm. And of course, Guglielmi started with the coils, and then the stents that came in, and one of the latest development, the flow diverters, you all know, and the intrasaccular devices since 2011, already more than a decade. And the biggest change, I think, in endovascular, and that's probably also why it's the main topic here of this day, is the thrombectomy. And this really changed a lot, I think. So this is about the endo development. So if you compare those things, the big advancements are, as you see in the last 2 decades, are in the endovascular therapy and not as much in neurosurgery. So together with this development and also with the decline in open procedures for neurosurgeon related to the ISET, and the ISET really had a big impact on our caseload as open vascular neurosurgeons, in the sense that it not only was changing the practice for the aneurysm the trial was intended for, but also had impact on the non-ruptured aneurysms, and in the end not only on the aneurysms that were suitable for both coiling and clipping, but it really changed also they were difficult for coiling, still had a first-line treatment of endovascular. So if you see in current practice, for example in France, a recent review, there are surgeons, the number of surgeons that really operate more than 20 intracranial aneurysms per year, it's very limited, only 11. So that's a big issue, and it's for unruptured, it's only a quarter, which is for open, and for ruptured, it's even less. Together with this, we face a decline in the number of patients, especially for suprapunctal hemorrhage, because of cessation of smoking and a better regulation of blood pressure. So what do we end up with? We end up with, for open neurosurgeons, with low volume, high complex aneurysms. So we should change the way we work, the way we train. And we should really, the old system of a master and who is training is not any longer sustainable. And we should expand our field of vascular into endovascular. What's the difference, holding an endoscope or using catheters? And there's always the saying, that, yeah, you can do both equally good. But yes, you can. We looked into that, and there are many other centers, and especially in the US, but also in Asiatic countries, there are a lot of hybrid neurosurgeons. But there are difficulties in institutional embedding. We had the lucky of André Grotenhuis, the former chair of the EANS, who really helped us to start up endovascular. So what can you do as a neurosurgeon? What are your options if you are interested in endovascular? So first of all, if you want to stay with open vascular, go to a very high volume center. But there will be only a few on a national level. Or go endovascular, only endovascular. That's a very good option because you will do most of the cases, as you will know. And especially it will increase over the coming decades more and more, I think. Or be a hybrid. So if I look into my caseload of neurovascular diseases, I do actually everything, stroke, aneurysms, fistulas, AVMs. If I would do only open, this would be my caseload. So, and it really helps me doing endovascular, helps me for open, and if I do open, it helps me for endovascular. It's really, there's a kind of cross-pollination between the two subspecialties. So for me, the first question was, what's the role of the hybrid neurosurgeon? I think it's an essential one in neurovascular pathology. So then, how about the hybrid neurosurgical theater? So, at least in the Netherlands, it's a hybrid theater. It's very expensive. It's like €1.5 million. So probably most centers don't have the caseload to have this as an own department. So you have to collaborate. Collaborate with vascular surgeons, cardiologists, interventional radiologists, pulmonologists, everybody who, orthopedics, who can use this. So in order to be efficient. So how could we use as vascular neurosurgeons, hybrid neurosurgeons in particular, use the hybrid neurosurgical theater? So we could use it in diagnostic or therapeutic. So for the diagnostic, you could use it for intraoperative CT imaging or for intraoperative angiographic control after open surgical procedures. And for therapeutic, you could use it for only endovascular procedures, for endovascular procedures requiring surgical access, or hybrid procedures. So let's look closely into some examples. So the cone beam CT, you know it's very helpful. There are different indications for that. For example, nowadays the endoscopic surgery for hematomas is really coming up. So it's very useful to intraoperatively assess the amount of removal of the hematoma, but also for relatively simple neurosurgical procedures like shunt placement, it's very helpful. So it requires some setup with the drapings and with the whole team to know how things should be done. But it's very helpful, and so for aneurysms, it's really helpful. We have the Siemens system, which is good. So here, for example, you have the two aneurysms, carotid T and the MCA aneurysm. You see the clipping, the intraoperative unsubtracted images, and the run with the direct control with the patency of the vessels and the occlusion of the aneurysm. So it's really helpful, and it's even more helpful for AVM, because sometimes there might be tiny remnants in the most lower part, which might be sometimes difficult to oversee if you perform the surgery. And this is really helpful. And also if patient is in prone position, it's not a problem because you can use radial access to catheterize. So what about pure endovascular? You could use it for everything. In our practice, we do the aneurysms, the AVMs, we do it at our biplane machine, separate at our own location. But sometimes it's useful for stroke, because if you're busy with a procedure, you can't stop the procedure, you don't want to delay the stroke treatment, so it gives you an opportunity to go to the hybrid room. It's an extra place. So what about endovascular procedures requiring surgical access? I'll show you a case. Female 60-year-old with progressive exophthalmos and visual decline. And you see the exophthalmos on the MR, and you see the dilated superior ophthalmic vein on the CTA. So first tried, so this it's an indirect fistula, barrow D, having the feeders from the internal carotid and as well as the external carotid artery. I only have the internal carotid artery here. I try to embolize through the inferior or superior petrosal vein, but there was no access, on both sides, and transarterial, there was also no access. So I scheduled the patient for the next day for direct puncture of the, so first the exposure of the superior ophthalmic vein, and then puncture and go directly with the microcatheter. So this is what you have. You have the carbon Mayfield clamp, which is translucent, but so you have to plan a little bit because it's not entirely translucent. And then you can see the direct introduction of the microcatheter to the cavernous sinus, and here the coiling of the cavernous sinus with occlusion of the CCF. So then at last, you have the true hybrid procedures, those are requiring both advanced open and endovascular techniques. And here you have a partially thrombosed MCA aneurysm on the M2 branch. And I'll go quickly over this because I know I'm over my time. So there's also edema, patient presented with epileptic insult. So you want to manipulate as less as possible the cortex. So what would be your strategy? Your strategy would be to revascularize this diseased branch, because it's not only the aneurysm, you see also the distal branch is very much dilated. So it's a diseased segment actually. So it might be sometimes difficult to identify the recipient vessel, because they might be very much like next to each other. You don't know which is which. So what I did is I performed intraoperatively a super selective catheterization of the disease segment and did ICG. I gave ICG through the microcatheter, and with your microscope you can see which vessel you should revascularize. So then I performed my STA-MCA bypass. And secondly, I performed the intraoperative control to assess the patency of your bypass. And next, the endovascular closure of the aneurysm. So this is the final result at 6 months follow-up. So in conclusion, in a changing field with a tendency for more endovascular solutions, there's an important role for hybrid neurosurgeons. And secondly, increasing technical advanced solutions require a hybrid OR and will be the standard of the near future. And just invite neurosurgeons to get involved. And for this, we all have our training from the ENS, which is next June in Amsterdam, but next year it's here in Sofia, hosted by Nikolai. So you're all invited, and thank you very much for your attention.
Thank you, Jeroen, for the wonderful example of how we can combine open neurosurgical techniques and endovascular techniques. I suggest Professor Sirakov give... yeah, okay.
About the last case, do you perform, before a decision for a bypass, do you perform some balloon occlusion tests just to see the collaterals, if they're existing?
No, it did not, because the segment, there were two M2 branches.
It was not possible to close it with the
No,
balloon?
that would certainly lead to clinical significant ischemia. Absolutely.
Yeah, actually, I was going to comment that since there is no time. Most of these serpentine aneurysms, since there is a very low flow to distal circulation, they already have pyelonephrostomosis. So I would rather do test occlusion before, and I would say that I have like maybe more than 25 cases like that in the last 30 years. I haven't seen a single one who failed test occlusion.
Okay.
So usually they don't fail, and you can just close it.
You could, yeah.
Yeah.
Yeah. I didn't do it because I didn't want to take the
No,
risk.
just for the next cases, just keep in your mind. You know.
Okay, thank you.
Thank you. Professor Sirakov. So, from zero to hero, the journey of endovascular aneurysm treatment in Bulgaria.
Yeah, thank you. I just want to share our struggle at the beginning when we start this endovascular odyssey, if I can say, in Bulgaria, and how we can manage to introduce and maybe develop this endovascular treatment for cerebral aneurysms. Like in many countries in the early 2000s, here in Bulgaria the situation was the same. Most of the aneurysms were surgically managed, so our neurosurgeons clipped the aneurysm. We starting to change this in 2011 when the first biplane neuroangio was installed in our hospital. So for the next 4 years, we managed to create a dedicated department, neuro department. In the next 6 years, we managed to reach 100 procedures, combined diagnostic and therapeutic ones. And the things really changed very fast from the 2020 when we managed to get our second biplane angio, which was high-end tech, the last Philips Azuron, which we are very, very happy and satisfied with. So, for example, the 2022 already we can manage to perform 350 endovascular procedures, therapeutic one per year, combined aneurysms and AVMs. Our idea at the beginning, our goal was to offer for the Bulgarian patients 24/7 services for these cases, and of course to fight for free of charge devices here in Bulgaria. At the beginning, everything should be paid or covered for the patient themselves. And in the beginning, the first struggle I thought we can have was with our neurosurgeons, how we are going to convince them to send the aneurysm for endovascular treatment instead of surgical clipping. But really the toughest fight was with the government and the National Fund about funding, gathering money for these devices and to recognize these procedures that should be starting to perform and develop in Bulgaria. And for 11 years, I can humbly say that we created the team. We fought from 2016, at least in our department, the patient didn't pay for anything about the procedure or the devices were used. We finally managed to get 24/7 availability. Maybe from the whole country we get calls for rupture cases, so we can treat them and have them in our departments. And of course, during this time, we continually gained experience. If I may summarize, the first steps, like I mentioned, was the first years until we reach 100 therapeutic cases. We fought for the cost-free. We create 2 fellows, which are already residents, finished their residency and working 24 hours daily with me together, and we have 2 more young residents. Already our team is 15 people, containing 15 people. We continually trying to train and educate more people. So we're creating in 2019 the National Training Center. And because in our department we're covering maybe more than 80% of every endovascularly treated cerebrovascular diseases, we managed to educate and to train a lot of people every day by us. If I may say, from the last year, we are one of the mentor centers from the SMIN program. So we continue this year to also educate through the video recorded cases and online, the whole interventionalists from the Europe. And I just wanted to show you several cases and steps we developed in the last 11 years. Very fast, because the time is short, I will show you we start to beginning with the coiling. You know, every young interventionalist start first with the coiling, then learn the adjunctive device usage like here in these terminal carotid aneurysms. We coil because of the wide neck with adjunctive balloon at the level of the neck, so we managed to coil it safely without protruding any coils through the lumen of the parent vessel. Then we're starting to fight and to implant permanently devices inside the vessels, like here in these very complex structure cases of the MCA. I think this was at that time the only possible way to treat this aneurysm. So we put 2 Atlas stents in Y configuration. Before that, we gel the catheter in this tough angulation, and we managed to coil the rupture portion of the aneurysm sac, with also, of course, with very nice follow-up without any recanalization. Of course, we can perform this kind of endovascular coiling with just 1 stent when the anatomy is suitable and the angulation allows you just to cover maybe 80% of the aneurysm neck, and you don't need for a second stent in the second branch. So here is an Elvis Evo with coiling. You can see also very nice follow-up without any signs of recanalization. Then from 2015, I think we are one of the first centers worldwide using a web device, still there with the Sequent Medical company. And it is not our first case, but one of the cases lately we put, it's very, I think, wide neck ACOM aneurysms with a second branch coming very closely, like a duplicature of the ACOM or trifurcation of the anterior circulation. So our goal is just to finish here the web, and you can see the device itself with the early follow-up at the 7 days with the MRI shows very nice preservation of the second vessel we didn't lose with the web device. This is another case with the web. I think, in my opinion, it is a very useful device when you can size it correctly. I think it's very easy to use, and if you can size it correctly, it's not a big of a deal to place it correctly, and I think most of the results are very nice. Despite the latest publication, they showed maybe the recanalization rate is a little bit higher than we expected. And of course, flow modulation devices. Here you can see giant covered nose aneurysms. When we put a flow diverter stent, we can observe very nice reconstructing the vessel, and of course, shrinkage of the aneurysm, which is the main goal here most of the time, because you know these kind of patients are related with some visual symptoms or some mass effect neurological symptoms. This is a dysplastic or dissecting MCA aneurysm on a young patient. Here was this patient was treated at the time I was believing that putting a wire on 2 coils could induce faster thrombosis and maybe reduce the risk of delayed rupture. So here we put a flow diverter with just a single coil, and you can see the follow-up with very nice reconstruction of the vessel. And of course, sometimes when it's a very wide neck ACOM complex aneurysm with lacking contralaterally A1 segment, in this case, I don't know, maybe more experienced guys in endovascular can perform stent assisted coiling. I think it was very nice case for using the new smallest flow diversion devices. Of course, like in the beginning of everything, one of our first cases with 0.21 catheters in this anatomy didn't allow us to very nicely expand the stent. You can see this like a twisting or not good opening at the level of the curve. So we go inside with the Comaneci device. We just angioplasty with the Comaneci very nicely, and the final result you can see very nicely open of the stent of the curves with very nice follow-up. And like I mentioned before, the Comaneci device, in our opinion, is very useful tool, which can, of course, replace the balloon with the benefit not to worry about the time. You can inflate it without obstructing the blood flow inside the parent vessel, and you can perform coiling for 20-25 minutes without additional antiplatelet therapy. With the balloon, we have some restriction in time, because if you leave it for too long, you can induce thrombosis in the parent vessel. So here is an example of Comaneci inflated just to cover this wide neck aneurysm on the ICA and to reach satisfactional coiling at the end of the procedure. Lately, we were lucky to make the first in human a new device, intersacral one, which is memory pre-shaped nitinol device. When it reached 37 degrees, it became rigid at the level of the neck, discus shape. So you can place it at the level of the neck and it's very stable. You can produce coiling, and the most important, it induced epithelialization and thrombosis at the level of the device. So it's like a breach at the level of the neck. And if you can place it correctly, you can coil even loose. I'll show in the next slide, and you will do very nice follow-up at the 6 months. Here is a case in which we placed this Nautilus device at the level of the neck, and we were not managed to do a nice coiling at the end, but you can see the 3rd month follow-up. It continuously produced epithelialization and thrombosis at the level of the device, and it induced more thrombosis inside the sac, so you don't have, we have more than 50 cases, we didn't observe any recognition for now, but maybe it's just too small, the number of patients we follow up. So if I may humbly say it, for 11 years, we managed to continually grow our therapeutic procedures. For example, in 2023, we performed more than 300 therapeutic procedures, and until now, in 2023, we have already 350 procedures performed until 2 days. So our goal is to continue our certified training physicians in our department, to dedicate, of course, stroke centers, which we, until nowadays, we are a little bit struggling, and of course, to improve patient care. Thank you for your attention.
Thank you, Professor Siracov, for your wonderful presentation. Really impressive cases, and the Nautilus device, I believe, is a great adjunct to the endovascular treatment. Any questions?
Which was the neck bridger? Which company makes it?
Endostream.
Endostream. Okay.
Yes, it's a Nautilus device.
Yeah. This is invented by J. Mokos, I believe.
I think J. Moko and Adnan Siddiqui has some part in it.
Yeah, and something that we discussed last time, that we've always had the discussion for MCA aneurysms, and I believe that the shielding device like Nautilus might convince most neurosurgeons that this is the right way to go, because obviously all other strategies have been somewhat difficult in long-term perspective, especially in young patients.
Yeah, those neck bridgers and intrasaccular disruptors made till wide neck aneurysms, especially ruptured ones.
Sure.
You know,
sure.
I mean, I had been known as a very aggressive endovascular guy, but you know, in the 15 years ago, I was sending a bunch of patients to surgery because if it's a wide neck, you don't want to put a stent and flow diverter. Now, we're able to do this, and even they recanalize this, it saves the patient in the acute stage. Then you can do whatever you want. You can put your flow diverter and cure it. So
it's non-disputable that recognition rate by endovascular approach is a lot higher, but even with the second procedure performed, I think the risks are relative or maybe low, I don't know, for the patient.
These are important.
I have had a clear clip strategy for MCA, which is changing, of course, with years. But I was taught in the beginning of the ENS courses, Professor Pigeon used to say, you know, if you put your finger to your infratemporal fossa, well, the aneurysm is 1 centimeter below. Why should I go all the way when you can directly clip it? Of course, now the new devices, new techniques, new catheters, and the preference of the patients. Nonetheless, many patients say, I don't want to have surgery. We go to endovascular techniques. But in my experience as a neurosurgeon, a mediocre neurosurgeon could clip an MCA very well, where a mediocre endovascular cannot do the job with an endovascular MCI aneurysm. You have to have a lot of experience, and I think that is why there are so many new techniques and devices developing for such types of aneurysms.
I totally agree that the MCI aneurysms, maybe half of them or more, are complex to treat by endovascular approach.
Yeah.
We very rare see a very nice neck just for go, and you know the recognition rate is low. So I'm very glad that I have the opportunity to work with very experienced neurosurgeons by ourselves. And for the MCI aneurysms, if we have some problem of thinking about very high risk of embolization, we send it also for neurosurgery.
I loved very much the idea of René Chapeau using 2 balloons, and he says, okay, if you really pack the
but in
aneurysm
his
nice,
hands.
and now he's putting in 30% of the patients ever, because he says, well, I did these techniques with 2 balloons and I have 30% recanalization rate, so now he's bringing patients back to do stent-assisted recoiling for most of his MCI aneurysms. So this is his experience in the last year.
It's same, you know, we used to do a lot of double remodeling.
Yeah.
And they were recanalizing. Obviously, it doesn't change. Actually, we did the largest single center paper about that, and we show that double balloon do not change recanalization rate comparing the single balloon coiling. So basically, reconstruction is important at the neck, and the reconstruction comes with the either stent or flow diverter. The only thing I can disagree with you, and you know, you like to clips aneurysms, I know. Because my brothers, I've been doing WLNC, Adnan, you know, Dilo, Ricardo. But what I see in the last 15 years of our friendship, they are making less and less and less and less clipping. Because, you know, flow diverters are now, I'm just going to talk in 20 minutes. The more I see the results of flow diverter, I by myself doing much less number of white stenting, all these, you know, complex things that René likes. I used to like that too, but you know, we're getting that simplicity now.
I absolutely agree with you. As a hybrid neurosurgeon, in my experience in the beginning, I started with the idea that I would probably clip more, but in the end, in my lecture, which I also have, you will see that practically it's not wrong to be biased in the technique that you're more experienced with, and actually most of the hybrid neurosurgeons tend to be biased to do more endovascular procedure in the end, which is fine if the outcome of your patient is fine. It's, I think, the future.
If I may say, like Professor Chekije shared it a lot of times, you need to heal or you need to treat the vessel sometimes, so you can cure the aneurysm, or not the aneurysm itself, just to fill the sac. So totally agree about that.
That's what clip does.
Yeah.
Thank you so much. Any other questions to Professor Sirakov? Thank you very much. And we move to the pre-recorded live case. Where is Dr. Alioski? Yes. So he will show us a case of vertebral dissection.
Actually,
and see how we manage it.
Actually, I will speak about the microcosmos, which is the part of the stroke, also for the subarachnoid hemorrhage. Okay. Yes, dissection.
Okay.
Some of them, they start with a. I will speak about the rare condition. Increasing recognized as a cause of morbidity and mortalities in young patients, can occur spontaneously or be related to trauma. Dissected aneurysms can result in rupture and subarachnoid hemorrhage, also with a stroke. Due to the risk of hemorrhage or stroke, management of it can be challenging. I will not put a lot of things of epidemiology. Dissection is responsible approximately for 2% of intracranial aneurysm. Slight male predominance, and hypertension is the most common risk factor. Other risk factors may be trauma, oral contraceptive, and pathophysiology of the dissection of the artery. Vertebral artery it has 3 layers, intima media and adventitia. We know that intracranial part of vertebral artery has much thinner media, and adventitia layer has last elastic fibers. Rupture of the dissecting aneurysm are very high. It's more than 70%, and rupture is more likely to occur early, hours and day after the presentation of symptoms. Clinical presentations: severe occipital headache. It is most common presenting symptoms. TIA or ischemia, aneurysmal dissection can lead to rupture or subarachnoid hemorrhage. Important to recognize that the symptoms pathology may present with early hemorrhage or ischemia. If vertebral artery dissection is diagnosed within hours or days, it is difficult to know when the clinical scenario will potentially unfold. Management of dissecting unruptured aneurysm segment, it is diagnostic challenging, but the potential risk of hemorrhage study shows that unruptured aneurysm at the time of presentation have a low chance of subsequent rupture. Prevention of ischemia is sorry, I don't see. And unruptured dissected aneurysm should be treated in the enlarge or follow-up in the patient develop recurrent symptoms and medical management. Sorry. I would like to present clinical case. Young male, 32-year-old male, presenting with neck and occipital headache, nausea and vomiting, ataxia this arteria. Symptoms arose during fitness training. We do a CT scan. And we found occlusion of the right vertebral artery. So we do DCA. We see the intimal flap, actually. Here is we do the 10,000 units heparin with bolus. After 10 minutes without clinical deficit. After that, we see neurologic deterioration of the patient, and we discuss the treatment with stent retriever with solitaire 4x40. We see the intramural hematoma, and we let the solitaire maybe more than 20 minutes, and after we resheath the stent, we have a new growing of desiccation and intramural hematoma. For this reason, we discussed to put the bigger stent to have a little bit more radial force, and we put the solitaire 6x40. Here is the top of the solitaire. And this is the final result. control CT was performed 48 hours after. And we see the patency of the right vertebral artery. Conclusion, dissection are rare but important case of both subarachnoid hemorrhage or acute ischemic stroke. Imaging diagnosis can be challenging and might require more than one modality. For those presenting with ischemic, the primary focus should be prevention of further embolic events. For those presenting with subarachnoid hemorrhage, the primary focus should be treated of the dissecting segment to prevent rebleeding. And usually we do the coiling, trapping, or stent assistant vessel prevention with stent or flow diverter. Thank you for the attention. It's from René.
In those cervical birth cases, I still prefer to use the regular coronary balloon expandable stents. In the long term, they are very good. I mean, because we've been doing this since before self-expandable era, so they are very good and more cost-effective.
We don't have it on the market.
Really? No?
Yes.
Coronary stents.
I don't have it because I'm neurosurgeon, endovascular, etc., etc. We don't have a lot of coronary stents in the shelf.
Okay.
But I agree that it's cheaper and it's okay to put the
That's why I always keep coronary stents in my lab.
Yeah. But in this case, particular case with a bigger stent, I think that we have a good success.
I think it's a very interesting case, and it's very difficult to decide because there are no clear, randomized evidence what one should do in such a case. You could as well close the vertebral artery for the good of the patient if the dissection is large enough, you can trap, or of course after Sampras trial, the stenting in posterior circulation has also been claimed somewhat dangerous, so it's a wonderful example of a case where you could do
for sure
many different things.
Yes,
many different things.
In the future, we will treat more and more dissecting artery. We will need to put to do rescue stenting and to do more and more balloon dilatation of dissecting segment or atherosclerotic plaque.
The main problem of these dissections, you remember we discussed it, and basically because of conservative management has a lot of victims. Yeah. So in the worldwide, neurologists like them to anticoagulate and wait. But there are many victims of this treatment. Yeah. But, it can be working like maybe 80% of the time, but 15 to 20% of the time, that particular neurologist won't see that patient because they have a recent, they are symptomatic and they go another physician, another center. So basically, it's just it's the problem of the dissection. It's a very dynamic disease.
Or they will have intracerebral hemorrhage.
I have a bunch of cases that in the evolution of a small M1 dissection turns out to be a giant M1 aneurysm in 10 or 15 years. Yeah. It's interesting.
What is your policy, Seru, to put the stent or just predilatate and nothing's more, or it depends?
In intracranial dissection, we are very aggressive because we know that the conservative management has a lot of victims.
You do loading dose of prasugrel or something else, or?
We kind of, we start to use a lot of flow diverters to reconstruct arteries in those dissections. We used to use a balloon expandable stents like before flow diverter, but now pipeline seems to be a very good device for such dissections, intracranial dissections.
Thank you.
Thank you for wonderful discussion and the nice case presentation. So we move to the satellite symposium, where we will talk about direct to angio for stroke patients, We Trust study and our solution in stroke and neurointervention, and our new Azurian biplane.
Thank you.
Christoph Schlager.
Yes, please.
Nice Azurian.
Perfect. So good afternoon, everybody. Thank you very much for having me and for the opportunity to share some perspectives and innovations from Philips on stroke care. Bear with me 1 second. Good. Okay. Can we have the slides up? Perfect. Great, so I would like to start with the good news again, and we have heard it today already. There is really strong and growing evidence that mechanical thrombectomy works for stroke patients with large vessel occlusions. However, as also Professor Petrov and some others of you have already pointed out rightfully, the share of patients that gets access to mechanical thrombectomy treatment, that would be eligible and gets access, is unacceptably low across all our countries in Europe. And if we look at the patient journey, at the process, then we see that there are many steps, and it's a time-consuming process. And along this process, there is also many bottlenecks that cost time. If you think, and you know this better than me, if you think of when patients arrive, they do not always arrive Monday to Friday, 9 to 5. Stroke patients arrive at night, on the weekend, when less experienced staff is in the lab. And therefore, we need to equip them with the right support, with artificial intelligence, so that they can also do their treatment with confidence. Also, if we look at the systems that are being used, the CTs are sometimes slow, LVOs can be missed. Sometimes there's not one occlusion, but two. And if it's late at night and you're not so experienced, it can be missed. Then, as you also know very well, it's really a multidisciplinary effort with a lot of communication between the ambulance team, the radiologist, the neuroradiologist, and so on. So a lot of communication needs to go on between different teams, different care settings. Transfers take place, rescanning takes place, and the consequence of all of that is that time gets lost. And roughly 40% of patients that are eligible, that are sent to mechanical thrombectomy, still arrive too late. And as we all know, time is brain. So, obvious question, what can we do to save time, to save brain? And there's a lot of things we can think about, right? Starting with awareness among all of us, among the general population, for the symptoms of a stroke, recognizing it, then having really trained staff in the ambulance that comes and picks up the patient, getting a faster CT, many things we can think of. In this talk, I would like to focus on 3 aspects. The first one being direct to angio. It's a radical pioneering workflow based on significant improvement in cone beam CT, and we will talk about that. The second aspect is on the angio lab, on the interventional X-ray in the lab itself, focus on improving the workflow there. Again, stroke is an acute setting, workflow is critical. And the third one, as it's multidisciplinary teams working together, we need to enable them with better communication and data transfer. Let's jump into it. Cone beam CT. What we have seen over the years is that cone beam CT is still not as widely adopted as we think it should be or could be. Now, why is that? 3 reasons. First, it is still often considered difficult to do 3D CT-like imaging in the angio lab. Second, if you want to then visualize and manipulate the acquired CT images in on the older systems, you needed to go to the control room to do that. It was not possible to do that tableside. And thirdly, also if we look at visualization and measurement tools compared to regular CT, they were quite limited. So these are the reasons that we see why cone beam CT in the angio lab is not yet as widely adopted. Now, reflecting on this, we have introduced in 2021 a new version of cone beam CT that we believe addresses these challenges, that we believe brings solutions to these points. And we call it Smart CT. And what it does is it makes it really easy to perform the 3D CT-like imaging in the angio lab with clear step-by-step guidance. And secondly, it enables you to visualize and interact with the resulting CT images on a tablet at the table side. And this tablet works like our iPads, like our smartphones. So we like to say, if you know how to use a smartphone, then you know how to use Smart CT. And with that Smart CT launch, we have also brought better visualization and measurement tools to the angio lab. Let's see how this works, if hopefully the video runs. Yeah, so here you nicely see it, step by step, step 1, step 2, and step 3, then a fast scan. Yeah, and you can fully control the acquired CT image at the table side. You see here, it's like an iPad. You can zoom, you can with 2 fingers. It's as you know it from your tablet. Yeah, but what we have seen so far was focused on workflow, and that is very important, but we don't stop here. It is also about image quality, of course, when you think of cone beam CT. And next year, we will again launch a new version of cone beam CT in the angio lab. This time, the improvements will focus on image quality. What will be new? 2 things will be new. First, the trajectory, and you see it on the screen. This is a video from our research lab in the Netherlands. The frontal arc that follows what we call a butterfly movement. And with that, it acquires a bit more field of view that enables better image quality. And then the second thing that is new, in addition to this trajectory, the second thing is new reconstruction algorithms that reconstruct out the cone beam CT artifacts and the bone shading artifacts, and with that significantly improve the diagnostic quality of the image. And we show that on the right side of the screen, where you see the comparison in the image quality between the current cone beam CT and the next generation that will become available next year. Now, so with that, we talked about improved workflow, a simpler way of working with Smart CT. We talked about significantly improved image quality. Now the question is, what could this mean for stroke patients? And there are several single-center studies that compare the patient outcomes of direct-to-angio workflow with the current established routine with CT. And what you see in these single-center studies is that the time saving with the direct-to-angio workflow is 40 to 70 minutes. And if we know that with every 30 minutes delayed every 30 minutes delay mechanical thrombectomy, the probability for a positive patient outcome, meaning no functional disability, changes with 15%, then 70 minutes is a lot. But these are all single-center studies, and you can now say, yeah, single-center studies, they can be biased, and it's true, can be biases. So therefore, Philips has decided to sponsor a first multi-center randomized trial, the WeTrust study. And the WeTrust study has the objective to show the patient outcome benefit, but also the health economic benefit of the direct-to-angio workflow. You see it here illustrated. It's quite simple. You take the CT out, you send the stroke patients with a large vessel occlusion directly to the angio suite, where you do a cone beam CT, and then afterwards a mechanical thrombectomy on the same table.
As I said, the objective is of this study, of the WeTrust study, is to demonstrate that direct to angio results in superior patient outcome in ischemic stroke patients with confirmed LVO compared to the conventional CT-MR workflow. It is a multi-center study, 16 centers on 3 different continents, Europe, North America, Latin America. 500 plus patients will be enrolled. We stand now, as far as I know, between 60 and 70 patients are enrolled, so it will still take a bit. And hopefully this can then show very clearly and without bias the benefits of the direct to angio approach. And this can then also help to reconsider guidelines. So we talked about cone beam CT, improved workflow image quality, the potential for direct to angio. Now let's look at the AngioLab and the interventional X-ray platform, where also we see a lot of potential for workflow improvement. Again, all workflow improvements I think are very important for you to treat stroke well, because it's acute, it's hectic, it's often at night. Let me introduce to you our Philips Azurion platform. It is our latest image-guided therapy platform. It was co-developed with physicians, and it's a very popular system. I'm happy to say that we're very successful with it globally, also in Europe, also in Central and Eastern Europe. Users appreciate it for its image quality, for its exceptionally low radiation dose with the unique Clarity IQ technology. And I think especially for stroke, worthwhile to highlight is that it's really an easy to use system. Very intuitive user interface enables an efficient care delivery. But let this not be said by a Philips person. Let's hear from a user. We have a short video from Professor Spelle in Bicêtre in Paris, and let's play it.
I always say that if you don't see, you cannot treat a patient. The Azurion brings a complete rethinking of the system.
So Philips Azurion is the new generation of imaging-guided therapy platform that we use. It is very intuitive. It's more accessible, faster. We always want to do more with less radiation, less time.
Le parallel working, c'est une grande nouveauté qui nous a beaucoup plu pour les manipulateurs. On peut post-traiter les images en même temps que l'opérateur poursuit sa procédure, sans gêne du tout de l'un vis-à-vis de l'autre. Le parallel working nous a permis d'obtenir un gain de temps considérable pour le manipulateur.
The tablet, a so-called TSM, that we are using to control the system. What I love is the possibility to digitally zoom and manipulate the picture.
Zooming is a great thing, and it's so easy right now. It's just with a 2-finger touch. It's very important for us today to have the highest level of image quality.
So you have the VasoCT, which we do perform systematically during a procedure to assess the perfect apposition of a flow diverter or an intrasaccular device. You see the threads made of nitinol. It's incredible, the resolution that you can have on the screen. You have a 2 or 3 millimeter diameter stent that is filling the whole picture, and you don't lose any resolution in that. And the improvement of the Clarity system is a roadmap. You cannot believe when you are injecting liquid embolic within a brain AVM, you don't see the movement of the liquid embolic that has been injected. And when you want to refresh the picture, you just have to push on the button, single button, immediately you clean the picture and you clearly see what's arriving. The way I recognize that it has changed my life is when I'm going in other cath lab, using other machines, then I realize what were the improvements that we had by the last evolution of the Azurion system, which is really a big achievement. This is the best system manufactured ever by Philips.
The best system ever manufactured by Philips, says Professor Spelle from Paris. It's nice to hear for us. We're very happy about this feedback. And the good news is Azurion is available in many flavors. And that is important because it needs to optimally fit your needs, the needs of your team, and your procedural focus area. So it's, of course, available as a biplane, as a monoplane, as a ceiling system, as a floor system, in different detector sizes, and with procedure-focused software packages and upgradable over the entire lifetime. Yeah. And we don't stop here. Next year, we will again launch a new biplane focused specifically on interventional neuroradiology. And let me just show you what is new, in addition to what Professor Spelle has just talked about. So what is new is 135 degrees of freedom on the frontal arc, which is helpful if you need to access the head during the procedure, to place a headrest for anesthesia, for example. There's also faster lateral movement and faster parking, which helps if you want to switch from 2D to 3D. And the system comes with image beam rotation, so you always have a patient-centered image independent of the angulation. That is available in 2024. Now, we talked about direct-to-angio, cone beam CT, we talked about the Azurion, the workflow advantages of Azurion. The third topic I would like to cover in the remaining 4 minutes is better communication and data transfer for these multidisciplinary team that tackle stroke. And here we are partnering. We're not doing this alone. We're partnering with a company called Nicolab. And sometimes I get the question, why did you choose Nicolab? Now, the main reason is Nicolab was a spin-off of the Mr. Clean trial. And the people that founded Nicolab are still connected to Mr. Clean. Some trials are still running. And Nicolab has access to the Mr. Clean database, which is one of the best, if not the best, patient database for neuro algorithms and so on. So those are the reasons why we chose Nicolab. Now, what is Nicolab offering? It's a cloud-based solution, doesn't require any hardware in the hospital. And I understand when you talk in healthcare, when you talk about cloud, in many countries that is sensitive. Nicolab's cloud solution is fully compliant with all the regulations in the US and in the EU. To give you an example, the veteran hospitals of the US Army, a large hospital group that belongs to the US Army, also works with Nicolab, so it is a very safe solution that has 2 components. The first one being a sharing and communication platform, the second one being AI-based diagnostic support. Now, let's look at the first part, the communication and sharing platform. How does it work? Well, you define a network of people, of radiologists, neuroradiologists, and they get a notification on their phone. They have the Nicolab app, they get a notification, it says, suspected LVO case. Then you have a mobile mini-PACS on the phone that gives you all the patient data. You have a DICOM viewer where you can look at the acquired CT, MR, ultrasound, DSA, and it is certified for diagnostic use. Of course, you can also look at it at the workstation or at the laptop, but if you want, some clinicians want that, you can also do the diagnosis on a handheld device. It includes also automated quality checks in case the CT is not good enough, it highlights that, and it enables, of course, that is the main purpose, network-wide image sharing and also real-time collaboration on it. You can, together with the second person, you can share it and go through in real time and discuss it also, have a call, discuss it, get a second opinion. This is the communication part, the data sharing part. The second element is around diagnostic support, and this is enabled by artificial intelligence. So hemorrhage detection, is there a bleeding, aspect score, LVO detection and location. And to my knowledge, Nicolab is the only company that also offers LVO location. I don't think that Rapid and Brainomics, other companies that offer similar solutions, offer that. Another difference with Nicolab and advantage, in my opinion, is that Nicolab also covers the M2 segment, so not only M1, but also M2. You have the collaterals and the perfusion. And again, a short video from the team in Bicêtre that is using it.
Hi, I'm Dr. Cortez. I'm an interventional neuroradiologist here at the Bicêtre Hospital. We use Stroke Viewer in our facility to have a mobile access to the patient data and information, and it facilitates easy communication by collaborating together. The app is available 24/7, so we can use it anytime, anywhere. First, I get a notification on my phone, then I can just open the case. I can review the timeline, I can look at the thumbnails. When I'm looking at the MRI images, I can enlarge them or change the brightness to feel more comfortable. If I need the help of one of my colleagues, I can use a collaboration. I share a link via a text message, and we can start to share and to make a precise diagnosis. Once we both have access to the images, we can share on it together. If needed, we can scroll through the DICOM MR images and choosing more than one scan to be sure not to miss anything. With the mobile DICOM viewer, we can access the native MRI images anytime, anywhere. What's nice is that we can look on the app. We don't need to use a workstation because it's certified for diagnosis use. For the CT scan, the algorithm, it helps to detect the occlusion, and with a blue bounding box, you can clearly see the suspected occlusion, including the collateral scoring and coloring, which helps to make the right decision. If I don't have access to my phone because I'm scrubbed in the block, I can actually access the images of a Stroke Viewer in the Azurion without losing time or having to scrub out. The collaboration functionality, it's a real plus because we can make a real-time decision between two physicians and more as we use the chat to discuss about one case. All of that helps us to save critical time for the patients. It also helps with the stroke flow within the hospital. All of this brings the patient faster to the angiotubes.
So what I would like to add to this is that, of course, Nicolab and Stroke Viewer is fully integrated with the Azurion. I think it's, again, important from a workflow aspect. You have full control at the table side. You can view all the patient images and data in the Azurion Angio Suite. And even if, from an ambulance or from a referring hospital, they send the patient data to you via Nicolab, you can directly on the Azurion, on the FlexVision, get it on the screen, prepare for the patient while the patient is in transfer. So wrapping up, we have strong evidence for mechanical thrombectomy. Fortunately, still as many bottlenecks, and I think we really need to speed up the door-to-groin time. Cone beam CT image quality and workflow has really improved, and we believe can play a big role in achieving that. Therefore, we're doing the VTrust study, a multi-center randomized study that hopefully will prove better outcomes with direct-to-angio. And last 2 points. Next year, we will again introduce a new Azurion biplane with better workflow specifically for neuro, and it's all integrated with Nicolab for streamlined communication across these multidisciplinary teams. Thank you very much for your attention.
There is no time but time for one question.
I have an honest question. I'm a good believer of one-stop shop concept, because actually I was so stupid. I was the father of this name when we were developing Icona with the Siemens, okay, and their advisory board. I should have gotten the patent of this name. So now you have much better CT quality. You were behind, but you have actually better CT quality than Siemens. But you have a volumetric also scanning. So what is holding your hand not to have a full CT perfusion with MTT, CBF, and CBV like Icona, so you can install the rapid and you can really create the full one-stop shop stroke service?
So you don't have CT perfusion. The reason under that, never get the answer of this question, is because of patent issue of 4D angio, because the Siemens, how Siemens did the CT perfusion, full CT perfusion, is the data set of this volumetric 4D data. That's how they developed that. So why you don't do this? This is some patent issue or what is that? Do you have an answer for that?
Yeah, I think it's a different approach. We have a different perspective on the 4D concept that Siemens has introduced. There is no, at least not that I'm aware, there's no patent limitations. We can discuss it in more detail offline.
You should do time resolved 3D change the AVM treatment dramatically. I mean, it's without 4D angiography, for example, when I was invited to US for an AVM proctoring, I told them if they have a Siemens, if they don't, I don't go there because I don't treat AVM without 4D imaging. But it's a very small niche, it's not important, AVM business. But you have a very good quality of CT. It's actually better than Siemens now. And I think you should do...
And you're referring to Cone-beam CT image quality?
Yes, Cone-beam CT. Yeah. I mean, you should do, time resolved 3D, and you should create full CT perfusion like Icona does. Then we have a one-stop shop.
Thank you for the feedback.
Yeah. Thank you very much. We have to move because we are behind schedule, so...
Makes it smile.
Yes. Professor Bachvarov, 10 years experience in neuroendovascular interventions.
So, it's a pleasure for me to be part of this event. Professor Serakov taught us the treatment of aneurysms last 10 years in Bulgaria. Varna is also in Bulgaria. It's a little joke, but our presentation was included later. So we are a university hospital on the other part of Bulgaria, and our patients are coming from one quarter from the territory of the country. This is important, and also it's important to create a team like orchestra, like football team or everything, where every one of this team knows what must do to have finally a very impressive result. This is our new angios, is 2019. Equipped with modern machine and everything which is necessary to perform neuro interventions. In our institution, we do often CT angio. It's easy to see the pathology, to assess the morphology of aneurysms, and side of bleeding, the blebs. Maybe here I have to say that in our institution, the main number of patients is with ruptured aneurysms. We have no time to discuss and to explain why, but many in our hospital we do ruptured aneurysms, and this is important for organization to assess the pathology in this multiplannar reconstruction. We can see that in one moment we can assess in this patient we have 3 aneurysms, and the bleeded one is the smallest at A-comb. This is 3D reconstruction, the same patient. And of course we do rotational angiography. Is of extremely importance to see the morphology of the aneurysms and to assess also the vascular spasm, you see. Our principles that we follow are as soon as possible, but we know that there is no clear difference between early and ultra early treatment of an aneurysm, because in some cases the patient comes 2 hours after the stroke, and we work too early. The patient is not so stable, but of course we're trying to do everything as soon as possible and early as possible, because to avoid vascular spasm. We know that this is endovascular treatment is only one stage, one step for a long process of treatment of the patient. And we follow strict algorithm from the beginning to the discharging of the patient, and we try to create a common language. So it was discussed that there are many options for treatment, but in cases of ruptured aneurysms, we usually do coiling, and this is our experience. 214 endovascular embolizations, and yes, we put also N4 diverters, but that was in patients where we saw a complex pathology and they underwent several steps, several interventions. I will show you one of these patients later. This is distribution of the aneurysms. It's statistically maybe important for some of you, but every one aneurysm, when it's ruptured, this is case of emergency, and we have to work. In early hours, in first 3 days, the most of patients are relatively in good conditions. This is normal, you know later what's happened. We make assessment of the supraarachnoid hemorrhage by Fisher scale, and of course we use Handy Hertz scale. This is important that up to 24th hour we try to do treatment to perform embolization. And better outcomes we observed in patients with a single stage and early diagnosed and endovascularly performed intervention. Of course, in some patients with ruptured aneurysms, it's difficult, and with more than one aneurysm, it's difficult to say which one is ruptured, and maybe this is moment when endovascular procedure is better than open surgery, because if we have right-sided hemorrhage and we have two aneurysms, ACOM and middle cerebral artery, for neurosurgeon, I think it will be more difficult to perform in one session two clipping. This is an example for a patient with a huge aneurysm, with ruptured aneurysm. He survived. We performed embolizing first, and then we put a flow diverter. We have one another patient I will show you. We use this scale for assessing the aneurysm embolization, and we have not enough time. We have patients with not good outcome, but we have to know that in patients with ruptured aneurysm, not every good embolized aneurysm means final good result. Different, and these are common complications, and we are in the middle of the these reports. So a few words. I'm going to show a person with ruptured aneurysm, pregnant lady. So this is part of the game, and we, as radiologists, we have to know that we have to save not only 1, 2 lives, and we have to protect them by radiation, to avoid radiation. So this is important to think. And this is a lady in 20th gestational week with ruptured aneurysm of narrow communicating artery and embolized. Of course, this is example, you saw the rotational angiography. This is the procedure, embolizing, and a year later, excellent packing. This is interesting patient. It was 7 years ago in our hospital with this ruptured jet aneurysm. We put coils. Of course, in 1 year we saw this finding. So it was necessary to put more coils and to put a flow diverter. This patient will come in 1 month for follow-up angio. Unfortunately, now I'm not able to show you what's happened. This is an example when we can perform in 1 session embolization for more aneurysms when they are on 1 side. I think this is obligatory. Final result with embolized aneurysms and the flow basilar tip aneurysms. They are very deep water because in this the bifurcation of the basilar artery, this is this plastic segment, and it's difficult to work. These are a cohort for 5 patients, and I want to show you big aneurysms. First of the 2 patients has intraparenchymal hemorrhage, and despite this difficult finding, they survived without neurological deficit. The third one, you can see the peripheral spasm, and this lady had small hemorrhage, but in next days we saw severe vasospasm. This is important. And also for for AVMs, we have less experience, but we met 2 children, and we in this condition have to work. So it was lucky, we were lucky, and patients also. We embolized these aneurysms, and this is a beast also in posterior fossa with this final result. So it's important to underline that this is severe pathology. It requires experienced team, and we have to try to treat them as soon and early as possible to have good results. Thank you for your attention. Yeah, okay.
Thank you very much, Professor Bashvarov. Maybe time for 1 question. If not, we move to the next speaker. Vaite Wang from Austria, from the Vienna team. He will give a talk about hybrid treatment of complex MCA aneurysms.
So yeah, good afternoon. Thank you very much for this invitation. It's an honor to be here and presenting our data from Vienna. Yeah, this is okay. Yeah. Oh, sorry. We already said. My topic today is hybrid treatment of complex middle cerebral artery aneurysm. It's a retrospective series over a period of almost 3 decades, because it's a rare disease. And as I show you, you will see that over the time, because of new technologies, endovascular techniques, you will see that we also changing our treating policies. This is our team in Vienna, current vascular team, led by Bawiński. And yeah, Vienna, sorry, first, no conflict of interest. Vienna is different, a little bit different, because this is also the official slogan. Statt Wien, Wien ist anders. We are hybrids, means we have a neurosurgical background. We do endovascular since beginning 1980s. And so we will see sometimes we have different approach to vascular diseases. Yeah, difference, this is for me nothing new. I'm born in Taiwan, raised in Austria, trained as neurosurgeons, but work in endovascular. So it's absolutely my field, with other words. Now go back to complex medial cerebral artery aneurysm. It's a rare disease, especially complex aneurysm. The definition of complex aneurysm is difficult. There is not a really straightforward definition, but if you go to recommendations, you will find this aspect: giant localization of difficult access. I mean, from surgical point of view, posterior fossa is really difficult. Posterior circulation. And also the configuration of the aneurysm, you need to consider how it looks like: broad neck, fusiform, or other anatomical aspects. Now, of course, wall structure is a blister-like aneurysm, is a calcified, is thrombosed. This is also things you have to take into consideration. And one thing is also, the first glimpse, you think it's an easy aneurysm, but it turns out that it regrowth. You treat it several times, and maybe 3 times, 4 times the regrowth. Maybe you have to reconsider that the aneurysm is a complex aneurysm. Good. Now, after this so-called definition, you can imagine and if you work in this field, and all of you know that they have a complex medial aneurysm has different phases, as you can see here. This is only few. So the treatment strategy is very, very different from case to case. From surgical side, the idea is to exclude the aneurysm regarding the size, and so there is no circulation inside and no fear of hemorrhage. This can be done by parent artery occlusion with or without bypass protection, and this is a list of possibilities developed over the decades, and then you here in this publication in the Lawton's group when he was working in San Francisco. This is a very good paper. If you're interested, I will refer you to this one. From endovascular side, over the years, over the last 30, 40 decades, if you consider coiling as the first good, detachable coil as the first good technique, then it's almost more than 30 years. Now you have neck bridging devices, you have intersaccular devices, and what we all love is flow diversion, of course. I think the next topic is about this. So what's the role of a hybrid neurosurgeon? Over the last 30 years, because of the changing of techniques, we have collected a series of 26 patients, which are done, most of them after bypass protection, with or without surgical techniques, means clipping, exclusion of aneurysm, or also endovascular modalities techniques. These are few figures we get from our technician, that you consider every single aneurysm, complex aneurysm, as different, and so there are different strategies which is possible. Now, this is our number, 26 patients. Yeah, 2/3 are female. Most of them presented with bleeding, and also, of course, it's very like vertical headache. So these are, it's difficult. It's not really symptoms, but this is a next large group. And as you see, most of the aneurysms are almost giant if the definition of giant is more than 2.5 centimeter. The location distribution in M1 segment is like this. Most of them is located in M1 and 2 bifurcation. Yeah, we have 26 patients. 6 of them get purely endovascular treatment, 4 of them coiling, 1 stent coiling, 1 flow diversion, and 20 receive bypass protection and further treatment. And as you can see here, 40 patients, that's a majority. Our concept was bypass protection and then occlusion of M1 segment, either by surgical or in the recent, for a long period with coiling. And the others are now bypass coiling, flow diverter, bypass clipping, and one really, the last one, re-implantation, interposition. I think with today's techniques, we won't repeat this anymore. This was back when other possibilities, especially endovascular possibilities, are limited or is not possible. Now, I show you briefly 2 cases. This is what we normally do. It's a large aneurysm, partial thrombose. So we put a bypass, 2 pedicle bypass, as you can see from here, and then occlude aneurysm, choroidal aneurysm, including media bifurcation. So for this, you've talked before, maybe you can do it without bypass protection. We are always afraid of ischemic events, so we do bypass protection. In this case, we want to occlude M1. This is, I can see the final result. Here is the bypass, 2 pedicle bypass, which work for 2 or 3 decades in our department. Final result, 5 years follow-up, MRI 0, MRI negative, the patient refused angiographic control. The next one, this is a 40-year male patient. It's also a giant thrombose, M1, M2 bifurcation aneurysm. Initial onset was seizure, no bleeding. We don't know, maybe we will do it differently nowadays, but at that time we called it. The result was, of course, with a small neck realignment, but okay. But as you expect, because of the thrombus, it's regrowth. Reperfusion after 16 months, second coiling, then 2 years later, regrowth again or reperfusion, and so we decide for our all good technique bypass. In this case, we just did a single pedicle bypass, and the idea behind that was we have flow diverter. We coiled this rest, and then we put a flow diverter into the lower branch here. You can see here the flow diversion, and we hope that this will thrombose and there is under bypass protection. Interestingly is we control it just this month, and we have this situation. Because there's MR control, you see still something around this aneurysm, around the flow diverter, and for this reason we did a control angiography, and this is what we see. The bypass is working. On the right side, you see the internal carotid artery. This is a 3D reconstruction of a common carotid artery, and you can see, and then if you do the working projection, you can see here flow diverter is working, but there is still some leakage through this here. This is thrombus area, and there is still a little bit perfusion to the upper branch, but we will keep it this way. We accept the situation. So, we achieve it on the whole clinical outcome with all our techniques in most of cases, we achieve a better outcome than the initial MRS score. Of course, in 4 cases, it's situation worsens. We have also one patient who died of our procedure. Another one is a post-operative myocardial infarction, but this is not, this is another case. Imaging result is, we perform around 70% of the patient cases angiography. We still call the patient to do a control. The patency of bypass is in 85%, 3 cases occluded. And the occlusion rate of the aneurysm in the imaging is almost 80%. There are some with remnant, residual, and we have also achieved flow reversal. But these cases are stable, so we'll keep it like this. So with other words, over the years we have developed different strategies. It's a work on progress. Of course, nowadays we will not work like 30 years ago because of other future possibilities and future techniques. So thank you very much. My time is out.
Thank you, Vaite. We move to the next presentation because we are much behind time. So Professor Sekirce will talk about flow diversion, the flow remodeling as next generation treatment concept. Simplicity is the most ultimate sophistication.
Thank you, Nurfet and Eva, for this kind invitation. It's always good to be here. And yes, I'm going to be talking about art of simplicity. So the revolution of parent artery and neck reconstruction in the endovascular aneurysm treatment had been started, actually, I would say, in Ankara in late 90s with the implication of liquid embolic, Onyx HD 500. So these slides are like 23-year-old. So basically we started to reconstruct and we started to create our own stent with the liquid. And basically it wasn't working because we still had a bunch of regrowths. Then we start to implicate using stents. At that time, the stents were like a Medtronic S670, very old coronary stents. They were very hard to navigate. The procedures are very complex. But reconstruction was nice. But some aneurysms had been needed to be excluded from the circulation because of the mass effect issue. Then we discovered the idea of the aneurysm and we described the aneurysm exclusion with using cover stents, which was actually the leading point of the last revolution, which is the flow diverters, because putting a cover stent is the most ultimate flow diversion at the neck of the aneurysm. However, you cannot do everywhere in the brain because there are side vessels, side important vessels. In this traumatic aneurysm, it was possible to do that. And actually, long-term controls of these cover stent cases of our series is very good. Finally, in 2008, the real revolution became realized by pipeline device, and we realized that actually we can reconstruct those ugly parent arteries, not only treating the aneurysm, but also the parent artery. So then we realized another revolution with the results of the cases. Then I think the most important part of this revolution and change is flow diverters has been making the treatment of the aneurysms possible, especially located in bifurcation with an important vessel coming off the sac, which used to be a major limitation for endovascular treatment. I remember, these fenestrated clips, all kind of surgical things for such aneurysm. It was not easy to do, even with open surgery. But just you place a flow diverter, and according to the flow demand of these integrated vessels, there is a new remodeling. So in follow-up studies, we start to understand the effect of flow demand with structural changes. And when we take one of these fenestrated arm, and you realize a new basilar artery is forming. And basically, it depends on the flow demand of this important integrated branch, which is anterior choroidal artery here. It has this origin. Now it has a new origin because of the aneurysm remodeled, and we have a new anterior choroidal artery segment here, because the treatment is very, very intelligent. And this is a very dysplastic segment of artery, and the selection of flow diverter is very important.
good chrome cobalt, changing this geometrical modification, create your own bypass. When flow diverter placed at the neck of the aneurysm with an important vessel, coming off the aneurysm sac, according to the flow demand of that particular vessel, you have a different setup of the follow-ups. And you can have nice results like this, with perfect aneurysm occlusion, with the patency of the integrated branch. And also, you can have, we call it now class 5 stable remodeling. Some of the aneurysm stays there because it needed to be keeping the flow conduit of that integrated branch here. We call it class 5 stable flow remodeling according to the new classification. What is the art of simplicity here? It's just a wide neck basilar artery and tip aneurysm with a PCA and superior cerebellaris coming off the sac. I love doing white stenting, doing all kind of tricks there, and you can do that now. We have the tools, but just think about this simplicity. And this is the 6 months follow-up, and this is the 1.5 year follow-up. And look at the 3D. While the aneurysm is being closed with remodeling, the sac become continuation of the left PCA and SCA with two separate channels, with both vessels became thinner hypoplastic. So basically, it happens with the flow demand of this particular vessel. And it allows us to treat the aneurysms not only from parent artery, it's away from parent artery. We call it indirect flow diversion. The aneurysm is originated here from the superior trunk here, but you just place a flow diverter in front of the secondary parent artery, and you just modulate the flow, get this class 1B occlusion, which has a aneurysm occluded, but also integrated branch is hypoplastic. So in the old days, when we had the first flow diverter, which was a silk, I was so proud of this result, because at that time the concept was this, just you have to place the flow diverter at the neck of the aneurysm. But today, if I do the same case, I was going to definitely do this, because we have developed the concept of art of simplicity. This is a patient came to me from Finland, has been offered to be a lot of complex bypass surgeons. She has 3 sisters, bled and died because of SAH, and we just place a flow diverter at the word, and there was no flow demand of that pica, and the aneurysm is gone. There's a little bit of intramural hyperplasia, but asymptomatic occlusion of the pica. If there is no flow demand, if there is a potential collaterals, we have asymptomatic occlusions. So here's another case. The only problem of the flow diversion is we don't know how many flow diverters we needed to beat up that flow demand to be able to have this remodeling. In this case, again, asymptomatic occlusion of the pica. Because there is no way to predict that. It's just do it with the experience. So this is an ICA aneurysm with integrated ICA, obviously, and couple of flow diverters placed at the base of the aneurysm. This was a ruptured aneurysm. I tried to go in from above and below. I couldn't get into the aneurysm from that dissected segment. And as a treatment from a distance, we call it, 1 year later and 5 years later, you see that the aneurysm is gone, but the vessel is remodeled. So this is a treatment done from the basilar artery, not in the ICA. This is a patient which we treated years ago in at one of the World Life Neurovascular conferences. Look at this complex MCA bifurcation aneurysm. The multisegmental disease continues with the superior trunk, and basically the stent, flow diverter stent, which is pipeline, placed in the inferior trunk. In the follow-up, not only main aneurysm is gone, but the indirect aneurysms of the superior trunk is gone because of the class 1B occlusion, because of the flow remodulation. Because of this remodeling effect, we come up with this new classification system. Because Raymond-Roy was not enough, we divided the class 1 occlusion according to the patency of the vessel, the class 1A, B, C, and also the class 5 stable flow remodeling. So if all bifurcation vessels are patent, it is class 1A occlusion. If this integrated branch becomes hypoplastic with the flow diverters, it is class 1b occlusion. And if it is in a longer period of time sometimes, showing an interval change, and control angiography shows that sometimes class 1b occlusion, actually, if the vessel become continuation of the integrated branch, if the aneurysm sac becomes continuation of the integrated branch, we can even call in the first control angio as a class 5 here. And especially for PCAM aneurysms, we have to develop, because we are radiologists, when we see aneurysm remnant, we say, oh, there's a remnant. And this is the 10 years follow-up after placing 3 flow diverters across this giant, partially clouded PCAM aneurysm. And how you call this result? Is it a failure or is it a treatment success? According to the Raymond-Roy classification, it's a failure. It's still aneurysm filling there. But they stay stable in the many follow-ups. So then we call them class 5 stable flow remodeling, because that part of the aneurysm, which at the base of the sac, it becomes continuation of that integrated branch, which has a lot of flow demand, which is the embryonic PCAM. It's a similar experience. So this certain paradigm shift created by the flow remodeling concept in sidewall aneurysms inspires us into the treatment of complex bifurcation aneurysms, and we start to look them like this. So you look them like this, so then the treatment is easy. So this is an aneurysm. One of my former fellows left his fellowship and treated immediately after finishing her fellowship. This was an aneurysm that we used to deal with all kinds of tricks, wire loops, and in surgery, hypothermia, bypass procedures. And look what she has done. This is 8 years follow-up. So basically, the treatment goes there. These are the cases that we used to proud of, and we used to proud of to showcase in the WLNCs and old ACNR link meetings that we used to do with Jacques, and I was doing Y stenting, X stenting, double balloon remodeling, and we love that. We love doing these loop techniques and everything, and look at these aneurysms. Now these are possible to treat with this double stent assisted coiling, but a lot of hustle. So can we treat bifurcation aneurysms in such geometry even today with these aneurysms? I'm not sure. So if we place a flow diverter at this neck of such aneurysm, the result is reproducible. When I first showed this in Val d'Isère in 2008, I was almost being shot there. And this is the results in 18 months. Is it reproducible? Yes, we prove that it is reproducible, but with the right medication, right anti-aggregation. This has been definitely reproducible in such a case with the integrated branch, which there's a stenotic here, and look what happened like 6 months later. Very intelligent behavior after placing a simple flow diverter placement at the neck of the aneurysm here. When we treat bifurcation aneurysm with flow diverters, first we got to understand the concept and target. Simplify and geometrically modify and let it remodel. So how you simplify? You directly go to the straight axis. So endovascularly complex case, surgically easy case. But with flow diverter placement to the easy access here, it is endovascularly easy case too. This is 2 years and this is 3 years. Geometrical modification and related flow diverter selection is important. That's why I jump into the Vantage talk today. With Vantage, you cannot do this geometrical modification of real chrome cobalt stent. Look what happened here. Look what happened pre-treatment angle and 7 months angle. All integrated branches patent, the aneurysm is gone, aneurysms are gone, and you have complete geometrical modification, which nitinol flow diverters including Vantage, cannot do. So we have to suffer a little bit when we place them in. So if there is no flow demand, with the long term, we can have class 1C occlusion, like to lose of the superior trunk, which is not a problem because they are all asymptomatic and it happens in a long term. So many, many examples. I don't want to have this ring. So if both trunks are relatively easy, always choose the trunk that is larger and you would create more significant geometrical modification. Some can ask me that, hey, doc, why you do this with a regular technique? As I told you, the more I see the results of flow diverter, the less I do this Y stenting, X stenting, stent-assisted coiling, because it is the art of simplicity and it is the result. So if both trunks are difficult, dependent endovascularly, then choose the larger trunk and let the smaller one remodel. This was a case that we did live in WLNC, and basically the inferior trunk is the larger one, superior trunk is the smaller one. They are both integrated, so we made a loop, small bypass, and we changed the geometry with the regular pipeline shield stand. This is the 6 months follow-up, and this is the 3D pre and 6 months follow-up. The target of simplicity in ACOM aneurysms are same. Flow diverter is to be placed from non-dependent, straight, easier A2 trunk, preferably from the ipsilateral A1, like in this case. This was a previously ruptured case, not in Daniaku stage. The A2 is integrated, so you place a flow diverter from A1 to A2, jailing the aneurysm and the other A2. And before treatment, this is 6 months follow-up, total occlusion. There was very small A1 here. Now at the 6 months, we have a larger A1. So it's basically very intelligent to see. This is a nightmare of surgery or endovascular. It's the subcallosal artery is coming off the aneurysm sac. If you clip this aneurysm without recognizing, or if you coil this aneurysm, the patient is going to be a plant because it's the terminal nominal is going to go, and basically this is going to be a horrible problem. But look at this simplicity. A1, A2 flow diverter, 6 months later, aneurysm is gone, because that subcallosal artery, like anterior choroidal artery, is very good flow demand. It keeps its patency, and this is the 1 year follow-up. To be able to have this, modern anti-aggregation needs to be adapted. In the early stage, even my good friends and Laurent and Jacques did a paper saying that flow diverters should not be used because what they had as anti-aggregation in Europe at that time, because of financial reasons, they couldn't use Prasugrel or Brilinta deticagrel. With clopidogrel, it is impossible to have such a treatment, make such a treatment in a low morbid mortality. Clopidogrel is a completely unreliable drug. It can be forgiven for regular coronary artery stenting, for regular stenting in the body, but in such a critical locations with very high density stents, no. So it has to be adapted. Now, all these papers writers are using flow diverters in their live cases because they change their mind after they start using Brilinta and Prasugrel. The results are better. So if you're treating such a relatively simple aneurysm, as I said, I still do flow diverter. If you don't, or if you cannot use second generation anti-aggregation, then don't do it. Just do the regular treatment. So in regard of the controversy, Charbel and I, we did a study to take out the clause out of the treatment, and both teams are very good in terms of anti-aggregation management and all that. We have the agreement of treatment, and we show that actually this treatment in a complex aneurysms can be done with very low morbid mortality. And post-treatment follow-up and morphologic expectations also had to be changed. So this is a new understanding about treating the patient, protecting from a bleeding. And if 6 months follow-up angiography shows this, and if the 18 months angiography shows this, and a long-term many of them are being followed, are staying same, so we don't call it aneurysm treatment failure anymore. Like in this case, 1 year and 3 years, very complex dissecting aneurysm with 2 vessels integrated. And another one, integrated inferior trunk in the left side. This is the 5 years follow-up. This is just a stable flow remodeling remnant. Another one, complex case, simple treatment, 1 month CTA control, and 8 months angiography, and 2 years, stable. That part of the remnant need to be keeping the flow conduit of the aneurysm. So it has to be also given some times. Don't expect that the result is going to come at just 6 months later. Sometimes at 6 months later, you still see the aneurysm is filling like this, it's an integrated superior trunk, but 2 years later, you have the complete occlusion. This is a Ishlak's case, my friends from Istanbul. This complex aneurysm with Fred Jr. closed after 3.5 years. What is the target of the treatment? Is a perfect picture, creating like 6 months, or keeping the patient from bleeding? Technique is simple. You take the easy branch, you oversize the flow diverter, preferably pipeline. I mean, this is chrome cobalt's results, and basically do the treatment. But the concept first needs to be set in our mind that simplicity is the most ultimate sophistication. So then you do your treatment with that sophistication. So obviously, the morbid mortality with the second generation anti-aggregation and with these new generation flow diverters, treatment is easy, so that's why it's low morbid mortality. We have different solutions for a similar problem. Wide neck, just finishing, last slides, don't ring on me. I'm getting offended. And web device and flow diverter. So, just finishing, I'd like to invite you all the TCT of the neurointervention, which we call it WLNC. That's what we've been discussing, and hopefully I will be seeing much of you in Istanbul this year, because WLNC rotates back to Istanbul after visiting every continent. Thank you very much.
Thank you, Professor Sekece, for your wonderful presentation. Any questions? Yes?
No. It's an old concept. We used to do that because of our mind was working in that way. And when I was placing a flow diverter into the inferior trunk, I used to check the leptomeningeal collaterals, but there is no meaning of that because the remodeling depends on the flow demand of that vessel. If there is a potential leptomeningeal collateral production of that brain vasculature, it happens and you end up with class 1C occlusion. The aneurysm will be gone and the vessel also will be gone asymptomatically, okay? But if the flow demand is not very high, but so-so, then you have a class 1B occlusion. Basically, the aneurysm will be gone, but also the vessel will be hypoplastic. If there is a real good flow demand that doesn't let the whole aneurysm occluded, then it turned out to be that class 5 remodeling, okay? If you ask me that, hey, doc, you never showed a failure. It is very low. I mean, there is not much time to discuss. There are some cases that, since we could not predict how many flow diverters we needed to beat up that flow demand, which happens mostly in the PCOM aneurysms. Those embryonic PCOMs, if you look at the papers, they say that don't do that because this is a contraindication for flow diverters, right? This is something that I completely disagree. Again, this is a decision made with our old knowledge, expecting a good result in a 6 months, 1 year, and also expecting a good result with just single flow diverter, single stent.
So in those cases, sometimes you place 2 and you don't see a positive result in the follow-up, then you place another 2. Then you finally have the remodeling. That is our problem for researchers in the future, to be able to predict a model, simulation model, to predict how many flow diverters are needed to beat up that flow demand of that particular vessel which was integrated. So basically there is no meaning of doing a test.
Yeah, just a comment. You have great experience, and of course you showed us very beautiful cases, but as you said, literature is against you. 19 studies, I think, is a recent multi-center analysis in 2023, says that...
No, it's been you'll be seeing a nice answer to that.
Yeah, okay.
In the Journal of Neurointervention. I mean, this is just, I hate some of these meta-analyses. They just put everything. I mean, for example, Laurent and Jacques, they wrote a paper. They were completely against flow diverter placement. Because of why? Because in Europe, they couldn't use Berlinta. Now, in the link, you see a lot of flow diverters are being placed to MCA bifurcation, right? So basically, that's what meta-analyses are missing.
I agree.
Because this is a progress, evolution, okay? I mean, right now, we also proved that this can be done with Charbel, with a large paper, with a very low mortality and very long-term durability.
I would suggest you do a randomized controlled trial, because after all, in the end, we have to work with evidence-based medicine.
That's the problem, and there is, I mean, evidence-based medicine, we can discuss these hours, and right now, if you invite me to a randomized, involved my case to randomized trial, I will certainly reject. Why?
Yes.
Because I don't want to risk my patients if a computer says to me, do a Y stand in this particular case. How am I going to do this?
I respect your opinion.
Okay?
Yeah. Okay. So we have to move because we are really behind schedule. I'll try to be very fast. Could you turn off my mic because I have to go there? All right. Yeah. Okay. I will try to be as fast as I can. So my talk is about the challenges of training in vascular and endovascular neurosurgery in Europe, which, could you please put the presentation on? Okay. So, yes, I have no conflict of interest and I'm a hybrid neurosurgeon. We all know that how ISAT and Aruba changed the treatment of vascular pathology, and open vascular neurosurgery has been, as you have heard in all other presentations, less and less used, which of course has led to the fact that surgical clipping now is a relatively rare procedure in compared to endovascular treatment, and consequently there is a declining number of cases where young neurosurgeons can practice clipping. On the other hand, we know vascular neurosurgery is technically challenging surgery. Practice is often limited to surgeons with subspecialty expertise after years of training. It takes up to 10 years to train a vascular neurosurgeon after being board certified. Many of the master neurovascular surgeons who developed and refined the microsurgical technique in a pre-endovascular era are retiring. So we're facing now the situation where training of a resident in open neurosurgical technique is practically impossible in many centers. This is how it looks from 2013 to 2016. You see almost 50% reduction of the open vascular procedures. So practically, it's very difficult to sustain a number of volume. And if we look in the past, operative proficiency was achieved through case exposure. That means that the more you operate, the more experienced you are, and in the end, you become a very experienced vascular neurosurgeon. Now we have to change, obviously, our strategy because, as you heard from other presentations, there are places where less than 10 aneurysms are clipped per year, and in a scenario where you will have recanalized, partially coiled aneurysm that is actually bled. You will have a scenario where an inexperienced surgeon will need to do something or let the patient die because he cannot send this patient to 500 kilometers away where you would have a very experienced neurosurgeon. So we have to see a way how to train these people in the future and how to have vascular neurosurgeons, of course, much less than what we had before because there is no need to have so many as before, but we need some in order to cope with these cases. So we need centralization of complex vascular cases to centers of excellence, and the future will involve tailored experience to ensure the appropriate breadth of experience in order to have a focused selection of cerebrovascular cases. Competency will be measured by technical proficiency and complication avoidance, as always, and management as opposed to case volumes. Operative simulators of vascular and endovascular have entered the field. I'm the director of the hands-on courses of the European Association of Neurosurgical Societies, and more are implemented in both modalities and definitely will play a very large role in open vascular procedures because to learn the anatomy, to find the right strategy, the right angulation of clipping an aneurysm. You will not have the opportunity to see this like before in operating 150 patients per year in a center. So you'll need to train this virtually to see and in order to prepare to be ready for such a patient. These are two simulators developed in 2 European countries. One is Switzerland and one is Vienna, where Vitae is working, which actually are flow based, and you could actually very well simulate clipping of an aneurysm, suboptimal clipping, recanalization, and you actually both models you can use ICG and practically are used now and will be more and more used. We implement them in more of the hands-on courses of the European Association of Neurosurgical Society. Microsurgery, of course, is essential. I'm not going to go to that, but most neurosurgeons now need to, and who want to do vascular neurosurgery, need to work on increasing and improving the microvascular skills, spend hours of training in lab work and animal procedures if you want to stay in the field. We have many courses. You see that now we have, except for the microsurgical courses, it is the initiative of the ANS to train neurosurgeons in endovascular techniques, and we have been closely working with ESNR on this topic. Jeroen Bogers here is the chair of the hands-on course in Amsterdam, but in the last year there has been a clear need for endovascular neurosurgeons. And why is that? That is the topic while we are all here in the morning session, stroke. These two people that you see, the picture on the right, this is me in 2011. I went to Andreas Gruber in Vienna to be taught to learn bypass. And then I met Alex Andreou, who was hybrid neurosurgeon, Andreas Gruber, who was hybrid neurosurgeon, and many other people who are already doing endovascular treatment. So this is how the idea for me then came that probably it's a good idea to start doing more endovascular procedures. And of course, during that time, I went on an Albert Rotten course in US, and he said, well, neurosurgery open has reached its end. It cannot grow anymore, but endovascular, it will grow for years. And that is how I think many neurosurgeons got very early, like also Nuri Alioski and Professor Pesquillo, into endovascular neurosurgery and INR. So now the opportunity for stroke gives the possibility for many specialties, neurologists, neurosurgeons. Also you see today invasive cardiologists want to be involved in stroke because there is a high demand for that. And it's obvious that one specialty cannot manage the high patient number. So, for neurosurgeons, you have the two options. Hybrid neurosurgeon, a dying breed. Why? Because I was taught to clip, I was clipping pretty well, and then I did my endovascular training. Now, in this scenario, it's not possible, unless you work with Mike Lawton or some other center where they train you first to clip. Most neurosurgeons will go into the dual-trained neurosurgeon scenario, which is not bad. You do only endovascular, you do your endovascular training, and you have some knowledge about surgery. I don't believe now it's possible to go in the scenario where you're trained first in surgery, and then you go into endovascular. So these are usually, you see here, different places. On the right picture is Professor Censato, the head of the vascular section of EANS, doing a flow model with Dodi Boccarti and the endovascular course that Professor Peschilio is leading in Milan in March. So I was told there's going to be a lot of advantages. First, reduced bias. I can tell you after more than 13, 14 years, this is not true. There will always be bias towards one of the two modalities, the one you're doing better. I think in the end, the most important message is we treat our patients, and the best solution is the one that is the best treatment outcome for your patient. If this is endovascular, do it endovascular. There's no need to promote for surgery or endovascular. And this, for me, is the simple truth. Complication management, for sure, also for stroke. We have to, there are many specialties involved in stroke, but you have to be able to manage these complications of these treatments. If not, it's going to be very difficult. That is why you need a multimodal team. For example, many patients need the compressive hemicraniectomy. Some patients bleed. If you don't have a neurosurgical department, it's going to be very difficult to manage these patients if you do thrombectomy. Hybrid OR, you've seen enough from the previous presentations. Biggest problem which stands in Europe is certification. Training, there are many fellowships you can go now, ESMINT, ESNR, ENS will also open fellowships, so training is possible in many places. Certification, though, is not valid everywhere. You might get a diploma, but what will it mean to you at your own home and whether you will be able to do anything with it? Neurologist, neurosurgeon, it depends, or cardiologist, it depends. Now, in the last 4 years, we have been working closely with ESNR. The only once accredited diploma that is actually being given in Europe is the European Diploma in Neuroradiology, and it's organized by the European Board of Neuroradiology. The goal of EBNR is to provide guidance to potential candidates and to administer the final examination for the European Diploma in Neuroradiology. Practically, our President Torsten Melling has been working closely with Maida Thurner, and we hope that we're going in the same direction in terms of training. It is clear that there is need of more specialists, and actually the ESNR, for already more than a 5 years period, have opened a program for training. If you pass 1 year, the vascular model in the ESNR training program, the candidate must be a certified radiologist, neurologist or neurosurgeon. Practically, you can get the European Diploma in Interventional Neuroradiology. Invasive cardiologists can undergo training, but cannot be certified. I go to conclusion. The goal of vascular neurosurgery remains simple: to treat vascular disease effectively, efficaciously, durably, and with minimal morbidity. The reality of achieving this goal is anything but simple. I always like this chart. We train, we start with a very low level, and then we become walking gods. But it's never like this in life. It's more of a different scenario. So we have to be persistent and train hard in order to give the best to our patients. To train a proficient neurosurgeon, one who has an intimate knowledge of the risks and benefits of all viable treatment options, can be accomplished by using surgical training, adjuncts, and intentional practice, surgical and endovascular. Trainees in vascular neurosurgery should be proficient in all treatment modalities. Thank you for your attention, and I want to invite all of you next year. We have the privilege of having the European Association of Neurosurgical Societies Congress in Sofia. So whoever has interest, we would like to invite you. Thank you very much. Any questions? Or coffee? Coffee it is. Thank you very much. We close this session.
We are a little bit late, as you have already recognized. And so I would be very happy when everybody who is talking will save at least 1 minute. And now I ask the first speaker, Javdar Bakhbarov. You see, I have problems with pronouncing the name properly. And he will talk about endovascular treatment in critical carotid stenosis. Yes.
Hello. Okay, we're ready to start this session. We're talking about the carotid pathology. It's connected to it intracranial events and ischemic stroke, so it's important. Many years ago, I could say 13 exactly, we presented our case with acute occlusion of the carotid artery, thromb aspiration stenting, and treatment of acute stroke. Thank you to Ivo. He was my first teacher, and he helped me to make first steps in treatment of the carotid pathology. Now this patient is okay without any restenosis, and he's with normal life without any neurological deficit. This is awful image. Every one of us don't want to see this. And we know the causes, we know many things about arteriosclerosis and everything connected with this progression of the plaques, inflammation and distal embolization and so on. But is that only the problem as a whole, or maybe this is the carotid stenosis only some part? Is deep water. Fortunately, we have now modern imaging modalities, and at the same time, we have different options to treat this pathology. When I talk about the critical carotid stenosis, the definition is not so clear, but when we have a patient with stenosis between 8 and 99%, that means that we have significant decreasing of the flow through the affected carotid artery. And we have to keep in mind the string sign. This is pathology, angiographic finding that we can see in different pathologies, dissections, thrombosis, in cases of partial recanalization. We are flying with these two patients, the younger one and 71 years old. First one is smoker with transient ischemic attack and left hemiparesis. So a lot of problems. And the other one was without some previous history for pathology. But the second one, the male on the 71 year, also came in our hospital too late outside the window for some acute action. So this is the finding. This is the carotid ultrasound in the male with previous transient attack. We can see some changes into the brain. On the other side, obviously, there are no fresh signs for ischemic stroke. But because this patient was out the window for treatment, he underwent only conservative treatment, and he died in 5 days. And this man survived, and we will talk about this finding to the end of this presentation. So there are a lot of materials treatment of critical stenosis when patients with contralateral occlusion. Of course, we have to keep in mind the anatomy of the circle of Lewis, a type of aortic arch. It's the neurological deficit to know what's happened with these patients, can we help or not. You see a picture that you will say, what are you talking about? This is not real stenosis, some defect. This is the final result, but if you look at the first picture, you see the type of catheter. This is a Simon catheter, which means that maybe we have some problem at the level of the aortic arch. Yes. If we look at the not problem, but we have difficulty. This is V-shaped brachiocephalic trunk, and also if you look at the stenosis, this is not so simple stenosis with soft plaque, so this is a dangerous stenosis. Also, when we planning patients for carotid stenting, we have to keep in mind that these are patients with pathologies in different arterial territories, and this is example a man with severe stenosis into aortic iliac segment. We first performed the dilatation and stenting of the iliac artery, and then on the second stage we performed carotid stenting. I want to show you a case. This is a woman, 57-year-old. She came in our hospital because there is some type of stenosis. Look at the aortic arch, also V-shaped brachiocephalic trunk. We did diagnostic angio, and it's look that we have almost or maybe full occlusion of the internal carotid artery at the origin, and dominantly only we see the territory of the external carotid artery and collaterals here to the internal circulation. And because we performing neuro interventions and we have micro catheters, micro wires, I decided to cross this suspicious full occlusion, and when I injected contrast through the microcatheter at the level of the skull base, I realized that we have patent artery. And then finally the segment occluded was only this one. So we decided to go ahead. We performed balloon dilatation. We had this image, and finally we put a stent. Yes, this is very good image, but question is how often can we do that? Because if we have compensated patients with good circle of Willis, we can perform, we can produce some distal embolization. Our experience includes 123 patients, but look at patients with critical stenosis of 47, which means 38. I think this is high percentage. Every fourth is with high grade stenosis. We follow strict protocol in our institution. We perform transfemoral approach. We do heparin at both 5,000 units at the beginning, atropine also, and we exchange the diagnostic catheters with a guiding system over the wire into the external carotid artery. Also, some kind of unusual complication. This is patient from 2 weeks ago. I put a wire. You see the kinking at the left carotid bulb, and I thought that to place the stiff guide wire into the proximal external artery, it could be no problem. But I watched on the monitor, and I saw the heart rate. It was 150, 160. You know the sign. This is because I occluded completely the vessel to carotid body. So when I removed the wire, this tachycardia disappeared. We have excellent modalities to present the pathology. Once again, person with high-grade stenosis. I want to underline that balloon dilatation prior to put protective system. This is unprotected step, most risky step, and this is the critical moment for success. This is before and after. And about our patient with occluded carotid artery, but well-developed collaterals, we have to know that brain can be compensated by these collaterals from the external carotid artery. And carotid stub syndrome is event that we can meet in our practice. And these two patients are from the 2 weeks ago. In 1 day we met these patients. It's rare, but you know the law of series and so on. So this is challenging vascular pathology. It can be treated by experienced team. And this is crucial step in case of acute stroke, of course, when we have tandem lesions. And you have to keep in mind the collaterals from the external carotid artery. Thank you for your attention.
Thank you very much for your presentation. And I think there are really critical lesions. Yes, I've seen. And is there any question?
What is your, Professor Matthias, what is your approach in type 3 aortic arch for carotid stenting?
Yes, I can tell you, it depends. Yes, you have several techniques, but normally I like to work with the Wittek catheter. Julie Wittek was a neuroradiologist from the United States, originally born in Czechoslovakia. And he had one that is different from the SIM catheter, because I can do the curvature already in the aorta before I reach the aortic arch. So I have already the, and then I go on, and then I see, oh, subclavian, room, left carotid, room, brachiocephalic. And then you go in with your guide wire. Then you can bring up the catheter. And when you have a very long catheter, then you can use also a coaxial system. So the catheter is within a sheath. And when you have the catheter in position, then you can also bring up the sheath. So you have the wire, the catheter, and the sheath. In one.
Yeah.
Your approach for this type of aortic 3 or aortic arches. I see that you're both a little bit fence for femoral approach, but it is very easy to do with the right radio, and it works in 5 minutes, and you don't have any...
Not always, yes, but that is a good option, yes. With some anatomical situations also, the radial access is very helpful and safe and fast, because you have not then to push and pull in the aortic arch. Therefore, I mentioned that I go in and blop, 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 and then, so not pushing and talking in the aortic arch, because that is also diseased. And then you have showers, not only in the treated artery, but everywhere. I have seen that by some guys, yes. So don't do that. Be careful with excess.
Manner of work. Somebody reports.
Okay, so.
Next is you.
Yes.
So tips and tricks to overcome difficult anatomy.
Yeah, that is naturally for half a day, but I will make it a little bit shorter. And yes, first you have to be familiar with the anatomy, yes, and diagnostic work up and on, and I start with the anatomic variations, you know that. We learn that sometimes already as students. The normal situation, you know, but here, oh, what is that? The left carotid is coming from the innominate artery, not from the aortic arch, yes. Bovine type, yeah. Then you have these elongations. You see that is not a Wittek catheter, that's a SIM. Yes. And naturally you can discuss here if it not better to come by a radial access? I would recommend here a radial access, because then you have not to go into the aortic arch. Yes, then you might have a right descending aorta. Yes, here an example. Yes, so everything is on the other side. Then you have, yes, an isolated right subclavian. Why is it necessary to be familiar with all these variations? Because I have seen, even in a live case once, they went into the left vertebral artery to treat a carotid artery stenosis because the left vertebra was not coming from the subclavian, but directly from the aortic arch. So you have to be familiar with that. You see here such an example. This vertebral artery is coming directly from the aortic arch, and both the left column and the vertebral artery have stenotic lesions at the origin. And then, yes, separate origin of the right subclavian and right. Also that can happen, so it's not a brachycephalic trunk, and the left is occluded. Yes. Then you have the arteria lusoria. Also that you should keep in mind. Yes. So here you have a list of what we can encounter all the time when we approach via the aortic arch to the carotid artery. Type 1, we have already seen that, so I can be faster. But type 1 can also be with elongation of the supraortic arteries. Yes, for me, that is one of the reasons why we need carotid surgery still. There are two indications where I think surgery is preferred. One is you have dense, stone-like circular calcifications, because distension of the vessel wall is not possible with a balloon and stent. So it's much better than to operate, and the surgeon will find some sites where he can clamp the artery to treat that surgically. And the other is when it's very much elongated with kinks and loops, the surgeon can shorten the artery. Yes, and that cannot be done by endovascular techniques. Type 2 aortic arch, type 3 aortic arch, you have seen all these images already, so it's not easy then to go up to the carotid lesions. Carotid artery itself, you know that most cases, yes, it's at the level of C3 to 5, but that is also a reason why endovascular treatment sometimes is better than surgery when it's higher up or down. That is not the normal access to the bifurcation. And then endovascular treatment, it doesn't matter if it's one vertebral column higher or not. Yeah, then you have also here some anomalies in the carotid artery. So as you see, there is a tricamina primitiva, or you have a hypoglossal artery coming there out. Catheters, I already mentioned the Wittig catheter. You can also work with others, depends on the anatomy and your personal experience. Yes, when you work with sheaths and guiding catheters, they must be kink resistant, that's clear. I like the Terumo wire, normal and stiff, yes, but also sometimes an amplet stiff is very helpful. And you need also to have 014 wires. I will show you cases. So here type 3 aortic arch, yes. So normally you can deal with that, and you see successfully it was treated. 3 techniques. We have the anchoring techniques, the telescoping techniques. That was what I mentioned when I have 3 systems, wire, diagnostic catheter, and sheath together. Guiding catheter technique. Anchoring technique naturally needs a patent external carotid artery to bring in the guide wire there and then to advance the sheath or the guide. How do I do that? You see it here. I form it already at the level of the iliac arteries, so I have not to work in the aortic arch or go to the heart and get the shape of the catheter there. So I have it already here, then I push it up until I'm in the aortic arch. Yes, then you pull a little bit, gently, naturally, to get it in, and then it's not so difficult to do the procedure as you see here, yes, with a tight stenosis, a little bit eccentric. Here you see how I do that. And then I remove the stenosis in the usual way. Then here another left. Yes, when you have this situation, you need a different access. There was one vascular surgeon in Marseille, yes, who did direct puncture of the common carotid artery. So he had not to handle with many catheters, only go up, place a stent, and so on. Bergeron. Yeah. But you can use the brachial, the axillary, and the radial artery, yes, so normally a radial. And you see here how it is done. Yes, then you have this elongation. I already mentioned that, and that might be a problem, how to go around the curves. Often it's not possible to bring a sheath or a guiding catheter around the curve. But as you see, you can do that. Yes, we could remove the stenosis also that way. There are several tricks how to do that. Then, what is also not very helpful when the artery is elongated, sometimes the internal carotid has a reversed way, so it goes first down and then up. Yeah? So you have here, again, a problem how to go into. Yes, you know that, so some cases, here you see again, this is this tight stenosis with this elongated common carotid artery, and we succeeded, but the sheath stayed below this tight curve. Yes, so another case, here you have the problem of the internal carotid artery. As I mentioned already, sometimes it's better to get that with surgery treated, but we could do that. Yes. And you see here, we went through all these curves, and at the end, we could remove the stenosis. Yeah, then we have the cases where we have recurrent disease after carotid endarterectomy, also a case. I think that is perhaps a clamping damage to the vessel wall, because it is at the end of the endarterectomy segment. And you see, it's not a problem then to remove them. Yes, tandem stenosis is also a problem. Symptomatic patient has here a tight stenosis. We removed it and look up here. Oh, close to the skull base, another stenosis. Yeah, what to do with that? Naturally, we treated that too and removed both stenosis in one session. The same is when you have stenosis at the origin, at the aortic arch, osteostenosis, and a bifurcation stenosis. That was a difficult case because it was somebody with cancer, radiotherapy, and a diffusely diseased artery. Yes, you see here stenotic lesions at the origin, higher up in the neck. But we could go in and remove all these stenotic lesions. So you see the end result on the right side. Another case, yes, one artery occluded, stenosis, vertebral artery. But you see, yes, the left is functioning very well, the right is occluded, so there is blood flow coming to both hemispheres from one carotid artery. And there was not only a bifurcational lesion, but a distal carotid artery stenosis, which could also be removed. Yes, sometimes you will encounter also other pathology. You just heard this afternoon about that. Here we removed the stenosis of the carotid artery, and then we saw, oh, there is also an aneurysm there. So we treated it also in the same session. The aneurysm occluded it with coiling, and so could. So don't forget, with your first 100 patients, you are a beginner. Expert starts with more than 500 cases. I've done more than 5,000, and you can still learn all the time. And how to train your skills is shown with my last picture.
So thank you so much for this beautiful presentation. I have just 2 questions regarding the tandem lesions. When you have a distal stenosis, what kind of stent you prefer to stent the distal?
Yes, it depends on what you have on your shelf. So when I started that in the 70s and 80s already, so you see I must be older than 30, then we did only ballooning, but not overdilating and not very rapid, but with, you can wait a minute, and the results were not bad because it's normally not calcified and so on. And now, yes, you have quite a selection of stents which are first flexible. Yes.
I mean, you use the regular coronary stents.
Yes, you have also, you can use coronary stents, but there are also other stents for the neuro intervention.
Yes, just flow diverter and so on. Okay.
Yeah.
And for this very kinked carotid artery, do you have some preferred stent, like, for
yes,
example?
Yes, it must be flexible. Yes, we have now this hybrid stent, and the road saver is very flexible and will pass through these curves too.
Okay. Professor Wondero, maybe you can join to us.
Oh, yes.
Може ли да пуснем микрофона, който е подвижния?
Включен ли?
Да.
Okay.
Do you use cerebral protection routinely?
Yes.
Or
yes.
And which?
In all cases.
Which device do you prefer?
That
Filter,
depends,
proximal?
Yes. When I have a good anatomical situation and can place the MoMA device, I work with the MoMA. If not, when it's very, or the external is occluded and so on, then I would prefer a filter device with distal filtering.
And do you use micromesh cover stent or no?
Yes.
But road saver is exactly
the hybrid stents. This is more or less micro. Yes.
Professor,
because there
why
you
don't
have.
you join to us and take a headset? Може ли само да някой да асистира професор Вондеро да му сложите микрофон?
So I think we must continue in the program, otherwise we are running out of time.
Okay, thank you so much. So I would like to invite Professor Stankov, Zoran. It's me. Okay.
So,
this is a sponsored lecture from Amgen. Okay. We have a connection from the cath lab, from City Clinic, just for the live case.
След него.
Имаме ли връзка с Катлан?
Имаме връзка, да.
Здравей, Иво. Добри съм.
Здравей, добри. Да. Очакваме твоята презентация за Amgen.
Да. Добре, значи сега съм аз, понеже...
Аз исках да те помоля, ако е възможно, ние да си представим случай, защото пациента е вече е на масата.
Давайте, вие сте по...
Да не го караме. Ако искаш, давай ти и след твоята презентация ние ще сме готови да представим случая.
Окей, аз ще гледам да съм
Let's
бърз.
go.
Okay, so can I see my slides? Just this is a little bit common, but topic regarding the use of Repata for the reduction of the LDL cholesterol. At the moment, we have a big problem with the patients with acute coronary syndrome because we have guidelines which say that we should go very low with our algorithm for the
bad LDL cholesterol reduction, and practically all are hospitalized patients for acute coronary syndromes even with any coronary syndromes and proved coronary artery disease or peripheral artery disease or carotid artery disease. They are indicated for intensive, very intensive LDL reduction therapy, which according to the guidelines up to the 1 month ago should be stepwise, with the first high intensity statin, 4 to 6 weeks waiting time for observing the effect, and then if not working high intensity statin, you should go with ezetimibe. Additional 4 to 6 weeks waiting time, and then inclusion of PCSK9 inhibitor. That is our goals with the 50% reduction of the LDL and pursuing LDL absolute value less than 1.4 millimoles per liter. And if after this 8 to 12 weeks, if the target values of LDL are not achieved, you can include PCSK9 inhibitor. Fortunately, in the new guideline, which was accepted during the ESC conference, now you could start ezetimibe and high-dose statin even in the hospital and in the very, very high-risk population with repeat acute coronary syndrome in the 2-year follow-up. Now the current guidelines allow to start PCSK9 inhibitor in hospital. The problem is that even after high-intensity statin therapy and inclusion of the ezetimibe, there is a 1 in 5 risk of repeat incident, and this incident is the risk for this incident is highest during the first year. Then it is around 3.5% per year, but in the first year it's around 5%. So we have to act quick, intensively, and as fast as possible, and earlier as possible. Unfortunately, the target goals are not achieved at the moment, and the most powerful therapy which we have up to now are the PCSK9 inhibitors. The Fourier trial was one of the baseline trials which actually traced the road for PCSK9 approval and acceptance as a mainstay of for the intensive lipid lowering in 21st century. And Fourier clearly demonstrated that the reduction in LDL cholesterol is very quick. You practically achieved, according to Fourier, I will show you the latest trials, that actually you achieve your target goals very quick with the PCSK9 inhibitor. But in Fourier it was achieved during the first 4 weeks, and it was sustained effect. And this effect of reduction of more than 25% additional reduction of the MACE rates, these are even the hardest endpoint as cardiovascular death, MI, and stroke were reduced with 20%. These are not only effect on the cholesterol, these are effects on the mortality, the recurrent MI, and recurrent stroke rate. So the evolocumab actually reduced the rates of the hardest endpoint. And that was at the expense of practically very, very low adverse event rate. And this effect of evolocumab was sustained in all patient groups. the patient with the recent MI, the patient with diabetes mellitus, with the multivessel disease, those with the peripheral artery disease, with the multiple cardiovascular events, and with the MI in the previous 2 years, the relative reduction was around 20 to 25% in all these groups regarding the, as I said, the hardest endpoints. The EVAX study was one of the few which actually examined, this is the pharmacodynamic study, which examined the effect of evolocumab during the first days of acute coronary syndrome event, and it was clearly shown that at the day 4 to 7, actually, after application of evolocumab, in patients with acute coronary syndrome, these are patients with increased troponin, the target value of LDL cholesterol was achieved. Actually, it was a very immediate, very fast and very sustained effect of application of the medicine, and practically during the hospital discharge, actually around 80% of the patient received achieved the target level of LDL cholesterol less than 1.8, and even 65% of the patient achieved less than 1.4, the recommended level of LDL cholesterol for this patient during the hospital stay. And at 1 month, actually, almost 90 to 95% of those patients achieved the target levels of LDL cholesterol. That was at the expense of very, very low frequency of the event rates. And the Huygens trial was one of the few with the Pacman study, which definitely proved the direct relationship between LDL and the plaque, in the acute coronary syndrome. Actually, it was a randomized study, and it clearly demonstrated that even at the 3rd week, actually, it is not shown on the slide, but at week 3, there was a significant increase of the fibrous cap thickness. There was a significant decrease in the lipid content and significant decrease of the plaque volume. And moreover, there was a significant linear relationship with the decrease of the LDL and decrease of the plaque volume, meaning that as much as you decrease the LDL, the much you decrease the lipid content and your plaque volume, and this effect started when the LDL was decreased less than 2 millimole per liter. So the Huygens trial was for me, one of the first and pivotal trial which directly demonstrated that decreasing LDL directly leads to the decrease in the plaque content, plaque volume, and increase of the cap thickness. So, in summary, we have patients with acute coronary syndrome which have to achieve, and now it is allowed according to the newest guidelines, you can start immediately with the most powerful lipid-lowering therapy during the hospital stay. And what is extremely important, that except the giving a statin, giving a high potency and high dose statin, even giving the PCSK9 inhibitor, you should pursue the target values of LDL cholesterol, which are important for patient and for the patient prognosis. Just giving a statin, just giving some medicine does not mean that you are made your job well. You make your job well when you achieve the target values of cholesterol, and especially of the LDL cholesterol. Thank you.
Yeah, thank you very much for this presentation, also that you saved us a little bit of time. Is there any question?
If not, I think we can switch to the
Yes,
cath lab.
then we go to the live case. Can we switch to the cath lab?
Hear me?
Yes.
Hello, guys. Do you hear me?
Yes.
In case you hear me, before starting the case explanation, I would like to...
Professor?
Yes.
Only comment about the
I will,
live case.
I will, yes.
Okay.
Do you hear me?
Yeah.
Excellent.
The patient
So
is...
the topic that Professor Vasiliev has exposed is extremely important for our patients, definitely.
Yeah.
This is the problem of early and aggressive atherosclerosis in patients, in people, not patients, in people with FH, familial hypercholesterolemia. In fact, this is like a model of atherosclerosis, and we know that the prognosis of such patients is extremely poor. So the average life expectancy is 42 years. So definitely we owe very much to these patients, and thanks to the high technology, biotechnology like monoclonal antibodies and also silencing RNA, and probably in the future other technology, this give chance to these people. We did, by the way, Professor Vasiliev was one of the participants in our local 5-hospital trial. In fact, it was a registry about the incidence of FH, homozygous FH in population of hospitalized patients with acute cardiovascular disease, peripheral, cerebrovascular, and coronary. And the incidence of Dutch criteria coverage for FH among this population, it was 6.59. It's very close to what we have known from the trials. In the registries, this incidence was 6.3. So we can expect in this population part at least 6% of this population to have FH, and we have to pay special attention to them. Dobry has mentioned already the combined therapy, statin plus ezetimibe, and as a second step to add monoclonal antibody like evolocumab. We have in Bulgaria, we are lucky because these patients, in fact, the patients are lucky because since several years, after expert opinion of the local expert commissions, this medication, especially evolocumab, is reimbursed for these patients that are covered in the Dutch criteria for FH. And we see more than 2 years now in this population, in this cohort of patients, definitely the reduction of LDL level is really dramatic. We have participated previously in a trial, FH compared to placebo on top of statin. And even since the trial, despite it was a randomized blind trial, we knew very well who is on medication and who is on placebo, because after the first several injections, the result of LDL was the change was so dramatic that it was more than clear which patient is in which cohort by chance. So definitely we have to support the technology and the industry, the biotechnology in this direction, because the prognosis of this patient is very poor. And our trial was very, very important, not only about the FH. It was very important to show us what small, but really very small proportion of the patients with initial hospitalization received high-intensive statin therapy, and the proportion of patients reaching the goals, reaching the target in the guideline. Almost 70% of the patients don't reach the guideline even after dehospitalization. It means that even the hospitalization period was not enough to convince the treatment team, in order to change so much the therapy that can lead to change of the bad prognosis of these patients. And it's like a huge conclusion about this very risky cohort of patients. This was my comment to Dobri's presentation. And hopefully we are going to have a little more liberal commission, the local commission activation, in order to have more and more patients that fulfill the criteria of FH to receive the proper therapy. And we are expecting since the next year also the silencing RNA technology also to be on site. And yes, Dr. Janevska, thank you very much. Thank you for your attention about my comment to the Repata, Evolocumab. And I would like to ask now Dr. Janevska to show us and to show you the patient that we are going to do live now.
Yes, thank you. The patient is male. 68 years old, presented with loss of vision of the left eye 2 months ago, with dizziness, weakness, and headache. Risk factors for atherosclerosis are diabetes type 2, dyslipidemia, arterial hypertension, and smoker. From color Doppler ultrasound, the result is subtotal stenosis of left internal carotid artery and 60% stenosis of right internal carotid artery. From transcranial Doppler ultrasound, have reduced blood flow of the left middle cerebral artery, and from perfusion MRI, residual penumbra. This is the color Doppler ultrasound. And now let's start the live case and comment and discussion about therapeutic strategy.
Okay, thank you very much, Dr. Janevska. Hopefully, I don't know, Dr. Janevska, please tell me, do you have by chance the MRI perfusion of the patient on site?
No.
This patient is part of our STRING program. It's a local investigation of role of endovascular intervention for patients with near occlusion or even string sign carotid stenosis, subtotal occlusion. So there are different definitions, but it's these are the patients with almost full occlusion of the symptomatic carotid stenosis. And in our trial, we are going to investigate MRI perfusion before and after, also DPR, FFR, arrest without the
vasodilator.
Without vasodilator, thank you. Also we are going to check neuropsychological test before and after. And this patient is, in fact, has two indications at least to be checked. First of all, amaurosis fugax. We know that amaurosis fugax is one of the most important predictor of major stroke. And second, his symptoms, including some cognitive decline during the last several months, that he noticed is probably the second reason to check. In fact, I'm here with Dr. Stoikova, Lydia, the technician, Dani, our nurse, and also Kate. Kate is with us. Thank you for my team. I will resume. In fact, in this population, we are doing both a transcranial Doppler to see asymmetry of the flow, and also MRI perfusion. And okay, we can, in case the audience or the panel, you have some comments. Could you please show the angio?
Ivo, yes.
Yes.
Can we see the angio finally?
Yes,
Just,
exactly.
and to see how the cerebral perfusion on angio.
Yeah, I will show you step by step what we have found. In fact, we have found very interesting things. I will show you. We have chosen a bi-purpose femoral approach in order to have easy access to all four vessels, two vertebral and two carotid arteries. Otherwise, we also have quite a good experience with radio. About 60% of all the carotid interventions we are performing by radio. As part of our protocol, we are checking the coronary arteries, and in this situation, you probably see there is a very interesting collateral finding, and this collateral finding is the right coronary artery, in fact, arising from the circumflex artery, and it's the so-called unique one and only coronary artery. We have a publication about that. It's a very rare condition, and this is one more case to our cohort of patients that we have described. Okay, but it's like to have some fun. And okay, we are starting with the investigation of the carotids. You see the target carotid artery. This is very well seen the external, and also you see some contrast entering the internal. You see, very slow. Dr. Polomsky will have a presentation, special presentation about our string trial and also about the definitions. Let's take a look what we have here. We have a very slow flow without distal filling, and we were asking ourselves to do or not to do, and because of that we did several projections. Okay, I will show you in a moment the most important. It's also seen here some feeling, but on the late phase, you are going to see that we have a second level at full thrombosis. You see, this is the second level, intracranial level of thrombosis. So we have two levels of thrombosis.
Ivo, can we see the right carotid and the contralateral?
Exactly. This will be the next projection. And again, this is another projection that is very, this is entering, this is a right caudal view. Right caudal view is crucial to enter the carotid in order to make the bifurcation of carotid and subclavian artery to be visible. So a right caudal projection is very important to get there. And what we see here, Dr. Janevska mentioned 50 to 60% of stenosis of the right carotid artery. It could be a target. It could be a target in case there is significant stenosis. And this is the angio. The angio, I would say it's with excellent contralateral filling through the communicant, anterior communicant artery. It's almost TC3 flow also on the left side. And I will mention once again that this was a gentleman that had amaurosis fugax that lasted about several hours. And he doesn't have any deficit, any neurological deficit. And I asked absolutely by purpose, Dr. Janevska, do we have there in fact the picture of the perfusion? And because I know the picture.
That there is a amaurosis fugax.
Yes, exactly. He had a relatively long time ago. Кога загуби зрението за малко? Not so long time ago, August, in August. Okay, Professor Matthias, what would be your comment?
Yes, I would remove the right-sided lesion because there is also ulceration of the plaque.
Yes.
And then, yes, you have to decide if you do it in the same session or separately on the left side, also there, but there I would then use a balloon-tipped guide or sheath so you can block the blood flow and can then work on the carotid artery on the left side, remove the thrombus and so on.
Okay. Okay, we are going to proceed to the right carotid, to the RICA, like you mentioned and you advised. And
so what is your plan now?
Our plan is to measure the pressure gradient here on the 60% stenosis. So I crossed already by the 0.14 wire the stenosis, and we are going to check.
From Doppler exam that the peak velocity was around 2 meters per second.
Yes, exactly.
It was around Dr. 200. They saw that it's around 2 meters per second, which means probably that this, but it was for the left or for the right? Right.
It was for the right.
So that means that practically this lesion, there is a very high chance to be significant, actually.
Absolutely, yeah, we are going to check now.
If we take an ultrasound criteria for significance, I mean. Exactly.
Yeah.
So, Ivo, which system for pressure
we
measurement?
We are using on-wire assist.
Okay.
On-wire and
so here is very important to take a good
Did we take zeroing?
Yes.
Zeroing, yeah. We are going to zero both aortic and okay. Flash.
Just be careful with the flashing into the cerebral artery.
Yeah, you're absolutely right. This is crucial.
The heart is much more durable for this.
Yeah, it's much more forgiving compared to brain. So, okay, we are ready for zero. Aortic and also zero there.
Can you switch camera to the FFR
yeah, we are going
screen?
to do that. The camera toward the...
Just to see, not
the... move a little bit the injector.
Yeah, remove a little the injector away.
Exactly. Okay.
Did you? Zero aortic? Everything fine? Okay. So I will proceed with the rapid exchange on-wire probe, crossing the lesion.
So this is over-the-wire pressure catheter, just for the audience, because we are very familiar as a cardiologist also, and we use it, but maybe some of the audience are not, maybe it's good to explain, Ivo, what you're exactly doing.
Yeah, we did zeroing for both aortic and catheter to have zero. And now on the tip of the catheter, just outside the tip of the catheter, we are going to equalize. So to be double security that both systems are measuring one and the same level of pressure in order to have a baseline comparison. So now I will cross the lesion, and I like very much making a roadmap. You see the point of the detector of the FFR.
Can you take one more equalization now?
We crossed the lesion. We can do it. We can do it absolutely. You're right, because we put some contrast.
Exactly.
It will change.
Go back and take. Yes.
I did it. Okay. We are going to
microphone.
Flash again. Equalize. Once again, zero. Equalize.
It's a cardiology style, but I wonder if there is a real indication for pressure gradient here, because the left side is practically occluded, and the patient probably occluded, and he had the symptoms of amaurosis. And the right side, even there is no stenosis there, let's say, there is a obvious ulcer, atherosclerotic ulcer, which makes it very vulnerable. So I really don't think there is any indication for any pressure gradient here. There is a certain indication of stenting of this site. I don't know what Klaus thinking.
There will be an increased flow velocity, naturally, because you have to compensate the missing left carotid. And I would treat it immediately because time matters, and I don't like to be with all the devices too long in the body.
Yeah, if there is 50% stenosis, it's going to increase, stenting is going to increase the flow and a full power
the
of
ulcer, and so
you can keep it just.
Okay. We are listening to you, definitely. There is some reduction of the flow, obviously, like the curve is showing us. It's not critical. It's not critical. So your consensus panel and moderator's opinion is just to stent it.
Yes.
What kind of stent would you choose?
Depends on what you have on the shelf. I don't know.
We have open cell, closed cell.
Closed cell.
Okay, this is in fact in concordance with our strategy. So we are going to put a long sheet and we are going to stent it. That is definitely a straightforward procedure.
Just to be clear for the audience, there is no clear criteria for this hemodynamic measurement at the moment. We don't know. Just according to the guidelines, the patient is symptomatic during the last 6 months. There is more than 50% stenosis, so there is indication for the contralateral occlusion. The patient is symptomatic. So according to the recent guidelines, this patient is absolutely indicated for the treatment. Just to be clear, because we have here fellows, we have some other specialties, colleagues, but I think that this exam gives some additional information for us. For me, this is for the first time I see measurement of the non-hyperemic index in the carotid. So
we did we did impressive cases. Exactly around the string trial, with the DPR, we have shown such values like 0.65, 0.63, really impressive result. But for the audience, for the young colleagues, and like Professor Matthias mentioned, there is one more reason, because this 60% or 50% stenosis is on a carotid that is responsible for 2 territories. In fact, it's even more important to be fixed. And we have both Doppler and also angiographic confirmation, and I totally agree with you. And what we are going to do now exactly. So
yes, you don't need any pre-dilatation, because that is not such a tight stenosis, so you can do primary stenting.
Absolutely. This is our usual practice, to make direct stenting and just to make the post-dilation. In most of the cases in male population, we are using 5 millimeter non-compliant balloon, let's say coronary balloon, but it's a balloon. It's a 5 millimeter non-compliant balloon. This is our usual practice. And of course, after putting distal protection.
What kind of distal protection you use, Ivo?
We are using usually the spider.
This is spider 5 or 6?
5.
5, okay.
Okay, go with the spider.
What do you think, Professor Matthias, regarding the direct stenting with road saver without distal protection and without post-dilation?
Post-dilation, that depends on how it looks like later when the stent is placed.
In fact, I would use, I would use NeuroGuard. But unfortunately, the NeuroGuard is not reimbursed in Bulgaria. For the people, they don't know what is NeuroGuard. It's a Contigo 3-in-1 system that is combining distal filter, stent mounted on a balloon, and the stent itself. And for me, this NeuroGuard technology is very, very useful for such a anatomy, because it's not critical, and it's in fact sparing several steps. With one simple crossing on wire, we have everything on site, and we can finish in 2 minutes. We participated in performance 1 and 2, and definitely it was a very, very interesting trial. Okay, the filter is on place, you see. It's good to maintain the filter.
This is a spider or?
This is the spider.
Spider.
Yes, because
this is the. It's nice to keep the spider on site without moving very much. And now we are going to proceed with direct stenting. We are going to use a closed cell exact stent, probably a short one. Short one, yes, excellent. Give it to me. It's a 9 millimeter by 7 separate conical. And we are going to stent this lesion.
Which stent you use?
Exact.
Okay.
Exact. In fact, it's one of the most utilized stents all over the world with huge experience.
Has good radial force also.
Absolutely very good radial force, really close cell design. And there are no very much data, but I like tapered stents because there is a quite big step down from the common to the internal. And I prefer to follow the anatomy. So, yes, go.
Have you experienced any difference between the standard closed cell stent designs like Exact and the dual layer micromeshed stent designs like Seagard or Roadsaver maybe? And especially in these kinds of ulcerated plaque, is the prolapse of the plaque bigger?
Very good idea, absolutely. We have experience with the Seagard, and we have participated in a trial checking the Seagard behavior with IVUS. And there was a difference regarding the protrusion of the plaque. And together with Piotr Musialek, we are preparing this data for publication. So to use a Seagard is a very good idea. Unfortunately, it's not reimbursed in Bulgaria, and we had several on site, but not anymore. So the answer is yes.
Yes, the stent has deployed very nicely, so there is nearly no residual stenosis. Now you can discuss if you do some ballooning later on, some angioplasty, or if you say no, only a control angiogram, and then we finish.
Yeah, it's also possible. It's also possible, but we are in fact following some kind of protocol, and because the patient is already pre-treated with atropine, go.
Yeah. So this is 5-hole balloon?
It's a non-compliant 5-hole balloon. I mentioned that for male population, 5 and very rare, probably 6 millimeter balloon we need, but in most of the cases 5 millimeter is completely enough. And what Professor Matthias mentioned is probably extremely true, because even with the inflation, there was a reaction.
Yeah,
there was a reaction.
The carotid body was now stimulated. Yes.
Yeah, the carotid body. Yeah. Yeah.
So
obviously,
the blood pressure can go down a little bit.
Yes, exactly. So there was some residual stenosis. It was not zero, and we touched already we did our stent apposition with this very short, several seconds balloon inflation, and the stents were a little more parallel. We have to admit. So we are already with the retrieval device. It crossed very easy. In case of a problem of crossing, we ask the patient to turn the head on the other side or to swallow. There are several tips and tricks, but in this case, it was not tortuous anatomy. It was very, very easy to cross. Молете, не мърдай, не дишай и не преглъщай. We are checking now the result. Quite good. There is some flow outside of the stent in the bulb, but it's not a target. The reference diameter is not the bulb, but the distal part. Okay, служи главата права. We are going to check now intracranial. And it will be interesting for me to see if there is a improvement of the contralateral. Okay, ready? Моля те, не мърдай главата и не дишай за малко. Yeah, it's difficult to say, but it's nice. It's nice. Okay, we are ready.
The best is the biggest enemy of the better.
Absolutely, yeah. And now will come the question. By interventional point of view, probably we can open the left carotid, but I mentioned already that the patient had amaurosis fugax, amaurosis fugax without any neurological deficit. What would be your opinion, your advice, to intervene on a second step or not to intervene? And
I would ask the patient to come back in 4 weeks, control it with ultrasound and so on, do a CT, and then you can decide if you want to open up the left carotid, yes or no.
Exactly. This is our idea, to make in one mount CT perfusion or MRI perfusion, and to check if there's some asymmetry, some lack of perfusion. And in case there is no any lack of perfusion, we probably will leave the left carotid like it is.
I think that was an excellent result, and you should be congratulated.
Thank you so much. We finished. We are going to put the angio seal on site, and we are done.
Okay,
thank you.
We will continue with the program. So I would like to invite Professor Gheoreschi, Alexander, just to give his talk about the one-year outcomes of double-layer micromesh.
Thank you for the nice introduction. I will present you the data of 1 year outcomes, results of the dual-layer micromesh stents for the treatment of carotid stenosis in one of the so far largest European studies. This talk will come as a continuation of the previous case, which was nice. It was a very fast carotid stenting. They didn't even perform control study with the filter inside. It was very, very fast, even for our practice every day. So, as we all know, peri and early post-procedural cerebral embolization events related to carotid stenting warrants further attention in both symptomatic and asymptomatic patients. This is why the dual-layer micromesh stents were primarily designed in order to limit this embolization risk and to sustain the cerebral protection during CAS. The Road-Saver study aims to further assess the safety and efficacy of these dual-layer micromesh stents. It was a real-world pan-European study. A few words about this stent's design. It was the second stent of its kind after the C-guard, with an inner layer of micromesh, which is consisted of very, very tiny small pore cell size from 370 up to 700 millimeters. With outer layer, which is designed from nitinol, and with this, it is very well opposed to the arterial wall. Compared to the other standard open cell and closed cell designs, you can appreciate that the Road-Saver stent has tinier pore sizes. Basically, it's a rapid exchange system as all other stent for carotid procedures, and maybe the only one 5 French device, and it requires a minimum of 6 French guiding catheter, 7 French guiding catheter, or a 5 French long sheet. It comes up in different lengths and different diameters from 5 to 10 millimeters. This study included almost 2,000 patients in 13 countries throughout Europe, and I must say that almost half of the patients were symptomatic, but the other half was asymptomatic patient with high-grade stenosis. And the primary endpoint was the major adverse event rate on 30 days and on 1 year follow-up after the carotid stenting procedures. These are all the contributing investigators in the study. Some lesion characteristics, so mainly divided almost equally between the right and the left carotid. Internal carotid artery involving the bifurcation in almost 92% of cases, and the mean length of the lesions were about 18 millimeters. Around 25 ulcerated lesions, 25%, and around 45% concentric lesions. The mean diameter of the stenosis before the procedures, according to the NASTED criteria, was around 80%, and after the stenting it was 0 to 5%, measuring on duplex ultrasound. Mainly it was performed through the femoral axis, as we all know, 70%. In my surprise, almost 27% of the patients were stenting via the radial axis, and in 3.5% there were other types of axes used. Embolic protection device was used only I would say only in 63.8% of the patients, with predominance of the distal filter protection. Predilation only in 26% of the patient, and post-dilation in almost all cases. Regarding the safety, I think the most important part of the study, the major adverse events rate was quite low, so 2.2% of any death or stroke rate, so even not regarded to the carotid stenting in all the patients. And stroke-related death on 30 day, it was 0.5% and 1% at 1 year. Ipsilateral stroke, 1.7% of the patients in 30 day and 2.7% of ipsilateral stroke after 1 year, so quite a safe device. Target lesion revascularization in only 0.5% of patients at 30 days and 2.1% at 1 year. So this speaks also about the long-term patency of this stent device. If we see these graphics of the numbers that were previously mentioned, you can appreciate that any death rate at 1 year was very low, and the stroke-related death or death related to the carotid stenting procedure was around 2.1%. Ipsilateral stroke rate did not differ significantly between 30 days and 1 year, which is inconsistency to the standard of care so far with the carotid endarterectomy, which has a complication rate about 2.5% at 1 year regarding the stroke rate, and the target lesion revascularization of the stented site was very, very low at 1 year. What about the efficacy of the stent? We can see that in-stent restenosis occurred only in 7.9% of patients after 1 year, but a significant stenosis which required further treatment or at least further follow-up from 80 to 99% was only occurred in 1.2% of the patients. And don't forget, we speak about 2,000 patients here, so one of the largest study. In-stent restenosis were based on duplex evaluation only, so measuring of the hemodynamics and the clinically significant stenosis. So to conclude, the Road Saver study confirms the safety and efficacy of this device in carotid stenting, and the dual-layer micromeshed stents in the largest so far pan-European study, with a very low 30-day major adverse event rate in the real-world population, and the very low incidence of stroke rate and ipsilateral stroke. Of course, the TLR rate was also around 8%, which is consistent with other stents for carotid stenting. And thank you very much. Some questions?
Okay, so...
Yeah, the results are very similar to the C-Guard, but the Road Saver, I think, is a little bit more flexible. The C-Guard is somewhat stiffer, so when you have a difficult anatomy, I would prefer the Road Saver.
Yeah, I agree, even though in my country, C-Guard is not registered, so it's not capable for use, but from our experience, we had a few cases with very acute angulation, where I wouldn't say that other stent cannot pass, but the Road Saver tends to act very, very flexible.
It is registered but not reimbursed.
It is reimbursed. It is reimbursed, yes, but in North Macedonia there is not a real difference like in Bulgaria if you use a dual-layer stent or a classical standard one stent, so the procedure is reimbursed in the same manner.
I see.
So for the patient it doesn't matter, but for us it matters.
I see.
Thank you.
Thank you again. Yes, we continue in the program. And I ask now an old friend of me, Jacques Busquet, yes, to give his talk, and he will talk about restenosis. We have that after surgery, and we also have that after endovascular treatment.
Thank you very much for your introduction. Alexander, you did a good presentation, and you were the only one to speak of restenosis of all around the day. So thank you, because I would like to speak of restenosis, and it's not a presentation that I'm going to do. It's a question to you, to Klaus. How can we treat very extreme restenosis in some case? Let's go to the talk. Overall is between 5 and 12. Do you agree, Alexander? Do you agree with this figure? Yeah, but we are in the middle. So you agree with that. So we can have restenosis. Did you find any restenosis in certain stent than other? No, it was just a road saver. Later. The optimal management of severe carotid in-stent stenosis remained unknown, as these people say on this slide. But be careful. If you are leading one day, please take some time to look behind you. No, not you, Alexander, but in general. We used to be a user of CAEA in France, a lot, maybe more, around 20,000, a little less than in Germany, but we know how to do in the training for young surgeons, we know how to deal with that. Klaus, this is you when you were young. Do you remember? Where was that?
Who referred the first patient to me? That was the vascular surgeon at the Freiburg University.
You remember everything. It was in 1977 in Münster, Germany. And then, some years later, you did the first stenting. Do you confirm?
Yes.
Thank you. In France, maybe you remember Jacques Théron. He was making an artisanal system, but he was the first with a striker stent to do what we call now CAS. Clifford Berkeley was a very good friend of us here. He supports the meeting like me with Dr. Dietrich. You have to remember him. He fell from the bed, he broke his neck. He was a very good friend, a gentleman. And he said, please, put a vascular surgeon into the discussion. You have to do that even if you are radio or cardio. The authorized stent, it was from 2 years ago. We know them. You need a very good intervention suite, but I'm very surprised. Everybody of you have fantastic rooms. But it's 2 million. Where do you get all this money? From the hospital? From the government? From the private practice?
From France.
Oh, thank you.
So, Germany.
I have no the figure, but more you do, better you are. I have no the drawing, but more you do, better. You did 5,000.
More.
5,000. We did a little bit less. I have no my slide, but it was a simple carotid angioplasty, and we had a normal stenosis treated by stent, and in fact, we saw like antimalhyperplasia or restenosis. It was a question. But I would like to speak with you of the predictor of restenosis. This is very important before doing in a trial, and you have to ask the patient: are they diabetic? Are they smoker? Heavy? Do they have a neoplasm? Do you let residual stenosis? So, is a small diameter or multiple stent? You have to speak with your patient. Endovascular surgical, it's like our friend Shakespeare. This is a question. Do you do restenting on restenosis? Do you do reballooning? Not you, Alexander, but the people here. Drug-eluting balloon? Maybe, I don't know. Drug-eluting stent or mesh cover stent to save the reintroduction of hyperplasia. Surgical management is in a way not more simple, but more expeditive. You do it, you treat it. I have this case report, interesting. A young patient, smoker, tobacco, cannabis, myeloid leukemia, hypertension, pneumothorax. He was a little bit diseased. We treat this with a gas nitinol luminous stent, but 8 months later, we had a severe restenosis intra the stent. So immediate decision making for me was surgical decision. And if you see on the slide, you see the stent inside, where the stenosis were. We were successful at the beginning, but look, we extract the stent and look what is a real hyperplasia. It's not the 8% little thing. This is something, and please tell me how can a man can have such a problem, and which are the predictors? You have to give answer to that. Look inside, and even outside. So we complete the endarterectomy, and we put up the former plaque, and we put a patch. And we just control 6 months follow-up. This is the team. We're happy with the patient in the middle. So conclusion, do a good streaming with a multidisciplinary approach, concerted decision-making with a surgeon, do a good follow-up with all the examinations that you have in your hospital. If you decide, do it early and control the risk factor. Thank you for attention.
Yes, thank you very much. And I think one of the problems is, yes, do the patient take the medication? Or does, because some of them are not so reliable, so they forgot it, and that is important, at least as long as we need to recover the stent with an endothelial layer. When that's not there, then there might be. Yes, certainly. I also have seen that. I treated them with endovascular techniques because it's possible. Today it's even better because we have now atherectomy devices where you can go in. Naturally, you have to block the blood flow not to lose particles going to the brain circulation, but then you can cut out the material. Yes.
And what is in your opinion the most predictive predictor? What is the greater predictor to have such restenosis intra?
Yes, we have two types. One is thrombosis, and the other, that was not thrombosis alone, but that was tissue growth. Yeah. So the question is, why is there these hyperplastic tissue developing there?
Previous radiation is a very strong factor. The radiation of the neck. Yeah. I mean, when the patient had a radiation before stenting, because it has a long-term effect. It don't matter, you know. I've seen a bunch of cases, probably you see much more that, you know, they have like 15 years ago radiation. We put a stent, but they restenose very quickly.
I will add that to my slide.
What type of atherectomy devices you use in the restenosis?
Cannot answer it now. I'm too tired.
Okay.
Yes, but we have that on the so.
Okay.
Because you also use these devices also in peripheral arteries. Yes.
So maybe in continuation of this, I would like to ask Professor Nikas. Did we have his presentation?
No, so he is not here. So it saves some
No,
time.
no, it's
Okay, so maybe we have him online.
Hello, can you hear me?
Yes.
Oh, yes, here it is.
Hello.
Yes.
Hello. Good evening to everyone. Good evening from the sunny, beautiful Athens here in Greece. It's a pity. I'm really sorry that I couldn't be able to be with you today. I have already arranged commitments here in Greece because we had our national meeting on stroke and our meeting of the national group of cardiology. So I have to be here in Athens. As you can see, I'm not in my home or even in my hospital. I'm in a hotel in Athens, and I'm enjoying the beautiful sea view from here. So I'm following the session all these hours from the internet. Unfortunately, it's an amazing session. I saw the live case previously that Ivo did, and I'm really happy to see how evolving are the latest techniques and the latest, I would say even the late thinking on how to marriage together the cardiology with carotid interventions. I'm really happy about this. So my topic today is to address the new trends on how to reduce the microembolization in carotid stenting. These are my conflict of interest. Please let me know if you can see my slides moving well or if you can hear me well. Professor Matthias, can you hear me well?
Yes, yes, but go on because you
Perfect.
have already spent the first 3 minutes.
Wow. Okay, you are really a good timer. So this is a small outline of my presentation. What is the microembolization is all about? Are there any consequences of my microembolization? And do we have any measures to prevent it? So the microembolization has always been the holy grail for carotid stenting. As we know, the major complication in carotid stenting is getting lower and lower, and therefore we need to find and reduce even though the rate of microembolization. So what is microembolization? There are indeed microembolizations. There are not macroembolizations which may create stroke. Most of them are symptomatic, and most of them occur during or even after the carotid stenting. And it's a problem. It's an old problem. Here is an old study which evaluated 53 patients treated with carotid stenting, in which we found out that 40% of our patients had positive DWI imaging and as regards the microembolization. And most importantly, only half of those patients has those embolization in the distal territory of the brain. This is something important. So another study identified that carotid stenting has a much higher rate of post-operative microembolization comparing to the carotid endarterectomy, and also identified that a couple of anatomic lesion characteristics like the lesion classification or the lesion length have been the most important to identify those patients at risk for microembolization. But this is something we need to take care of. This is something we need to look after, because half of those, or even more of those microembolization are air embolization. So, and it's not has to do with the lesion or even the anatomy of the patient, but mostly about our techniques and how we use our catheters and how we're addressing those patients. But unfortunately, even those air embolization or even the solid embolization during or after the procedures are both of them harmful to our patients. Instead of, except from the microembolization occurring during the procedure, we have also late microembolization, embolization, which happens even long after the procedure, even 24, 48 hours, or even after a month from the procedure. And this study tried to evaluate any risk factor to address who are the patients who are at high risk for this macroembolization. They didn't find much, except of the complicated aortic arch. It's really important to know that even stent coverage or even stent type didn't play any role on this late microembolization. And the consequences, yes, there are some consequences. They're not so severe as we thought to think, but unfortunately, there are some consequences. This is a nice recent study which evaluated the 119 patients treated both with carotid stenting and carotid endarterectomy. Again, carotid stenting had a much higher rate of microembolization. And here is the score in which we evaluated the correlation of the embolic volume to the conjunctive function of patient. As you can see, the higher number of the embolization and the higher the volume of the microembolization to the brain and those patients have, as a consequence, to decline the conjunctive function of our patient. So the problem, in order to sum up, microembolization really happens, okay? It's mostly silent, asymptomatic. It may happen during, after, or even long after the procedure, and obviously affects the conjunctive function of the patient, but not always or not so severe as we thought. So do we have any measures to prevent this microembolization to our patients? Yes, I suppose we have some measures to prevent it during or after the procedure with our stents and our embolic protection devices, especially the proximal ones. And later, after embolization, we think that we might change this kind of rate of microembolization using specific drugs or when we select the right patient. So as regards the embolic protection devices, there are several studies like this one, but I think this is one of the best. 53 patients were treated with carotid stenosis with a lipid-rich plaque. So they had a high rate of, the high probability of microembolization. And as you can see, those patients both evaluated with TCT, transcranial Doppler, and DW-MRI. And as you can see here, during the procedure, the patients who treated with a proximal protection device, MOMA device, had significantly low rates of microembolization. And at the end, even after the procedure, again, the magnetic resonance imaging showed that the patients treated with the MOMA device had significantly low lesions, and as regard both the number and the volume of those lesions in the brain. And there are several studies. This is a recent meta-analysis which included 8 studies and demonstrated nicely that proximal protection devices are much better in preventing microembolization comparing to the distal embolic devices. As regards our stents, that has been an epic battle, I believe 10 years ago now, in which stent is better in terms of preventing microembolization in our patients. The data are only a few. This is one of the few studies which looked at this problem. 40 patients randomized to be treated with Icolin or exact stent. All patients had the same lesions as regards morphology. And as you can see here, the stent design didn't play any role in terms of preventing microembolization as this measured with DW-MRI in the brain. This is another interesting study which was actually treat 100 patients with different strategies using filter devices, proximal protection devices, and closed stents, comparing to the double-layer mesh stents. And as you can see here in this, in the results of the study, the patients that we were treated with proximal protection devices and with the double-layer mesh stents were those patients who had the best outcome as regards the number of microembolization signals in transcranial Doppler. As regards the antiplatelets, the therapy, we don't have any data. As you can see here, I extrapolated a couple of data from previous studies. In this small study, then the use of antiplatelet therapy in the long term didn't play any role in preventing microembolization, especially the big ones or the small ones in our patients. And as regards the patient selection, I do believe that patient selection regards one of the most important thing that a doctor has to do when he needs to speak to a patient and bring to a patient to the table to treat a carotid study. As you can see, and you probably remember, there are specific stenosis characteristics like the lesion length, which may create a high rate of microembolization in our patients. This is a new study which also proved that both the age of a patient or even the anatomy, or even if the patient is seated in the right side of the carotid, these are factors to increase the rate of microembolization in our patient. And something really important, if the patient has hemodynamic stability, this increases the microembolization even in the long term. So if we have a patient that has difficult anatomy, has a right carotid stenosis, have a really long lesion, and we anticipate the hemodynamic stability, these are the patients which probably need to be a better treatment during the procedure or even after the procedure or even before the procedure, given a high dose of statin in order to prevent the microembolization. So in conclusion, I would say that indeed microembolization commonly occurs during, after, and long term after the carotid stenting. It appears that affects patients' quality of life and neuroconjugative function, but not so severely as we thought. And modern stents and protection devices can reduce the rate and the size of microembolization. But I do believe that the most important of all is to select the right technique with the right equipment, as Ivo showed us previously, to the right patient at the right time. Thank you very much.
Yeah, thank you very much for your presentation. You perhaps hear the hand clapping. And yes, are there questions?
I think there is another way to reduce it, and we standardly aspirate the stent surface with aspiration systems after angioplasty, and we about 10%, 15% of the time you see some pieces of the cheese actually in the syringe. So this is also very important to, I believe, this is our standard procedures. As in the last 2,000 carotid stenting we did, actually we do pronto aspiration, the surface of the stent, and there is nothing to lose. While your filter up there, you just aspirate and then collect your filter.
Yes.
A question for you, Klaus, and our friend behind. Do you think there is the same type of problem, especially cognitive problem, after carotid endarterectomy, classical surgery?
I cannot answer what is going on with surgery, but with the endovascular treatment, when I was a student, I learned that when brain cells are dead, they cannot be replaced. Today we know that's not true. We can produce new brain cells, we do that permanently, but you have to integrate that in the network with all the synapses and so on. When that is not done, the new brain cell will die. And so, therefore, rehabilitation is very important. Normally, these patients are more or less asymptomatic. And it's not easy to interpret these results because you have to look at the experience of the interventionalist, type of lesion. Then is that only happening on the side where the carotid lesion is, or also on the other side? Then you know that he went through the aortic arch up to the aortic valve, perhaps several times, so there is some release of atherosclerotic particles from there. So you have to go very close into the detail. And certainly good cerebral protection, when possible, proximal protection is safer than the filters, because the filter has first to pass the lesion that is unprotected. Then you have to make sure that it is, yes, well opposed to the vessel wall, because when it is in the curve or so and it's not touching the vessel wall everywhere, then the particles can bypass also the filter. So there are several things which you have to keep in mind. Yes, so we go on in the program.
Yes. Thank you.
Thank you
so much.
Best wishes to Greece.
Thank you very much. Have a good day, all of you.
Did Dr. Powomsky is here? Yes. Okay, so please I will be very curious about the string trial.
Yeah, that is surely. I will be back in some seconds.
So, dear colleagues, it's great pleasure for me to present you our work right now. So, about subtotic carotid occlusion, several words. It's there is no universal definition of the disease. Probably the most common thing is severe stenosis, and then distal collapse of internal carotid artery after that. The condition was first described in 1933. According to our literature research, there are 4 more constant criteria in most of the trials. Here, late contrast on the internal carotid artery after the stenosis, then a smaller distal diameter of internal carotid artery compared to contralateral one, presence of intracranial collaterals, and also the distal diameter of ipsilateral internal carotid artery equal or less than external carotid artery. Carotid stenosis are divided, subtotal carotid stenosis are divided on two subgroups. These with full collapse, near occlusion with full collapse, are actually real subtotal carotid stenosis. They have all hemodynamic things that we will discuss later. What we note about the pathophysiology of the disease, what is published till this moment, is actually the fact that each stenosis can progress to the near occlusion. Each near occlusion can progress to complete occlusion, and the histological finding of most of the near occlusion is equal. So the diagnosis is preliminary interventional, the diagnosis is preliminary angiographic, but histological finding in most of the cases is complete occlusion with microchannels or real near occlusion. Collateral blood flow is game-changing for this near occlusion. Of course, circle of Willis and three main things on level of arteria meningea media, on level of ophthalmic artery, and also on the occipital artery level. Please note that in case of near occlusion, real ones, in more than 63% of the patients have angiographically findable collateralization of the left-right hemisphere. What is very important about this stenosis is that they are theoretically related with lower risk of stroke because of the collaterals that we already discussed, and they are also theoretically related with a high risk of hyperperfusion syndrome after opening, or some other complications such as extravasation or neck hematoma. The mechanism of stroke in case of near occlusion is not so easy. It's not. There are probably more than one mechanism, more than just making this near occlusion complete occlusion. There are published series with focus of follow-up of near occlusion that found that most of the patients with ipsilateral stroke didn't have progression of this near occlusion to complete occlusion. Nothing has changed angiographically before and after. So this is why, first of all, the guidelines right now are based on NASCET and ECST, two big clinical trials where only 60 patients with near occlusion with full collapse are included, and the authors report low incidence of ipsilateral stroke, and to be more correct, 15.1% in such clinical trials. So according to that, here is the statement of the guidelines. European one: if there is no recurrent symptomatics, best medical treatment in case of near occlusion. The USA statement, according to American Society of Vascular Surgery, there is no differentiation between near occlusion and any other severe occlusion, but according to American Stroke Association guidelines, the things are similar than European one. Don't treat except of recurrent ipsilateral symptomatic. About stenosis and cognition, now we know that there are big cohort studies, ECOF in Chianti, where it is demonstrated that most of the patients with symptomatic carotid stenosis have some kind of loss of cognition, and also part of the patient with even asymptomatic carotid stenosis have a loss of cognition. It's very difficult to measure cognition because of the fact that cognition is not only related with the structure or the of the brain itself, but it's also related with the perception, attention of the patient. So when we talk about a real evaluation of the cognition, probably it's more correct to compare two tests performed in same in one patient, not to be based only on the value itself. In CREST trials that we expect to end in 2 years, about first 200 enrolled patients, there is evidence that there is cognitive impairment in every carotid stenosis, in both patients with the carotid stenosis symptomatic and non-symptomatic. It's compared to large registry of healthy stroke. Unfortunately, something that cannot be, I cannot, don't find nothing about the reason, there is no impact of the long-term dementia. The mechanism of cognitive dysfunction is microvascular disease, probably, demyelinization and axonal damage of the brain, and probably there are more than these mechanisms. What we know about the CREST trials, more than 700 patients with age above 70, the upper percentage of patients with carotid stenosis have lower than expected cognitive function compared to the healthy one. Here is one more analysis with 140 patients. 5 mental tests are used there before and after standing, and what is game-changing, there is a tendency to for the patient to perform a better result on the same test 6 months after carotid stenting. So probably there is a sense to intervene these lesions. Since 1983, there are several trials that with focus on follow-up of patients with neuro-occlusions that actually told us that things are not so pink as initially described. There is a high chance of progression of or a high chance of ipsilateral symptomatic. Unfortunately, all of these series that are presented here are relatively small. The first bigger meta-analysis is published in 2015, and it actually revealed a statistically significantly higher probability of restroke in patients treated of best medical therapy compared to patients with carotid artery stenting on the left with hazard ratio 1.6, and compared at the same time with the endarterectomy with hazard ratio of 2.2. Also, the authors told that there is a statistically significant value drop in terms of stroke according to the year of the publication. So this means that probably stenting and endarterectomy are better and better. The last thing that is published in 2022 with more than 6,000 patients with neuro-occlusion and carotid stenting, the authors report that stroke or death within 30 days is not different for neuro-occlusion or any other severe carotid stenosis. Our results, a little bit more than 100 patients for a relatively huge period of time with a mean follow-up of 2 and 5 years. The technical success was achieved in 98% of the patients. About early complication, we have 1 ipsilateral stroke, 3 cases of TIA, 2, they are not hyperperfusion. There are 2 patients with intracranial bleeding. One of them is treated conservatively. I'll try to be faster. The other one is treated unfortunately by surgery. And according to the long-term follow-up, there are stroke-related death in 4 patients, which is 4.4 patients. Here is one of our cases, patients which, as you see, MRI perfusion on the right side and CT angio on the left side with occlusion of right internal carotid artery. and limited crossover filling, something that confirms the MRI finding. The right radio axis was used in this situation. The lesion was crossed with coronary Gaia second wire support with bone as microcatheter, and a spider distal protection was implanted, positioned after pre-dilation with 1.2 bone. Exact stent, closed cell stent was implanted, and here is the final result. But what is more important, here is the coarterization after implantation. But what is more important, this is the same patient, CT angio before and after up and down, and MRI perfusion before and after standing. Just few words about the string trial, something that Professor Petrov told. It's something that starts 2 months ago in our institution. Is focused on a recanalization of a patient with string or near occlusion carotid. On the screening, there is Doppler, CT angio, neuro assessment with cognitive tests and MRI perfusion for every patient. Then, during the procedure, if decision was made for the procedure, blood samples for 2 biomarkers are taken. Again, neuro and cognitive assessment after the procedure, and post-procedure MRI. We have probably 15 patients included till this moment. Thank you very much for your attention.
Okay, so questions, comments?
All are
so
satisfied
if not,
with it.
Maybe let's go further. Thank you, Dr. Polonsky. The next one is carotid dissection. It's a very interesting topic.
Yes, so epidemiology. This is a group of patients who are younger than atherosclerotic lesions. You see that most of them are about 40 to 50 years old, but naturally it can be also older. I've never seen one with older than 90 years with a dissection. The incidence is low. Yes, it can happen at different segments of the carotid. It can involve the common carotid, the internal carotid, the intracerebral, also the vertebral artery might have dissections. And naturally, it can also happen bilaterally. The causes, it can be connective tissue disorders, cystic medical necrosis, fibromuscular dysplasia, and so on. Traumatic, yes, it happens with sports, with manipulation, even sneezing and sudden deceleration. Sudden deceleration, I will show one case. Symptoms also are different: headache, horror or facial palsy, cranial nerve injury, upper limb weakness, and so on. Mortality, yes, 5% about that. Recurrence rate, 2%. At 1 year, less than 1%. But an increased risk still, that depends on the pathophysiology underlying this process, yes, in 10 years. Yes, why do the patient develop stroke symptoms? Because there are 2 mechanisms, more or less. The dissection blocks the artery, and so you have no flow to the affected hemisphere, and then you have a stroke. Or on the membrane of the dissection, there is thrombus formation, and the thrombus goes to several arteries. Yes, when you have a stroke, then the prognosis is not good. And they have even a worse prognosis than when you have other stroke mechanisms, due to the size of the affected cerebral area, because that is very acute and there's no collateral circulation, no time to develop a collateral circulation. Yes, how do we use the usual diagnostic tools? You see it here, ultrasound in the neck, the common carotid. You see it also here when you do a CT angio. Yes, you see it on the picture here. And you see an angiogram to that. You see again here a dissection very nicely, going from the common up over the bifurcation to the internal. What for treatment options do we have? We have the conservative treatment options. Yes, in some cases that is sufficient. Antithrombotic therapy, thrombolysis. We also have open surgery, but that is rarely needed. Mostly we do it differently. We use endovascular treatment naturally, therefore I'm standing here. Yes, thrombolytic therapy, naturally that can be used in selected cases, but normally not, especially not when you have a trauma patient and so on. Yes, the female gender is here more often affected than the male gender, as you see. We have there a study with thrombolysis, and you see, yes, there is some risk of hemorrhage naturally in these patients. And surgical procedure, bypass procedure, thromboendarterectomy, ligation of the artery, extracranial bypass procedures. I will show you some examples here. Dissection. Patient was then treated and had a pseudoaneurysm 2 years later. Was operated on, and you see down on the right side the resected aneurysm. Then we have the Eagle syndrome. I don't know if everybody is familiar with that. That is when you have an elongated, as you see it down there, an elongated bony part, which is compressing the artery and causing the dissection. So that must be treated surgically. You have to remove that. Yes, you see some example, Eagle syndrome, styloid process, resection, because that is a too long styloid process, so that must be resected, and then you have solved the problem. Yes, we have certainly a stroke and cranial nerve injury risk with surgery, endovascular treatment. We have stenting of the dissection, coiling of dissecting aneurysms, embolization, occlusion of the vessel, and thrombectomy. Some examples. Here you see covered by a stent, and afterwards no dissection visible anymore. You see it here also. Later on. In this distal part, it's also a problem for surgeons. Yeah, they can ligate the artery and do an extra intracranial bypass, but normally I would say no, there are other techniques today available. Yeah, stenting, when you have persisting symptoms, progressive neurological deficit, recurrent neurological deficit, aneurysm formation, or even bleeding. MRI helps to find a good indication. And you see here another case, 46-year-old male, acute hemiparesis. And you see there the dissection is visible during MRI. It's also visible with the angiography. And you see that we treated that then here with endovascular techniques. And we could remove the dissection with ballooning and stenting. And within half an hour, the symptoms of hemiparesis disappeared. Another spontaneous dissection. Yes, and you see also the sac there in the distal carotid artery again, yes, the dissecting membrane. And after stenting, normal diameter and all as well. That was a very interesting patient. It was a patient who was coming from Italy to me, Italian patient, and he had an asymptomatic carotid artery occlusion on the left. But on the other side, yes, you see, oh, he has also a dissection with formation of two aneurysms. And with these aneurysms, it's not easy to treat them, because when you go in with a guide wire, the guide wire starts to roll in the aneurysm, so it's not easy to find the distal exit out of the aneurysm. But as you see, we succeeded at the end. We placed stents, and we have a follow-up after 5 years, and it's still stable, so his artery is patent, and the problem is solved with the aneurysms and the dissection. Yes, then here, sure, practical, yes, that's also something. Be careful with these very fast movements of the head, because they can result in a dissection of the carotid artery. Stenting, yes, I already talked about that. There are some treatment results when you look into the literature. And yes, at the end, more than 90% of carotid dissections can be successfully treated with endovascular techniques. Thank you very much. So there are no questions, so we can go on the program to save some time.
Okay, this is also an option.
For a short announcement, in fact, please, there is a fantastic gala dinner prepared for everybody. Please don't go home before the dinner. So you'll be invited in after the session in several minutes, so to have the gala dinner, to be together.
But it is in the hotel or outside?
It's in the hotel.
It's in the hotel, so we have not to go somewhere.
I think Professor Klisurski turn now. Am I right?
So we come now to the last contribution. I see our speakers already coming, and he will talk about endovascular treatment of intracranial stenosis. So, Marco, go on. Much success.
Dear colleagues, dear friends, thank you very much to the organizing committee for inviting me for this talk. I will keep your attention for several minutes on this topic of intracranial atherosclerotic disease or stenosis, which is a little bit neglected, I think, topic compared to the extracranial carotid artery. As we know, nearly about 10% of ischemic stroke in the US, in Europe, are contributed to intracranial stenosis, but in some countries as China or a population from Asian origin, these numbers are 30 to 50%, which is amazing. And this is one of the most frequent cause of recurrent stroke, as we know. On the other hand, there is a problem with silent brain infarction and vascular dementia. We rely on woman-based diagnosis of angio, conventional MRI, CT, etc. But there are new methods and devices which will help us in the future to have a better diagnosis. Of course, you can see here the relative risk of recurrence of asymptomatic stenosis, but for symptomatic stenosis, there are greater risk, especially severe one, between 70 and 99%. The risk is 20% over 1 year. And every problem and rule has exceptions, so we should be cautious and have to recognize rare cases of stenosis, as we see sometimes tuberculosis or Lewis or subarachnoid hemorrhage and dissections and other rare causes are very important. As you can see here on these 2 slides, On the right side, there is a pontine stroke with basilar stenosis, but this patient proved to be tertiary syphilis patient with cerebral spinal fluid data for meningitis, even without meningeal clinical symptoms. On the other side, to the right side, this is typical atherosclerotic stenosis with brain infarction, pontine treated in the city clinic. We have to focus on three populations of patients. First one are asymptomatic patients with no prior strokes. Second one are these with acute stroke and hyperacute management. And the patient for secondary prophylaxis, already having TA or stroke. And of course, maybe the most important patients are those with distal perfusion failure or vasoreactivity failure. As you can see on this right side, transcranial Doppler and Sept in patients with extracranial severe stenosis, but the same principle is true for the intracranial stenosis. On panel C, you can see this Sept in normal control, but lower this after doing acetazolamide test, you can see hyperperfusion and also not increasing the blood flow velocity in middle cerebral artery, which is affected, compared to normal side where we have increased velocities. And we have a patient, last patient with, treated with Professor Petrov. We have a lot of patients collaboration, wonderful collaboration for 10 years. And this is a typical patient with diabetes, 8 years old, who had symptoms for 1 month. First of all, he had kind of Jackson motor epileptic phenomenon. And after some time, he had also progressive symptoms. When we saw him, we have already mild hemiparesis and distally impaired arm with facial palsy, which is typical for a neurologist. Strangely enough, before that, he was sent to physiotherapy for his hand weakness because he has no probably these symptoms. But of course, we sent him to MRI, and the result was not so terrible. Mild periventricular lesions, Doppler extracranial was normal, but I would say, in my opinion, in my country, we rarely or not so routinely send patient ambulatory for transcranial Doppler or for CT or MRI angio. Of course, we do MRI and transcranial Doppler, see severe intracranial stenosis, and we send the patient to the Chiboden City Clinic, where Professor Petrov and his team made balloon angioplasty with excellent angiographic results. And of course, we adapted his therapy. He was already on anticoagulant because of his atrial fibrillation and paroxysmal atrial tachycardia. We only added aspirin, 100 milligrams, and atorvastatin 40, which we see is it right in conservative guidelines. And on first week, he has 1 point and no deficit ever since. But on third month, tendency for increased cerebral blood flow on MCA was noted again. So we shall see if the therapy contributed to that. And I cannot resist my temptation to show you the first case with Professor Petrov 10 years ago. It was an amazing case with a lady, 35-year-old, of course, with severe stroke. And at that time, we have a CT only, not spiral CT, but normal. And she was sent for MRI the next day. And because there was problems thinking about MS and something like that, no angio was done. Only we can see the lesions along the all borderline territory of MCA from the frontal to the occipital cortex, which means there is a proximal large artery problem. And you can see this severe TAR stenosis. She was treated twice, once in 1 month and after 2 months, with excellent result for 10 years already. We have no any evidence of recurrence of this stenosis in this lady. By the way, it was not atherosclerotic one. This is timeline for the history of treating of intracranial stenosis, especially with for the last 15 years with pivotal trials. I would only mention medical treatment for the secondary prevention, which is important to have aggressive management of modifiable risk factors, high-intensity statin therapy. There are now new things, as you heard, about inflammatory cascade and antibodies, which we can use now for the coronary arteries, but probably the trials will go on for the intracranial arteries as well. And despite this therapy, as I mentioned, already we have a high risk. Recommendations from the American Academy of Neurology and Cardiology are evidence. We have class A and 2B. Of course, aspirin for the stenosis between aspirin 30-25 milligrams, and for stenosis between 50 and 99%. If we have severe stenosis between 70 and 99, of course we do with a double antiplatelet therapy. Ticagrelor and aspirin is an option, and cilostazol with aspirin and clopidogrel is also an option. Neurologists, we rarely use cilostazol. It is used by vascular surgeons in our country mostly, but there are some studies about vascular dementia in cilostazol, so probably there is a contribution here. Of course, we have surgical treatments with no benefits, or special encephaloduroarterial angiosis for the, or bypass surgery for Moyamoya disease and other things. For endovascular treatment, of course, transluminal angioplasty is a mainstay. But now, more and more, undersized angioplasty balloons and slow balloon inflation technique are probably more better for better results. And I would like to hear from the colleagues their experience here, because I'm a neurologist, I don't do interventions. And I'm finishing a few minutes, 2 or 3 minutes with my presentation. About stenting, there is a lot of debate, several studies, but based on this data, currently guidelines are against stenting as an initial treatment with symptomatic stenosis, especially after clinical CASIS trial published last year. But we are living in Balkans. Probably we think we are part of Europe, so we should keep to the European guidelines. They say the same thing about medical therapy. Of course, risk factors should be managed, but for endovascular treatment, it should be rescue therapy in selected patients with symptomatic high-grade stenosis after probably clinical reoccurrence. And one point, because we are doing probably in my country also more and more, we're trying to do interventions in acute stroke. This is one point when we consider intracranial stenosis in the hyperacute management of stroke. When the patient has no atrial fibrillation, when we have water-shaped infarct or truncal type occlusion or earlier reocclusion. So this is a kind of example of our case done also in the city clinic, wonderful results, typical. And after 3 months, we have detected also intracranial stenosis, which was not detected, or there is also kind of different diagnosis between Doppler and typical conventional angio examination of the stenosis. So in conclusion, treatment of intracranial stenosis, atherosclerosis is evolved, and probably it will be better treated in the future endovascularly. Targeting underlying mechanisms is very important. And listening this morning presentation of Professor Iris, I would say that this kind of brainomics software will be, or rapid software will be especially important for this type of stroke or this type of patients with asymptomatic stenosis to define if they're high risk for neurological deterioration. So, thank you very much for your kind attention.
Yes, thank you very much. Naturally, we have not only atherosclerosis with its risk factors, but also vasculitis might happen. You have shown one case of a 35-year-old woman, so I assume at least that there is some inflammatory process and it's not atherosclerosis. So you have to, when you want to treat them later on effectively, yes, you have to find out the pathomechanisms which are underlying these development of stenosis. Are there any questions? So you have convinced them all.
Yes, I think that we are in severe hypoxia, including brain hypoxia, so we have to conclude the session.
Oh yes, that is a good recommendation. Yes,
that will be the best what we can do at this moment.
So then I thank all the speakers and all the attendants, and we see one another.
As I mentioned, dinner.
At dinner or tomorrow morning.
See you tomorrow. And also tonight.